Good morning, Abby. Are you there? Hello? Can we do a sound and video check? What is it? Greetings, people on the panel. Can you hear me? Taklapoon. Marcus. Ahmad. Can anyone hear me? Oh, yeah. Ugh.
Hey, Dr. Bennett, are you able to hear us?
Hello, can you hear me? Hi, Abby, can you hear me? Hello, hello. Yeah,
Knock, knock. Good morning, everybody. Sorry, I'm the official breaker of all the fun. We got to start working. Great to have all of you here. Thank you for coming and joining us. We have an exciting long day of learning ahead of us. Again, I said it again today. This would not be possible without all the support, starting with Baptist, going through all our sponsors, and I'm not going to name them because I'm going to be unfair. We'll forget something and somebody. Our faculty, AJ, Demetrius, Tudor, Lucy, Ansar, Raul that could not be here, Dr. Valdivelo that's going to be here this afternoon, Matt Gunas. So everybody that made this possible locally or nationally to come here and donate their time and be here with us, sharing their experience. We're going to start with Demetrius Lopez from Chicago, Porto Alegre / Chicago, talking to us about AI in acute stroke setting. Demetrius, please.
Good morning, everyone. So this is, I have to say, probably the second most interesting talk of today for me. I think if we can go back one slide. Yes. So yesterday night, it was clear to me that a lot of people were not really very much aware of the project that we have going on in Chicago now. So just to summarize a little bit of and give you some context to you and how AI is important on building a stroke network. So for almost 20 years, I was in a university setting in downtown Chicago. And there was an opportunity about first 6 years ago. And then I decided the opportunity was to join a local network of hospitals. And about 4 years ago, this network of hospitals now merged with another network of hospitals in Wisconsin. So was called the Advocate Aurora Health System. So at that point, I decided to move from the university setting to this new network. The network is literally exactly the same amount of time that I've been there is when the network merged. So we are still going through the merging process. And I think this talk will show you a little bit of that. But the idea is that how do you, between Wisconsin and Illinois, with Milwaukee and Chicago being involved, 27 hospitals, how do you build this together? How do you put this network together? Next. Oh, I can do that, sorry. And then, so the main issue is that stroke, of course, in a region like this is a disease that has a difficult diagnosis. It's very time sensitive, and there is a lack of system of care coordination. Remember, when we did our trials, Swift Prime, Dawn trial, all these trials, we were actually downtown Chicago receiving all these patients to downtown. Everything was done in one hospital downtown. We got the numbers, we knew what to do. So the standard of care was actually created, and the concept of comprehensive stroke center and the tier care was all in place before we joined this network. So we had a very good idea of what we were looking for. So we just had to coordinate this and look at this around Lake Michigan. As you can see here, all our hospitals are from Green Bay all the way down to the southern part of Chicago. Christ Hospital is about 220 miles of land that has about 27 hospitals between that. And in two major cities, but a lot of countryside too. So you have a mix of hospital sizes. Just to give you an idea here, Lutheran General Hospital, 623 beds. Then you have, Christ Hospital and the Milwaukee St. Luke's Hospital. These are also 600 to 700 beds hospitals. The others are smaller, 200 beds, 400 bed hospitals. And so we had the opportunity was to build this integrated stroke network, we call, and we create first a tier system level of care. So within the system, you do have comprehensive, we have 5 comprehensive stroke centers, and all the other hospitals are primary stroke centers. And so it's a multi-hub and spoke system, basically. And the most important issue is we also created 3 centers of advanced care. And this is like the places where you do most of the AVM and most sophisticated intervention. This is how we separated those different categories. So a little bit different than what DNV and Joint Commission will ask you to do. But the importance of this, especially for acute stroke care, was that we had to have a patient, for example, you can see here, hospitals that are pretty far away, we had to have a communication system between the hospitals. So the most important thing, and this is what the integrated stroke network means, and if we one day can create a designation by Joint Commission or DNV to be certified as an integrated stroke network. What that means is that you prove efficiency, that within your network, if a patient gets to any hospital within your network, the level of care is standardized, that we can make it faster than if you have to do a diversion protocol farther away to a hospital outside of the network, not justifying that. So we can create an entry point any way in the system, and that would prove to be a better workflow than trying to divert patients. So that means you had to build a team. You have to have we had all the AI that was essential for us to build this. So I think this is when we start getting to our talk. But today, you know, we use Rapid, we use Viz AI. We also have a communication platforms independent of Rapid and Viz AI that's called Join. And we had to have a patient command center as well as a telestroke system, and a few more things to come. So this is, we have about 12 to 13 give and take interventionalists on the team. So you had to coordinate the care between all these different operators. And here you have radiologists, you have neurologists, you have neurosurgeons all involved here. We had this patient comment said, this is a standalone, it's a building in Downers Grove, Chicago, that has every hospital in the system, well, their bed availability, the time to the traffic information. We have a partner of ambulance service that is doing the hospital-hospital transfers that is actually in-house. And this is a call center. They receive the calls, they assign, see which hospitals have the bed within the system. Remember, when you're a multi-hub and spoke system, you have 5 comprehensive stroke centers to send the patient to. So you have to see which one has the bed, which one is ready to go and closer to that patient. And if you don't have that, you go to the closest hospital, get the care started, and then you transfer to your comprehensive stroke center if needed. So the telestroke deployment was key. So all those hospitals, remember, doesn't matter if you're in a rural Wisconsin or downtown Chicago, you're getting the same neurology team, seeing the patient and assessing the patient. So telestroke has been a huge part of this and very helpful to integrate the network quickly. I'm not going to talk about Viz and Join and Rapid. I think we've talked about this before here. So these are, I will answer any questions you may have. These are excellent tools, but they are only addressing one issue, which is, yes, you have an algorithm detects a disease. And imagine in a system like this, we have more than 200 CT scanners going on. So you're getting a number of images a day that is incredible in terms of to manage that actually became the biggest issue than just having a tool to control that. So this is an example of how many patients 65 years old or more, and this is that were screened by each month with an LVO. So you know, on average 250 to 400 cases of patients that are 65 years old or these patients then have a reimbursement. So this is finishing now, but it's called the NTAP. So this is a way to pay for your AI in a way. So it's very important to, was very important to keep track of that. This is going away now, unfortunately. Another tool that I thought was very interesting that we started, this is a project with Rapid, and recently Viz also added the aneurysm tool. But what is interesting about this is the ability to not only identify aneurysms, but also then after is to track the aneurysm if it's changing size or growth. So that's kind of the concept that I'm going to be sharing more and more with you, is the ability not only to detect things, but how to organize the data and how to use that for you with the integration with the clinical data too, and potentially research. So here you have the tool, it identifies the aneurysms, gives you the size and the shape, and then these you can also use this for potentially planning of surgery. So you can have an embed on this, and this is how beautiful this gets. You don't need to use only this tool, but you can use SimCure and other simulators with the data you require. As long as you integrate the data, you're going to be able to also plan the surgical treatments. And in this case, you can actually simulate a device specific. And this is a case that you can show different type of flow diverters. And you can, this is actually a case we did at WNC. This is just showing a complex lesion. This is the Siemens rendering, cadaveric rendering. So it looks like this is a real case, but you can transform in a cadaveric idea. So it's not like, it's a very beautiful image of it. But the idea here is that you do a segmentation of the data, and then you can develop your planning of your treatment. And also you can actually basically study the aneurysm in a way that is incredible. This is also used today to go to a Mantis platform. So you can use a digital simulation as well as a 3D print of this. So that integration of data is what we're talking about. We're not talking about getting USBs, connecting, getting the files from one place to the other. This is all integrated within, if you do a scan anywhere in the system, you can get the images and do this post-processing, as well as track the patient over time if it's changing. So this is the different flow diverter sizes and the impact will cause in the aneurysm. And I think, and this is an interesting concept, which is more and more you're going to see the ability to predict how the device is going to land and simulate that. But look at this. So now you have a database of all the cases that are coming through. And then whenever the patient comes back for a follow-up, it identifies that the patient's back. And then you can have a comparison using AI of what is the change on the aneurysm over time. So what else is new? And this is really the cool stuff. As you integrated this, we start talking to DNV. You start getting also some awards of all the hospitals that are involved. And it's pretty busy season when you do a DNV review. Now we're doing a few days, but you do the whole network together. You don't do each hospital at one time. So this is really powerful. What I really want to talk to you today is this, is how you have the AI of the AIs. And so the newest concept is that rapid viz, you can see here, we end up having tons of AIs. You have this stuff looking for cardiac, lungs, and all kinds of AIs in your system. So you need to find a way that you use AI to help the algorithms, independent algorithms of different specialties to then be organized. Because ultimately what you want is that your patient, doesn't matter which AI, so you get a picture modality, any MRI, endoscopy, pictures in the OR, all those files have to come together to that one patient, and then you need to use all the AIs that are available and then coordinate that information. So the only way to do this is by having a system that you actually get each data file that comes in, and you actually, we call pixelization. You basically have to create there's no more, if you go to your CAT scanner today, there will be 5 to 10 different protocols for CT of the head. So your AI you'll be assigning, if you do an audit today, I guarantee to you that you're probably not sending all your images to AI, because there are different protocols and the programming is only for a certain protocol. And so what you need to do is to start eliminating the names that are given by the imaging modality and create a language that AI understands. And doesn't matter what type of, how you register that image, it will be transformed in the data set that the AI links to that patient. So you start eliminating the labeling for each modality that you do. And why this is interesting? Well, ultimately, the integration of this allows you then that when a patient comes in, it recognizes which algorithms you have used in the past, and then you can actually compare the study with the next images that you're doing. We're not quite comparing between different imaging modalities, but certainly within the same imaging modality. And this is not part of rapid or viz, but rapid and viz are part of that, and basically. And so here is more or less how this gets protected. But the idea is that in the end, if you have a patient with a certain disease, you have an aneurysm that is 5 millimeters anterior communicating artery, what this does, it allows you then to, it flags you. In this case, this is an X-ray. So it flags you, yes, there's pathology. No, there's no pathology. So it brings it up to the attention of the team. This imaging has an abnormality. And then it compares to previous images to see if there's a change in this. So the picture on the left lower corner is comparing the previous study to the new study, and also picking up on any type of new abnormalities potentially can have. And then it looks into Epic for clinical information on that patient. So now you have not only an imaging file that is able to be interpreted by this AI, but it gets also the clinical information that tells this is a patient that has these characteristics. So if we have all our institutions doing the same, you can actually say today, like, I wanted to know how a patient with an ACOM aneurysm 5 millimeters will do at 65 years old with diabetes, hypertension. So it's a data set that can be then compared to different institutions, and you can actually see the outcome after coiling or after clipping, and start getting data of how patients with a similar disease, similar clinical picture, different types of treatments, they fare over time. And this is an example of a patient that had a lung cancer with a chemotherapy, and then you can see that over time the lesion grew in size, and that means that this goes in the data set as a lesson of how you, if you treat this patient with this protocol, with exact clinical characteristics and imaging characteristics, you can relate to see how many patients in your data set from multiple institutions have this type of condition. So it's really an interesting concept of how to bring your AI, make your AI smarter even. Okay, this is now shifting gears a little bit. I talked about integrating the network and AI of the AIs. The next level for us too, we're just starting this protocol of doing basically a looking at the workflow today is if you could eliminate contrast to detect large vessel occlusion. So imagine how fast today you move your patients, and you guys have great times. But look at if you have a mothership situation and you could actually decide to go to the angel suite once you eliminate the chance of intracranial hemorrhage, and there is a high probability there is an LVO just by a plain CAT scan, no contrast. So no contrast is given, and then you have a workflow like this. So you go directly from seeing the patient to CAT scan, and the plain CAT scan will call your team to say, this patient has basically a high probability of an LVO. Now, depending on the hospital system, this could be up to an hour. Many places, maybe 15, 20 minutes, 30 minutes, it's time you gain. And if you're going to transfer a patient, that's actually pretty helpful too, because you can go in any hospital in the countryside and you can actually activate your transport between your hospital, your transport system with a CAT scan on. You don't need to wait for the CTA. The patient can be receiving the thrombolytics, so you get the CAT scan. And I don't know your workflow, if you do your thrombolytics in the CAT scan or if you get the patient out to the CAT scan prior to do the CTA with contrast. But interesting enough, in some hospitals, you actually have to get the CAT scan, come back to the ER, get your thrombolytic, and go back for CTA if you need it. So you're moving away completely from that, and you are actually standardizing this across the network and making more efficient and calling your transportation much faster. So this is the initial publication. This is from Mark Rebo in Barcelona. You can see here the data sets of comparing different patients using, of course, in this case, they did do the comparison with the ground truth was a CTA, but they did the screening of the imaging with the methinks algorithm, and that showed these numbers here. So if you use methinks LVO, which is a top table, the sensitivity was extremely good already just with the methinks LVO, just using the imaging. But if you use methinks LVO plus, that means that you add NIH to that data set. So you do the CAT scan, you do a NIH, then it increases definitely your specificity on this screening. So this is a very interesting way to enhance the ability of AI detecting and large vessel occlusion, not only by imaging, but adding a little bit of clinical information. And down below, you have actually how that pan out when you use the different vessels and the different types of detection strength for using only the algorithm versus algorithm and NIH. So I think it was definitely very interesting for us to be part of this project. When we look into only Illinois, how much we would gain if we didn't have to do the CTA and went directly from CT scan, we start seeing like an incredible decrease in times. And I think that very much as we're talking today of going direct to angio, this is becoming a workflow that is maybe in between to that. You're trying to screen the patient with a little bit of imaging as opposed to just come directly to angio and do the image in the angio suite. I don't know if we're going to have time, and maybe today we can discuss a little bit of that, like what is the trend here? Are we just getting a screening on the field and going directly to angio? There are issues with that. But at the same time, if you stop to get a CAT scan, either in a drip and ship situation, or if you do in a mothership situation, you're freeing up your angio suite, but you're having a little bit more certainty of that. You do spend a little more time than going direct to angio, perhaps, but it's better than having to do a CT and a CTA. So that's where we are with this. So I think that I hope this is appealing to you, that how we coordinate or integrate a stroke network is really using AI as an essential part of making this work. But I think the most important thing is that we need to do the AI for the AIs. I think we're going to have all these algorithms of looking at different things, but ultimately, if you are responsible for the administration of these data sets to do the post-processing, it's going to be key to organize that. And I'll give you an example of another project which is a little bit of sharing how you make a patient have all the different modalities connected to the one patient, so that when you receive the information, you get, I don't know how it is in your hospital, but not infrequently, you have a PAC system for radiology images, but you may have the GI images in another type of storage, or you may have the cardiac even studies, not in your PACS, but in a different type of database. So when you are in a very, I guess, many hospitals and you're having patients going from one place to the other within the network, there's no reason why you should not have all the image sets connected to that patient. And this is not talking only radiology modalities, but also OR pictures too, and any type of movies, any type of image file. One very interesting is the concept of when you do telestroke, we have a video file of that patient. So that video file showing the patient with a weakness or a facial weakness, or EMS teams, when you have on the field potentially a video of the patient, that video can be used to compare to a video on rehab later on to show the patient either improved or did not improve, but you don't have now to do an MRS scale. You actually have a true video file showing how that patient, you can perhaps argue that the AI will be able to quantify the improvement or not of that patient down the line by having these files. But you'd never be able to do that if everything is dead in the water. If you do a telestroke consultation and that video file gets erased or you don't store that, it will never be able to be used as part of that patient medical record. We do have some AIs that are acquiring video and speech files to then document, and that's called CV aid, by the way. So that is a way to do that already today. So the main issue here is that how you do this is isolate this, you remove the silos, the imaging stay in the hospital, and try to coordinate all basically more of a patient-driven file storage. So here you have radiology, cardiology, all these different files coming together. This is a different solution. I mentioned to you the AI of the AIs. Here's a different story. It's this workflow here, which is basically, there's this, it's a Diacom router called Ambra. And these Ambra files, what allows you to do is that any image that is done, and this is, I think, for the guys here, Eric, Nim, and Ricardo, you're gonna really appreciate this. Your Angel Suite today, if you have, I don't know if you noticed, but when you export the files from your Angel Suite to PACS, that's one option. But if you go into that drop-down menu of how many destinations you can send that, I know you're working on this, but you will be adding VisAI, Rapid, and then potentially SimCure and other destinations. But all this is done with this. You can anonymize the data set, and you can also have the different destinations connected to that. What that allows you to do is basically have a direct communication hardwire between your system, Angel Suite or CT or MRI, to the different modalities of that you or post-processing that you'd like to do. So it enhances your ability to do post-processing on the images you have from Philips or Siemens. I think this is an example of a CTP, a multi-phase CT. You can get a collateral score on your Angel Suite, and this is for the Iacono workflow. And not only you can do that, you can then send this to Rapid and Viz and try to get CTP results. This will come in your app. Today, we receive our angiograms in our Viz app. So you can see actually not only the CT, MRI, but you can also see the angiograms, and you can actually help you make your decision, compare these studies over time. So this is the case. Now, imagine that situation that you have the file, you have the OCT file, you have the DSA file, you do the simulation of that, and then if this can be sent to the robotic intervention, we'll talk a little bit about that later today, but that's how this information needs to be going from basically diagnosis to treatment. And so where we're heading with this, I think ultimately an integrated network, it doesn't stay only at the hospital level. So the next step will be basically how you track the patients on the field, and the wearable devices are the ones that, and this is the top right is CV8. So you can see the video file of that patient pre and post treatment, but also the ability to have more and more data sets. So our network advocate just purchased a company that builds wearables. And the idea is that you can locate the patient, so just to give an idea, recently we were in Japan at the World Federation meeting, and to get into Japan, you had to download this Join app and a family of Join app that actually was your COVID attestation to the government of Japan. So you upload your vaccination, you upload also your position. So any city you were in Japan, you had to let them know, no fever, I'm in Kyoto today, and everything is okay. So there was a tracker on that. It's called My SOS. And that tracker had the ability to then identify who was close to you. Everybody was being tracked in Japan while we were there, not only the citizens, but also visitors. And I know a lot of people are looking to each other. I don't think this is a good idea, but we potentially can track all the team members of our Angels. So sometimes we did this for kicks just to see, like when people are calling for a stroke code, you actually can see the little dots where they're coming from to the hospital. As you can track the ambulance, you can see how far the ambulance is going from one hospital to another, but you also can see how your tech, your nurses, and the doctor, where they are in route in relation to the ambulance. So then you can do it, detect if somebody got a flat tire or something is delayed with somebody, you can activate somebody else to help out in the code. This is then, if you know the patient not doing very well in the field, or this is actually the paramedics, they will have it's called joint triage. If we use a FAST-CD, but you can choose any scale, race, or so forth. In the field, they will connect with the stroke team, not only to the emergency room, but they can send to the stroke team. We're piloting this now. You can see that we would actually receive a direct communication from the field and be able to then start following the tracking of that patient, where they are, and talking to the ambulance at real time prior to coming to the hospital. So I think that's where I wanted to provoke you with these thoughts, and see if this is something you find interesting or not. But it's really the only way we're finding to integrate our stroke network is to using AI and organizing the data that we receive. And definitely looking forward to have other medical centers doing the same, so that we can actually find the same disease, clinical history, and treatment, and start comparing data that way. I think that's going to be a fantastic way as we integrate AI to Epic. So you have not only those isolated images, but now you have your clinical, and you can anonymize and then compare the data sets between medical centers. Thank you.
Any questions for Dr. Lopez?
Thank you for great talk. Have you had any discussion about these AIs with radiologists, and what are they on board, and do you get any pushback, any of that?
Yeah, so the it is an initiative from the Cerebrovascullar program, and we definitely, and Kiffin is here now, but she was really instrumental with doing that. The way it was a very limited release in the beginning. So I think there is something about AI culture that you need to work on. And that is, it will start, we definitely communicated with all the chiefs of radiology, every department of every hospital we went. And also the CT administration folks. So not only the radiologists, but also the folks that actually do the imaging and so forth and coordinate that. The administrators are very key for that in each hospital. Why is that? Because it's not a one-time deal. Once you get that processing in place, every new CT scanner you acquire after, you have to audit from time to time to make sure that all the different protocols are actually being sent to your AI. And now with a subdural aneurysm and different, in the beginning, maybe they were sending only the stroke codes for LVO detection. But many times now you really would like to have any CT, not CTA only, but also plain CTs sent. And I think that that is an ongoing then management of the relationship. What is interesting now is that after a few years going now, they what helped the discussion was the NTAP. So we had to talk to radiologists to ask them to do a dictation saying that they used AI on their interpretation of the results. And that conversation then made us, because we had introduced and we involved them from the beginning on this was an easy discussion to have. The hospital system was happy because now we're getting some reimbursement for the AI. And but I think I foresee this being now a constant managing of that, and you have to bring them to the table. But I do feel that the concerns sometimes come as you add emergency room crews, different type of nurse staffing in pre-hospital and in EMS. Who are you going to share the information with is key. So that's why we use a communication tool separate to our AI. Because if of course, today there are ways that you can isolate a chat without sharing images with the helicopter crew, ambulance drivers and everything. But we decided to keep that separate from the beginning, you know. So it's a communication is going to be key for the success of this, but the culture on AI is one to start doing these webinars constantly and keep that working that message.
Any more questions, guys? Early morning, everybody, quiet, no questions. Thank you, Chet.
Thank you.
Our next speaker is probably the guy that traveled the longest to be here with us, Professor Marcelo Magaldi from Belo Horizonte, Brazil, is going to share with us a very provocative talk on microsurgical revascularization for chronic ischemia. Thank you, Marcelo, for being here.
Good morning. So thank you, everyone, for being here this morning. Special thanks to Ricardo, Nima, and Eric for the invitation. Special thanks to Gustavo and Vito for the help, and to Abe, I don't know if she's here, for all the help. And it's a great pleasure to be here. Actually, it's going to be a different talk. It's going to be a very interactive talk. I'm going to ask you more questions than you are going to ask me questions, okay? And it's a very, it's kind of work that I don't know if anybody's doing, or how do you care, especially with chronic patients in stroke? You do what you have to do. The emergency system is fantastic. Dr. Lopez showed a fantastic lecture about AI, but what happens to the patient 6 months, 1 year, 2 years, 3 years after? So I know that, are there many physical therapists here in the room? Yeah, good. Speech therapists here? Nurses, maybe? Yes. So you are the people that most deal with chronic patients. So you are going to teach me a lot, okay? So I come from Brazil, and as it's an innovation talk conference, I'm going to see where do I advance here? I guess I'm lost here. Oh, here, sorry. So disclosures. I have no interest of conflict. Some slides is from my collaboration from University of Zurich and the Charity Hospital in Germany, where I had a meeting in Switzerland in 2020, just before the pandemics, where we have discussed a lot about brain hibernation and the chronic situations, what is very interesting. I'm going to present some real world data. So some cases are well documented, some cases are not well documented. You have to believe me a little bit. If you don't, that's fine. And let's go. So the first thing is we developed, so what's this brain? I forgot to tell in the beginning. It's brain revascularization to activate inert neurons. We divided the project that's been on in the last 3 years in brain A and brain C. Brain A, acute and chronic. In chronic, you can divide in occlusive stroke and non-occlusive stroke. Doesn't matter for me. It matters how the patient is after all these months, okay? So to start with, I present a case here. What would you do? This patient, she's a woman, she works, she has 4 kids. She was healthy. Maybe she had some hypertension, but she's not very aware of that. She's in poor social condition. She arrives at the public hospital, 45 years, 9 hours, arriving with this image. Hemiplegia, left hemiplegia, and there is no endovascular urgency in our service. There is none. So what do you do? You just care about her hypertension, say that's fine, go to physical therapy, and she's going to be probably with a huge deficit in her life. So what we did this angio CT, showed a large vessel occlusion on the right side, and it took her to the OR. It was 1:00 a.m. The anesthesiologist was fed up because nobody did that before, so he didn't want to help a lot. And we found this trifurcation thrombus in M1, M2. There was no way to see how it was before. So we did the intervention. Patient did fine after, and she returned home 1 week after, almost to a normal life. There was a big achievement for her, a big achievement in the public hospital. That's not my work. It's been done a lot, not a lot, but some centers do. It's not the purpose here to compare surgery with endovascular. Endovascular is the mainstay of stroke care. I'm just showing you some interesting things about the acute care. So what I'm going to show you now, after doing this case, we went back to the lab, as I'm known for the placenta guy, maybe you know me for the placenta guy. We tried to reproduce what we do in a stroke scenario with endovascular and surgery, and we actually published a new technique, how to intervene microsurgically in stroke. So first thing we did this, I don't know if you ever saw that. How does it look like a stent driver in removing the thrombus? We had this natural thrombus in the placenta. We took a stent driver and we forced it through the vessels, see how much force it's applied through the vessel, see how much thrombus you can have pushed back, and how is the vessel after. Did it stop the video? So let's see if it runs. Okay. Then it didn't stop, but okay. Then I'm changing, how can we do it microsurgically? How can, if you open it longitudinal, transversally, how big do you need to open? Then we did this and we published this case. I'm going to show you just because it's very curious. How do you remove the thrombus microsurgically. So you have the vessel very clean, and you do 2 stitches, and that's all. Then we got to this situation, real cases. What I want you to pay attention here, we found that there are 2 kinds of thrombos that make a huge difference for us. This is the thrombus made of blood clots, let's call it like this. It's a bluish appearance of the external surface of the vessel. You remove it very easy, very quickly. You close it very well. It goes very well. We had a little bit of, not a little bit, we have good success with some patients. Then we move it to this case. Not before moving to this case. We published the 2-1-2 technique that is very straightforward. I talked with a lot of neurosurgeons around the world. How do you do microsurgical thrombectomy? There was no defined standard for a pattern to do that. So I published the 2-1-2. What's the 2-1-2? You make 2 punctures in the vessel, 1 puncture, other puncture. You make 1 cut, transversal. You milk the thrombus out and you put 2 stitches. And it's a very straightforward procedure. You need to have a little bit of practice, but the blood starts to flow again and very, very nicely. So that was very nice. We almost saved, we can't say saved some patients' lives. But then we have this situation. What's the difference here? That's my big question. What's the difference here? What do you see that's different from the previous cases? The vessel color, do you agree with me? There is no bluish appearance here. It's all white. What does it mean? It means that the clot is rich of inflammatory fibrin. It's not a lot of blood clot. It makes a huge difference. And we could remove this clot. It's like doing an endarterectomy of M1 or M2. But at the end, the blood, we had some flow, but minutes after, the flow stopped. We open it again, the flow stopped. We open it again, the flow stopped. And now I made a conclusion myself. And I'm going to ask Eric, Ricardo, Nima, do you have an opinion about this? Difference of thrombus? It's just a simple question, but
I have a lot of opinions.
Good. Could you tell me, please, which one do you will go better after? Why it's not improving or improving?
Yeah, we have studied this a lot.
Yes.
With Raul Nogueira and Walid Bridgic and others. Again, what you show in the first case is what we call red clotting in the neurointervention. That's a lot of red blood cells, works really well for whatever too. And nice to learn that's true also for microsurgery. Right. Just for people in the audience, Brazil just got approved thrombectomy on the what we call the Brazilian Medicaid plus Medicare. We call that SUS. Marcelo works in a program like that. They don't have a thrombectomy guy in the hospital to do a thrombectomy. So puts him in a situation that he has the opportunity to do this. That is something that in our center, if you take a patient for a surgical thrombectomy, I'm gonna have Dr. Nima said, you're doing what? Why? And all the other neurologists, rightly so, because we have, that's not the case where he works. So the creativity surfaces on places that have more need, and that's, Marcelo, beautiful you're doing. With that sidetrack, so the red clot, easy for thrombectomy. The white clot's the problem because it could be thromboembolic, but there's a good chance here you're dealing with intrinsic plaque. And even when we do this endovascular, it's hard to say, is there underlying plaque or not? And what I think is, and I'm hopeful that with OCT, we're gonna start seeing that, there's a phenomenon we call plaque erosion, that is just a very soft plaque that just get denuded altogether and expose all the core of that plaque. And even when we do this with stenting, it still has a high risk of reocclusion because of all that core exposed. So there's a good chance this could be the case here. Right. This also could be a white clot that is fibrin/platelet. Now it's, right, we think it's more platelet than fibrin that is the issue with all these studies of clots that we were involved on. But this one that keeps reoccluding most likely is just erosion of a plaque, and you're just cleaning that platelet. It looks white because it's platelet. There's no red blood cells, and it keeps forming again and forming again. So that's the long answer to your question.
Right.
But one thing, just to there are some tools now that are trying to identify what type of clot before you do the procedure, because it seems to me that that's your next issue now, is to figure out when you have one or the other, right? So there is some work with non-invasive image, but also the other one would be there's some wires that can measure impedance, and that can tell what type of perhaps clot you're dealing with. And so that's really, I don't know if you have any other ways outside of looking from the vessel directly, but before surgery to try to predict that.
Yeah, thank you very much. That's exactly
And one last one, there's a brilliant Canadian young engineer that developed something that we work on with Laszlo Mixcocho, when I was a research fellow in Buffalo, is an angioscope. So these Canadian guys came with a balloon that you go very close to the distal carotid, almost at the carotid T, and then you arrest flow, and you go with a camera and you look at the clot literally with a camera to see if this, just like you're showing here, white or red. They can go there and look at the clot. So take a picture of the clot with a micro camera at the tip of a 14 wire that will tell you red or white and might change your intervention.
Yeah, no, that's excellent. That's exactly what we found. So if you have a red clot, straight, very good results. If you have a white clot, it's very bad. The patient is not going to recover, and it's very hard. And actually, we have this case.
You can have Ricardo doing the surgery from here down there. So that, I think that would be the way. You don't need aspiration. I'll show you that.
Okay, so we have those cases, and we started doing. Some patients got better, the red clot, the white clot didn't. So we decided, so if it's a white clot, we need to do the bypass. If it's a red clot, we need to do the microsurgical anatomy. So I'm talking about the acute stroke, and I didn't start the presentation yet, okay? So we have this patient, and we have this imaging, and we decided, we didn't know if it's white or red. We decided to go to a bypass. And actually, the bypass, the video shows after that, yeah. Both running, the bypass works, and the patient recovered pretty well after surgery. I mean, more than if we didn't do anything. He was very, with a very strong vaccine. But then that's it. That's the pathology aspect of the white clot. And we'll see a lot of fibrin, a lot of inflammatory reaction. And we think this is very difficult. Why am I showing that? Because to this kind of patient, they have a lot of inflammatory reaction. And if it blocked it again in the same spot, it will block in another spot in an artery, another place in the brain. Then we started to think about why don't we look after to do something in the chronic phase after the inflammation has gone, if the patient survives, can you do anything to add to this patient? Then you started the brain C. So the down come from here, not from here, Raul and Ricardo and Dr. Lopez everywhere. And we started to look at how chronic patients are dealt in the world. And besides the nurse, the physical therapist, speech pathologist, not much has been done, in my opinion. Maybe I'm wrong. So we still have some percentage of patients that don't get better or they die. And in my opinion, I'm very convinced it's because it's inflammatory phase, because it is white clot, because they keep on occluding and so forth. So what's the brain C? Brain C is that we did a project with people with more than 6 months of stroke with a functional deficit. We should do something. First, big problem we had, we're talking about a public health system in Brazil. We had not well or good access to physical therapy and speech pathologists, what makes a huge difference. And not because there is no professional in the hospital because people could not access the service. So that was a huge problem. And it's very different from cost study because the purpose is completely different from cost. Then we added another type of patient, the non-occlusive stroke. When I started to discuss about revascularization to a non-occlusive stroke, people thought that I was crazy and nobody supported me. So what are the targets in the chronic patients? The motor functional recovery, the cognitive or language impairment, we see a lot. Emotional improvement, the patients get very depressed or not motivated at all to do any kind of activity. The sleep pattern goes down. The patients start to sleep much worse than did, and they are all complain a lot of fatigue. Okay, these are the target points to deal with chronic patients. And there are two theories that I'm going to talk a little bit and show some cases in between. One theory is the blood flow. The blood flow to the brain area can be going down to a hypometabolic, a hibernation state because of lack of demand. It's like the better side of the brain, the normal brain, will take all the activity to the poor brain, let's say that, and then the blood starts to flow with less demand to the bad side. And the other theory that's been very dealt in the neurology nowadays is the glymphatic system. The glymphatic system may play a big role with inflammation. So after 6 months, this patient came to us, not very late. She had 6 months of stroke. She was very fatigued. Her face was very depressed. She could move the right side, not the left side. And this is 6 months. We called her to the hospital to see what we could do. On exams, she had a blocked. She had a blocked carotid in the right side. And what would you do with a patient 6 months with a chronic deficit? She did physiotherapy, some physiotherapy, not a very good physical therapy, and she didn't improve. And she had a right-sided blocked carotid. Again, I'll ask you a question again, Ricardo. So 6 months after, blocked carotid, some reasonable access to physical therapy, not that good, and angio-CT showed the infarcted area on the left hemisphere, and with some reasonable collaterals, and she had a carotid block. Who can answer that for me?
I would order an MRI and see what's the extent of the stroke burden.
We don't have an MRI, Eric. Sorry.
Yeah.
We have only an angio-CT, a CT, and the patient.
Yeah, then I would call you to see what you do in those circumstances.
Okay, good question. So the reason I asked that is, well, we really didn't have. So I'm telling the truth. Okay. So what we did, we looked at collaterals. I don't know if you agree with me. Again, I'll ask you three. If an angio-CT, do you know the MITF system? From Australia, a guy that published the MITF system, C1, 2, or 3, and it's based on collaterals. No collaterals, reasonable collaterals, or good collaterals. All the patients now, acute or chronic, if they have reasonable to good collaterals, doesn't matter what time, when, we go for revascularization. That's our experience. I'm telling my experience, and we have had success with that.
So Marcelo, just to clarify, you're saying that you have a patient had one stroke, one event 6 months ago.
Yes.
And is stable.
Yes.
Stable deficit, just so everybody understands.
Yes.
Stable deficit, carotid occlusion, cervical,
Yes.
intracranial.
Cervical.
Cervical carotid occlusion with a fixed deficit. She's not fluctuating symptoms.
Yes.
She's bedridden, right
Yes.
hemiparesis, degree
Yes.
of aphasia.
Exactly.
So you're doing a CTA and you're defining collaterals or not. If
Yes.
there's good collateral, you're revascularizing.
Yes.
So why you're not revascularizing the one that has no good collateral?
Okay, that's a good question. I'm going to answer that. In this case, I decided, it was a patient of my colleague, I decided with him to go to the carotid disobstruction. Do you know what I mean? Not the bypass. You asked the good question. You know what I did? I did. The carotid was occluded, and was a matter of bypass. If there's no collateral, we go to bypass. If there are collaterals, we go to the big vessel, disobstruction, even if it's chronic. That's what I'm trying to say.
Gotcha.
Understand?
And you're
So we did.
and you're studying this, taking everybody to surgery, or you're randomizing surgery versus no surgery?
No, we unfortunately, I'm not randomizing because I'm having a very hard time to even to do a few cases, okay?
Gotcha.
Because of nobody believes, nobody trusts this. So in this case, we discussed it. I see, no, she has collaterals. So we go to a large vessel surgery. We don't go to bypass surgery. So that's what we did. We did the neck surgery on her. We disobstruct the carotid. Coincidence or not, she did the physiotherapy twice a week. The family didn't have time, whatever. 1 month after, in the left leg, she was like this. We opened the carotid. We didn't do the bypass. In this case, I'm going to show another case. So we asked her, and she tried. She always put the hand to help. We said, no, don't put the hand. And at the end, she could move higher up a little bit her leg, what she wasn't doing at all before. Why it happened, in my opinion, and she was very happy. She started to walk 2 months after. She doesn't have hand movement. Why did it happen, in my opinion? I said the collaterals, because if you open a large vessel with the collaterals, there's some blood flowing. I was afraid of hemorrhage, but the inflammatory phase has passed for a long time. And why did it improve the leg with the large vessel disobstruction? In my belief, because flow still. She had some collaterals, flow still, that she have a great improvement of ACA, and the leg area was more irrigated with bloods. I don't know if you agree with that or not. So I started looking at the literature, and I had seen this publication that is very interesting. That's from 2018, that talks a lot about inflammation and blood vessel regeneration and neural network rewiring, brain plasticity, and the vascular impairment and the mesoral perfusion with extracranial intracranial bypass surgery. We didn't do that to this patient. We're going to show again a patient. And to improve in chronic patients, not subacute patients. So let's stop it too. I think it blocked it here. Can you show the next slide, or it's not working here? Okay, now it's working. So all the neurovascular engagement and the steal phenomenon. The steal phenomenon is what I believe to happen in these cases where you have a blocked large vessel occlusion and you have less blood flowing to the leg area. Okay, so now I'm coming from, I'll explain a little bit of theories. I'm going to show more patients in a while. This is from University of Zurich, where they made with the bolt, the MRI, where they have a flow supply over time in chronic ischemia, and this demand monthly by monthly was diminishing in the affected area. Why I'm saying that? Because you have the secondary area of neurons around the ischemic area that they get into like a hypometabolic state of less demand, and the blood still flow phenomenon drives the blood away from that area. So that's the reason. So it's like a tree in the winter. It's a real hibernation of the bad side of the brain, but the good side of the brain starts to get it all. So the patient chronically starts to lose function, not to lose function, or will never recover function on that side. So they did, we discussed that's from Zurich. This slide is from Zurich, and how the hibernating brain would behave in chronic patients. So now we got to this. Who can interpret this image for me? What do you see? Again, this is a SPECT and an MRI. Who can tell me what you see?
There's a left MC territory infarct, it looks like.
Yes, what else? Great, thanks. What else do you see? Who
The
tells me what else?
cerebellum, yeah, what's going on that cerebellum, on the right cerebellum?
Right. What is that? Do you know what is that? What's happening with the cerebellum here?
There's a phenomenon called diaschisis
Yes.
that you can see that on perfusion imaging. When you have a hypoperfusion hemisphere, this ipsilateral or contralateral cerebellum can have hypoperfusion. I think might be what you're seeing.
Yes, Ricardo. And why is that important? Do you have an opinion, Ricardo? No. Does anyone have an opinion about why I'm showing that? Why the cerebellar diaschisis in this patient, that's a chronic patient, has an importance in recovery? Does anyone can take a guess? So it's a very interesting phenomena that we started seeing in chronic patients that didn't improve. And we found a lot of work being done with that from Germany and from Switzerland. And actually what happens, a lot of, that's the bold MRI. And every time you get a ischemic deficit in the cortex, the cerebellum, the contralateral cerebellum starts to diminish function. And this function that's diminished, that's reducing, impairs the recovery of the motor cortex. So it's not only a matter of cortex motricity, it's a matter also of cerebellar control. And why I'm saying that, because I'm going to discuss this a little after. Besides that, we have the theory of the glymphatic system. I don't know, maybe everyone is aware with the glymphatic system. So the theory with the glymphatic system, with this reduced blood flow, reduced cell activity in this hemisphere, we have a lot of accumulation of metabolic waste around the vessels. So even if you don't have an occlusion in the vessel, the neurons that are around it get less function. And that's the glymphatic pathway. And then I'm going to move to another method. It's a little bit, I don't know if it's too much confusing, but that's how we built this thinking about chronic patients. So we started to look again, how do you treat chronic patients? And one of the most researched things they do nowadays is this transcranial magnetic stimulation. Does anyone have experience with this here in the room? So if in the transcranial magnetic stimulation, one of the theories is that when you, let me show here, when you stimulate the bad side of the brain, you have to inhibit the good side of the brain. So why does it work? Because you take more blood to the bad side of the brain and you do less cell activity on the good side of the brain. So you have like more blood flowing to the bad side of the secondary area or tertiary area, and then the patient improves a little. Besides that, you have more depolarization and you have more flow to the bad area. It may be the metabolic waste can be flushed a little bit. So some research done about motor plasticity after bypass surgery, and the diaschisis that Ricardo told us, the plasticity that happens when the aschisis is treated. Let's see how. And the cortical thickness of the brain. I'm passing here, and always, and now the NOVA. The NOVA shows very well what the bold has shown, that the flow diminishes substantially in some months after surgery in the affected side of the brain. So after revascularization, the flow starts again, and the patient might recover function. It's the same idea of the constraint-induced movement therapy. That's very simple. It's just to lock the good side of the body. You have to always use the bad side of the body. So to try to improve blood flow to the affected area. So I call it the bathtub theory. What's the bathtub theory? If the blood doesn't go there, if the flow is diminishing, no cell activity, a lot of waste inside. If you put water inside the bathtub, it will clean everything. So this patient here now is different situation from the first one. This patient, 40 years old, he had a carotid stenosis, he had an acute deficit, he was a tennis player, and after that, he was on anticoagulation, and the carotid was recovered, but he had a chronic deficit. We saw him 9 months after, and he was not able to walk. He was not able to move his hand at all. In this case, non-occlusive disease, more than 6 months. Then we did a bypass on him. It doesn't matter if the collaterals or not, there's not occlusive disease, but where are we doing the bypass? Where? In which brain area? Does anyone have a guess? We're doing the bypass in the premotor cortex, prefrontal area. Why? I'm going to explain you why in a little bit. So coincidence or not, you might say it's a coincidence. 45 days after the surgery, the father brought him, and the attendant that was with him brought him. They were extremely happy because she could walk on his own. But she could have done that with a very good physical therapy. Maybe, but he didn't recover. And he started walking by himself without help. He was not able to do that. His mood improved, his sleep pattern improved, and he was also able to do a little bit of finger movements that the father was very, very, very happy. Not a lot, but just a little bit. But then another thing came. The father was very happy, and I asked the patient, are you happy with the surgery we did? Now you can walk without assistance. You can move a little better your arm. You can improve your mood. He said, no, I'm not happy. I said, why? Because I cannot play tennis as I played before. So the standard of life of patients are so high, and he expects to go back to normal life as before, that even if you think you help him, maybe you're helping or not. But now I just spoke to his father last week. This was 3 years ago, and he's fine. He's able to go to tennis court and play some tennis now. He's doing fine now. Okay, but the standards are different. This patient, another patient, we saw this patient 2 years after stroke. His motor function was quite good, let's say, but he had a cerebellar diasthesis that I'm going to explain again. So the cerebellar diasthesis is a disconnection between the cerebellum and the motor cortex of the impaired stroke area. In this case, what we do? We think if we improve the premotor functional area, the cerebellum will function better. So she has less apraxia, she'll have a better movement control. And this patient is a very good case, because if you look at the 2 videos, you're not going to see a huge improvement, but he did not do any kind of physiotherapy. He didn't want, then the pandemics came, he didn't want to go out, and nobody could take him out of home. He was very depressed, he was not sleeping well. He in the hospital, he arrived, he could not walk without support, without assistance, and now he can walk by himself. We don't see many improvement, but he's very happy. His language somehow.
Eu sei, mãe.
Yeah, it's in Portuguese.
E aí, Geninho, como é que tá? Tá indo bem?
Tudo bem.
Tudo beleza?
Graças a Deus.
Tem certeza, Genival?
He's left, he's sleeping better.
Sim, mãe, calma aí, rapaz. Oxe.
Reperfusion improved him cognitively and behavior
Aí.
according to
Demais,
the family.
olha.
Okay, so that's what we have. Let's see. This patient here, you see that she's a young patient. She had a large stroke. I think she was less than 40, and she was very impaired. This is a very, very chronic patient. About 5 years after she came, we did this perfusion image, very bad perfusion, and she went to prefrontal revascularization to the prefrontal area. And 2 months after, she was very happy. She started walking again. She started doing some things again. It was very interesting. And she had some still phenomena. This is another example of the aschiasis. So over time, this is the Switzerland research. Over time, month after month, the cortex starts to thin and be thinner and thinner and thinner, and the miserable perfusion and flow still to the other side is a huge thing. So there are a lot of interpretation about this data, but we all agree now, we people that work with this, that hibernation is what happens with the secondary, tertiary area around the ischemic area. So the revascularization plays an important role because of the cerebellum and not only the motor cortex, as I said before. Here show the bold showing some improvement and cortex perfusion, also in the cerebellum. The image is not here. You see the cortical thinness. This is from Germany, these slides. And so we started doing this. We revascularized the premotor functional area, and we saw cerebellar improvement. We saw cognitive improvement. We saw motor improvement. We didn't have a good pattern to follow because none of these patients has done excellent physiotherapy. I think with this method and an excellent physiotherapy, we can reach much more. Then I went to the internet, and I don't know, Ricardo, do you know André Machado, Ricardo? Yes, and I discussed it with him. I don't know if you saw this paper in Journal of Neurosurgery. I think it was 2018. He's doing an NIH trial. He's from Ohio. And what he's doing now is putting a DBS in the cerebellum. And according to his findings, I just spoke with him last month, according to the trial is going to end next year. According to his findings, when you put a DBS in the dentite nucleus of the cerebellum, he saw the same improvements that we are seeing with surgery, with revascularization of the premotor cortex. And then the Zurich people just published an article this year showing the bypass in the subacute phase, not the chronic phase, that some patients might be eligible after 1 week of stroke for this improvement. They have their protocol. So why this happens is, I'm going to advance and then I'm going to come back. So here, vessels in the brain. So the original bypass, you do to M3 or M4 bypasses. We are targeting a very tiny vessel in the premotor functional area. Why? Because of the disconnection of the prefrontal, the thalamic, and the posterior cerebellar connection. And we think that stimulating the premotor function, the premotor cortex, will get also a cerebellum stimulation, and now the secondary area with more flow and with cerebellum connection, we improve some functions of the patient. This is some studies telling about the plasticity of the Purkinje cells in the cerebellum. And that's what we do now. I think the placenta helped us a lot. We get the STA, and it's like putting an elephant inside a very small insect. We do a huge bypass to a very, very small vessel in the premotor cortex, and we have seen some improvements. Another tool that we had the time to use was the Kinevo robotic microscope. I have nothing to do with size, but it's an amazing thing that during the bypass or just before the bypass, you give contrast to the patient, and by the flow measurement, computer flow measurement, you see where the indocyanine is arriving first and where is arriving late, confirming our theory that there is a still phenomenon in the cortex, and right after you do the bypass, it changed the image in the computer. We did the research with this, with the placenta, measuring different arrival times of the contrast. And the last thing I would like to ask, I'd like to say is, so with this chronic revascularization of the premotor cortex, or the André Machado in Ohio DBS put in the cerebellum, we had a lot of leg improvement. We have a lot of cerebellar motor coordination improvement. We had a lot of cognitive improvement, better sleep pattern, less fatigue. But of course, the arm and the hand are the most difficult part because it's in the middle of the ischemic area, and we're not resuscitating ischemic area. So we are also adding to this patient the muscle transfer. What is the muscle transfer? You get the muscle from another part of the body, maybe from the leg. You do a connection between the biceps to the pectoral area, so patient can flex the arm also. He recovered the leg, he covered more improvement of motor coordination. Now he can flex the arm, what helps him a lot in the daily life. So I don't want to prove anything to anybody. I just want to tell my experience here. And I'm very thankful to you. This slide, the end slide, my family, and the end slide is just to give hope to an area that's no hope at all. Okay, thank you very much. Thank you.
Thank you, Marcelo. Any questions, any thoughts? I have a lot of questions, but I'll save for if
As I said, a lot of questions I don't know how to answer because it was
yeah,
not our purpose.
Marcelo, we talked about this before, right? Again,
Yes.
at the level of stroke science that we live today,
Yeah.
and I know Luca Regli and
Right.
Peter Varkozik, that they are
Right.
working on that. This
Yeah.
has to be organized and this has to be randomized.
Yes, right.
Again, to show that, and there's a lot of substract that is, as you beautifully demonstrate, that makes sense.
Yes.
We failed to show that bypass work for much lower hanging fruit.
Right.
But maybe we chose the wrong patients to show that the revascularization, surgical revascularization, microsurgical revascularization makes sense. Maybe this is the target that will show that makes a difference. But they it has to be to show one case
Right.
after another case. Is I love your picture of the flower, right? Is it to spark? Is the
Right.
beginning of something?
Right.
But the next step is
Yes.
find, okay, this is the people with diaschisis, people with this level, and now we're gonna go and how we're gonna quantify and show a difference. But again, it's beautiful work that you're doing. And the microsurgical thrombectomy, I like to see that Luca finally published that, because we see this rarely. But again, Nima can tell the number better than I can, but I think we fail revascularization maybe 5 to 10% of time. And there is this group of slow
Right.
progressors that we identify with the CTP,
Right.
that if you fail to open the vessel, I think microsurgery may be where we fit that in our practice. I'd love to hear your thoughts. I don't know if Tudor is around, but Nima.
Yes,
Eric.
just a quick answer. I agree completely with you. That's why I said I don't want to prove anything to you. I have just my preliminary data, but I agree you need to do this randomized trial. I must say that it's very hard to do, but we need trying to do it. We need to try.
Yeah, thank you, Marcel.
Yeah.
As Ricardo pointed out, I mean, there's a lot, obviously, of question, open-ended question. But I think, so the group in Stanford, we're working, I'm sure we'll get the results shortly, with a stem cell implantation for stroke recovery. And they have those cases that they implant stem cell, they did the surgery, and post-op day one, the patient has a dramatic improvement. And those patients are patients with fixed deficit for like years.
Right.
So obviously, this is not the stem cell that did something
Right.
overnight. There's
Right.
something at surgery that probably disrupts some inhibiting,
Right.
phenomena or things like this. Or some placebo effect that, activate the brain in a way that is quite spectacular. But
Yeah.
I think we're such at the beginning of this. And, it's interesting because the diaschisis, we all know about this, but I never really thought about it as
Right.
a possible deleterious problem, that the cerebellum is doing something that would, and there's so much, like with now vagal nerve stimulation for stroke recovery. I mean, do we really know how it's working? No, it's probably overflowed flood the brain with, some new signal and all this. So it's sure exciting, as far as what is eventually going to be possible for long-term rehabilitation.
Yes, I agree completely. And it could be placebo, could be something was done. As the cranioplasty study that even with just cranioplasty, some patients improve it. And I always thought about that when you put that very big vessel, the STA, connected to a very tiny prefrontal vessel. It's a very tiny vessel with a huge vessel, and the pulsation is pumping strongly there. I say, could be the pulsation that is stimulating, could be just opening the vessel, could be the pressure. I don't know. I agree completely with you. Okay, I don't know.
Yeah, so a great presentation, and
Yeah.
it sort of kind of opens our eyes
Yes.
into what is possible.
Right.
It's especially on the recovery side, because I think that's where the big battle will be. That's the next frontier. And some of these approaches that you've taken are very intriguing as far as the chronic phase of stroke. And I think that the key will be to understand what the best outcome measures are, because the outcome measures that we currently use, ranking scale, are just too insensitive to
Right.
discern. And at the end, our goal is to make patients' lives better. I
Right.
like that the story with a patient who still was unhappy because was not playing tennis.
Right. Yes.
By a ranking score assessment, it would have been a success,
Exact.
but the
Right.
patient was unhappy. So
Yeah.
I think we need to find better ways to measure what we do. And then we're going to have to go to the phase of trials to prove that
Sure.
that the effects are consistent, but it's great work. Now, as far as the acute phase or subacute, I keep saying, my first dawn patient was a bypass patient. I was privileged to work with a great vascular neurosurgeon who was ahead of his time, Howard Jonas. And that's exactly what we did. We used a slow progressor, a patient who was had an NIH stroke score of 20, despite a very small infarct on MRI with a persistent MCA occlusion at 2 days after she came in. And based on this physiological principle, back then, we wouldn't even dream about going endovascular. And Howard did a bypass in that patient, and that patient did really well. And I don't know, maybe bypass, maybe embolectomy, maybe it doesn't matter what you use, just reperfuse the brain. And I do agree with Ricardo that there are these patients, especially maybe chronic intracranial atherosclerosis, that you can't open endovascularly, or if you try to do it, it's at incredibly high risk. That our slow progressors still have salvageable brain and may benefit from these bypass approaches. I think we are just totally brainwashed, if you want, by these old bypass and even the recent bypass trials, which were more chronic, but really nobody has looked at the acute side of bypass, where presumably the treatment effects are going to be larger. It's a tough competition with endovascular, because almost everything that you can do now is endovascular. So I think that's the biggest problem that open surgical techniques are. But I do think that, yeah, if you, my thinking has evolved to the point where, now I'm thinking, well, rather than doing nothing because you don't have the devices or whatnot, in the hands of a skilled neurosurgeon. And that's very, very important to emphasize,
That's
because
true.
there's not many people who can do this. There's
Yes.
very few people in the US who can do something like this. And that's the other problem. The skills are dying, right? Because endovascular has taken over everything. So how do you actually still find people who are going to be able to do these procedures? So these are the challenges, but I think you've opened up a very nice window into what can be done with open surgical techniques.
Thank you. Yeah, good. Okay.
Thank you, Marcelo. If no more questions, we'll move to the next one. Thank you. Our next speaker is Demetrius Lopez, back to talk about present and future of robotics in the Angel Suite.
Hello, everyone. I'm here in the back, so pay attention to the slides. Basically, I thought the robot should give this talk. So as well as all my M&Ms, the robot will be responsible for it now. So, I think this is very timely to what Baptist is going through, getting to the robotics now. I think it's really, hopefully we can share some of our thoughts on this. But also with the previous talk, I think we just showed how we still need the workforce to cover different parts of the world, and robotics may be an answer to that too. Just for folks that are not familiar, right now, what we have approved in the United States is the use of a cardiac. This is not a robot that is meant for neuro. This is a robot that is meant to be done just by cardiac procedures. And let me see if I can take this audio out here. Let's see here. I got it. So sorry about that. So the main issue about this robot is that we are doing these procedures now with basically a technology that was not necessarily developed for neuro, but the concept is that you have your access is done by a human, so you have the sheath in place, and now you're going to connect this to the robot. The catheter is also in the arch at this point. So you see the team will bring you, the robot will connect now in one of the ports. You have two ports there. Well, this is the port for the diagnostic. And then now you're going to be able to get the robot engaged into the catheter movement. And inside of the cartridge on the back, you can have the wire, seen there. Now the team here is going to be outside of the X-ray area. And this is there are different ways, and I'll share with you how we do in Chicago. But this is basically the system is getting ready. The wire is loaded, ready to start operated by the robot. Everybody gets out of the X-ray area, and then you can control forward, back, rotate. All these motions are in there. So you can see the green knob is moving the catheter. The gray one in the center is the wire, and the one on the left is going to be for the second channel, which is the guides and brings your devices to deliver stents or coils or whatever you're going to do. So now we have, let me see here. So the next step that I wanted to talk to you about it. Let me see here. I lost my images here. Anyway, okay. So now we're going to go back into the what we have going on in neuro today, and I'll share with you the data from Ms. Mint. It was just published, presented by Michel Piotin, and the Michel presented the first European trial on the use of coils for endovascular treatment of aneurysms using the robotic system. And this is really the first data we have. I'm very curious to see everyone's opinion on this. So let's see what we got. So here it is. So this is the name of the study, and it's basically the evaluation is a single arm study prospective, and they basically were able to take a look on what would be the first series on multi-center using the robotic system to treat aneurysms. And in this case, the issue was mainly, it was really the first time that's being done in multiple centers like this. So a lot of these operators had, the experience was in the beginning of their experience, basically. And you can see that the main issue was assess safety in this intervention. And these are the numbers, what we got. Basically, the population, you can see here, there was actually a surprising 94% that at times they were able to complete the procedure. And then I was wondering if this unplanned manual conversion, this is sometimes proves to be as we do radial or femoral access for these cases, even a diagnostic, sometimes you do still have to convert. So some of the catheters are being produced now to kind of be more compatible with the system. But I was really positively surprised that the amount of unplanned conversion to manual was not as high as I expected to be for the first trial. And now there are some things that you can see, this cassette failure. This is a real thing. So there's some technical things still happening, and that can be a little bit frustrating. But in the trial was not that prevalent actually. And these issues of working length is a major limitation. A lot of times for safety, you can only go 10 centimeters forward and back. So you have to position your catheter in a way that allows you to do that movement. But you can right now start from the leg all the way up because of this working length limitation. Now going to the safety and the complications here, 1.7% of major strokes and intra-aneurysm rupture, 2.6% on this study. This is again first study unruptured aneurysms were used on the trial. So this is definitely curious to see now a comparison between previous trials and registries. I think that obviously I think there's a lot of room to work, certainly from embolic complications and this issue of, I think interesting enough, the packing density and the ability to close the aneurysm, have a Raymond 1 occlusion. It was actually surprising. Is there something about the robotic placement of the coils that makes it better? I don't know. I think that this is definitely something that was interesting to see. And I think more to come here as these devices are built for the robot. So this is perhaps the most advanced. We're waiting in the United States to be able to treat aneurysms now. So we're not yet approved to do so. We can do carotid stents or vertebral artery stents. This is now what I wanted to talk to you is how can we prepare ourselves? And part of the initial study that you're going to do is to do a lot of diagnostic tests, some carotid intervention, but also a lot of training in vitro. And one of the concepts that we're very intrigued by is ability to do remote intervention. There are a few things that need to be done for us to be able to do that. One of them is that we are working now with Siemens to develop the console of Iacono, so you can control not only the robot, but also your angel table and your C-arms from a distance. And so with the first step for that was to create this setup here. So this is what we have in Chicago. We have the Iacono system. We have a robot there. This is the core path. And then what we did, we have in our control area, we have the same console as the angel suite, the bedside. So you actually can completely leave the room and be outside controlling the table and the robot. I'm sorry about these fellows, but if no need for fellows or for anybody in this case, because you can do actually everything on your own. And so you don't need to have anybody in the room actually doing this. You only do the connections and so you're ready to go. So the other aspect, so one is there's a PCI trial starting that is going to do remote. So the core path that you buy today doesn't have the beacon that allows you to do remote surgery. So that has to be installed in your system. So when you buy your system, just make sure you have that in there, that whenever it becomes available, you can add to it. But the other part that was important is that we're still sorting out the control of the room, which is a key part of this. You don't want to have to do the surgery with somebody, you're talking on an intercom to somebody, turn the table right, left, up and down. It's much better that you control everything. The other part was we had to create a prototype catheter that would fit in the robot as is today. And this is was perfect way to do it was the Q system, because this is a catheter on a stick. So this is from Mivi. And this wire allows you to actually connect to the second arm of the robot or the second cartridge. So one will have the wire that goes up and down that takes basically gets the access, and then when you are ready for the aspiration, you're going to bring this catheter on a stick over the wire, so you're going to be able to control the two devices, and this is would not work if you had a catheter all the way to the end. So we had to have this special system to be able to do this, and this is being modified with an extra 20 cms of wire so that we would have enough length to do this experiment. So now I'm gonna get out of here and let me see how I can see. Okay, that's good. So let's put this down here. All right. Okay, so Justin Singer was the first to publish on using a concept of a remote thrombectomy. And what we're trying to do is this. His concept was a little bit different than what I'm going to show you, but I'll share with you his videos here. This is his concept of how to do this. Basically, you'd have a robotic, you have actually a cardiologist on the other end, so that you have an off-site neurointerventionalist, and robotically, the neurointerventionalist advances the wire into the MCA. So that's what he's showing here. So you see this is being done. Obviously, this is not exactly robotic, it's still hardwired to do this. But what he's trying to show is the concept of you advance the wire as a neurointerventionalist, and then locally, you'd have, this is all can be done by the robot. And then an on-site interventional cardiologist would manually advance the catheter, the microcatheter over that wire. And that's basically now a manual work done by a known neurointerventionalist. And then of course here you'd start the aspiration catheter going up there, and then, or the stented retriever placement. So this all done now manually. So this is not too different than having, you're basically training a local physician to do the procedure for you. Our concept, and this is the animation we created to illustrate what we're trying to do, is more something like this. So I'll just play the video. We showed this at WNC, and basically is the concept of, as you have a remote robotic stroke thrombectomy completely alone, no physicians on the other side. So a hub and spoke model, you have multiple spokes, the ambulance gets to one of your spokes, or perhaps you're in Minas Gerais, and then the ambulance gets to the hospital there. And then your team locally places, you have the diagnosis of occlusion M1, and your team places the sheath, and the guide catheter has to be advanced by somebody locally. But now, once you connect the robot to the guide catheter, and this is basically showing exactly how that's done. So you're basically connecting now that RHV is a special RHV. You see that there is a little gear that connects now. When you put that gear, that allows you to rotate the catheter, and that sleeve go over the sheath. So now you're able to place the first wire, and this is basically your diagnostic wire there. And you see the MIVI catheter is on the side port. And you have also the ability to have an aspiration linked to that, and that's going to be very important. So now you can see you go your access wire. This is just a conventional approach. That's what Justin had shown how he did his case. So you see middle bottom, so you push that forward, you navigate, and then you can rotate, you can go back and forth. And then once you get into position, you're going to actually cross the clot with this doing the robotic system. And you can see here different speeds. You can rotate. There are different modes to do this. There are some studies showing that we can cross lesions better by using the robot in cardiology. But here you can see the left knob moves the catheter. That's the catheter going over the wire. And then at this point, you have engaged the aspiration catheter into the clot. You remove the flush and you connect your aspiration. That's done by your team locally. And then you can start aspiration, and then you'd take that clot out. Of course, you can use the 4 or the 6. Maybe there are different sizes of catheter depending on the size of the vessel or how much aspiration you want to have. So that we conceptualize this as that we could do completely a thrombectomy using the robotic system, using aspiration system with no local help of a physician. You basically would use only a local team that is familiar with the intervention. So we went to see, can we do this in a model? So this is a kind of what this looks like, the setup. You can see I'm actually not in the room. So I'm here in this position in the control area. You can see here you have the table control and you have the robotic control here. And you can see we have a silicone model on the table. So this is our patient. This is the appearance of the patient there. And just to give you an idea how that control works, this is a real time. We're basically moving the table. So you can see there, you can actually move the, you see, you can, and this takes a little bit of training. Like you would have to move the system in a way that it's coordinates much better if you don't have 2 people doing this. So definitely recommend that. And holy shit. And that is very exciting when you're doing this first time. It's really cool, actually. So look at that. So you play, we're doing just like catheterization of the different vessels, the great vessels, and you go back and forth. Now we're choosing the aspiration catheter. You're getting set up there. And just kind of going to show a little bit of how this is being done. It is still hardwired, but we are remote. We're not in the room, you know, doing this at least. And but I think that the Wi-Fi technology to be able to do these procedures will be key. Now let's just show how this is going to look like. And then we're going to do our final video here of how this whole thing looks together when you do this as a true case, looking like a simulation. Sorry. So this is your patient. You have an occluded vessel, MCA occlusion. Now we did this with soft clots, hard clots. There are some radiopaque markers here, so you can see that. And whoa, did I do that? Sorry. Sorry, we'll get that back there. And this is very remote lecture here. Okay, there you go. So now we're doing the angiogram. And so different types of clots to see, of course, the aspiration alone limits you. I tend to use balloon guide, stent retriever as local aspiration and proximal aspiration. So this is a different deal, but you can see us here. I had a wire shape. This is actually, to use this, you use the 18 or the 24 Scientia Aristotle wire. And now we're crossing, nobody in the room. See, we're very much just a robot there. And we're now navigating into the MCA with I think the 18 wire. And now you'll see, so we cross the lesion. Now you're coming, bringing the MIVI Q4 up. And you see this hand here is doing that. And now you engage the clot a little bit more, they engage. And then you're gonna ask the team to connect that aspiration for you. So I did remove the 18 wire so that you give a little more room for aspiration. So you see, bring the wire back. Now you tell your team to connect the aspiration. And so the aspiration is connected. And we'll give a little bit of time. And in this case, because you have a visual, you see the clot is being swallowed by the catheter. There's some antegrade flow already happening here. And then you're gonna basically retrieve the system. And so all this, of course, it didn't work. In this case, we had, this was a red clot, and that worked, a simulation of a red clot. We did have some problems with a more fibrous clot. So obviously, this is not going to work in every case. But I think the point that Tudor was making, if you have a early, somebody with no collaterals and you have a fast progressor, this would be a very interesting workflow if you don't have the ability to get to a hospital system in time, or in places that are just very remote. So this is what I wanted to share with you. I really want to just more provoke a discussion from here. So any thoughts on this concept? And if not, thank you for your attention. I'll come in the front so you can actually see that I'm actually here. Was not the robot.
This, and I think it's fascinating. My question is that obviously this platform was developed for cardiology, you know, and they're more advanced. Why is there not more adoption? And as much as it's interesting, like a country like my country of origin, like Canada, where, you know, not many people live in the northern part. I mean, this is a technology that obviously will be life-saving. I mean, you know, winter time, I mean, you know, you won't be to a big center for probably 4 or 5 hours. If you have that north available, I mean, obviously it's life-changing. So there's no doubt there's a huge potential. It's really exciting, but practically, I mean, what has been happening with cardiologists, and when you think that in the United States currently, most neurointerventionalists do less than 15 thrombectomy a year, where really is that going to position itself, you think, really in, you know, 10, 15 years from now?
So I mean, I think the growth on this may be not only thrombectomy, this is just one application, of course, but I feel that what we're seeing is that we are really in the infancy trying to figure out where this is going to fit. But once you start doing, you do see how that can standardize the procedure more. And I think that is one issue that we haven't done much, is like this issue of how do we keep these procedures in general reproducible in different parts of the world. And this is really one way that you could potentially do. You control the forces you control. Now, there's no question that we had to adapt. There's a prototype catheter that fits in the cardiac machine. There are issues with right now, even the remote possibility is not, unless you're in a trial to do that we cannot do. So it will be rolled out. You're talking years from now to have this. This is really very far concept, just say we can go in this direction potentially. But I do feel that in cardiology, part of the issue is that, and I talked to my colleagues about this, is that for them, they have a lot of cardiologists everywhere. So they are able to have a human in most places to do a PCI without a problem. For us, it's not the same. We do have less folks with experience and centers that can do that. There's no question this is ideal in a network that the post-op care of this patient is going to be done in the comprehensive stroke center. So this is just early arrival treatment, and then ship the patient for management into a place that can do that, ICU therapies, all kinds of things. So I think that's it is really a package. It's not an isolated that you're going to put robots everywhere. I think you need to think about how those patients are going to be cared for afterwards too.
So Demetrius, it's great. We should be talking about this approach. But as you said, I think it's still, you know, it's a technology in search of indication, in my opinion, because the remote stroke stuff is, you know, years away from standard adoption. And there are some developments that may make the time factor much less of a factor, and that's neuroprotection, right? Or if we get it right with neuroprotection and we transform all the fast progressors into slow progressors, then all this concept of, the time is of the, the 2 hours that are critical and whatever are not going to be an issue anymore. So I always maintained that just like with other areas where robots are now being used as standard, that in my opinion, this is only going to take off, just like in prostate surgery or the Da Vinci for heart surgery or the spine stuff, is when the robot is going to get better than the human, right? When the robot is going to do things that the human cannot do. To me, that's the inflection point. Because otherwise, it's good for us. We don't get radiated, right? But I don't see hospitals making these huge investments just to save us from being radiated. As long as we can do the same that we can do the same thing that the robot does, I don't see the indication. The manpower is growing fast, and if we really are looking ahead and are taking into consideration things that Tom Oxley showed, by the time robots are around, there's going to be a lot of interventionists because the need is going to be high, because we're going to have elective procedures, right? That right now we don't have. So I'm not sure that all these assumptions, the time, the remote thrombectomy, the manpower need, those are problems now. But I don't know they're going to be in 5 years, right, from now. And that's when this technology may be at the point of being used 5 years from now. That's why I think that efforts should be made. If I were to advise those guys, the Corindus guys, efforts should be developed into making things, making the technology so that it's better than the human.
Tudor, I think that it's definitely a process, but when you watch Vitor Pereira working with the robot, it's super nice. Just is very intriguing to see this in Michel Piotin's hand. The robot does things that we don't do as humans. So when Vitor is deploying a flow diverter to be agnostic of A, B, or C, the device performs better than when he's doing with his hands. Why? I think, and I think that could be why, when you tell the robot, hold the catheter in position, the robot is not holding, is doing a bunch of micro movements, reacting to the pushback of the coil or the flow diverter that keep that catheter on that position for the duration. So I think we're going to start seeing that. And again, Michel is the first time he showed that his packing density, and naturally this would be great. And they need to randomize, do the robot and do manual, because the same operators, the robot or no robot will be the only variable on that. Because you compare with the historical data, we all know that can be a gimmick. But I think it's very interesting. Another one that you said, look at the workforce, right? Our people, the trained people, a lot of them are going to be working in a low volume center. So the robot for the trainee, I think, is a great way to prevent errors that a low volume center could have, because the robot will be helping this. Again, in the US system, we discussed this with Christophe Coignard, all other French guys said, oh, it's much cheaper in France to train another interventional neuroradiologist and send the patient to that place. That's not the case in the US. We're not going to change the system here. Every hospital wants to have that, I mean, for better or worse. But I think it's going to be very interesting. That's why we're embarking on this.
But there's also teleproctoring.
Oh no, a lot of different things.
But I think so. I think some of the excitement comes down. If you look at the learning curve, if a fellow today starts robot and angio conventional manual, I think, and we don't have data on this yet, but it looks to me that 20, 30 cases you do you get farther away on the robotic, what you can do with the robotic system, than you doing with your hands, especially your background, depending what kind of, as you grow up, what you're used to, what kind of skill sets into eye to hand coordination you have. I do think that this will favor that if you start the fellows in both, that they're going to be extremely familiar with this in no time. It's going to be a pretty short learning curve. The other part is, I agree with Ricardo. I do feel that the navigation of this, you get used to this. I mean, now, almost every diagnosis, everything, I just get the access, get out and do everything from there. It becomes really, you become very comfortable with that workflow. And I think for me is doing some things that are very clean and very smooth and how the catheter moves around the circulation. Now imagine if the Icono, the angio system imaging is coordinated with the robot, and now you're starting using the navigation of the wire specifically into things that we normally just try and error, as opposed to be a smart intent on what moves you make to get a certain destination. And I think that is a little bit of when you look at the mode of how you move the wire, there are different defaults that you can do for zigzag or your torquing, this and that cardiologists have done to cross tight stenosis. But I think that we're lacking that right now. Honestly, every time we cross a tight stenosis, you have a roadmap or something, and you just kind of go with the flow there. There's no I'm not so sure, actually. Argument I hear all the time is, do you get the haptics with the robot? You really don't right now. You don't have any haptics there. But I have to say that if you have a good map for it or something, you may be able to apply that towards the offset the haptics information you're not getting. But that's a discussion. We're going to see this down the line. I think, you guys are welcome to the robotic program. I think that as you get engaged into this, there's so much to explore on this, but this is far from a finalized product. This is still being worked out, so be very much prepared for some frustration. So I know, Nima, you may be running this project, so it's definitely, takes a lot from your team and yourself to work through the kinks on this. It's not, it took a long time to get this done. It was not like you just, go.
Another thing that I think is going to happen, we're going to see tools develop for this, and that's what you mentioned, right? When you look what they can do with the Da Vinci inside the belly, and that's why it took over, because the degree of freedom that you have with the correct. Yes, I think this is a step in that direction.
Thank you, guys.
Anybody, any questions? James? I was 2.6%, yes.
Do you think you have that many in the lab with us? Going back to, when the robots do better than you can do?
That's a great question. It's tough to say, right? We don't know which kind of animals they're treating, so it's
there's no mortality for whatever it's worth on that, and but I think that I definitely was a little bit that was one of my concerns, and the conversion to man, because I wasn't sure how much the operators would feel uncomfortable and going to, but it sounds like the safety profile, based on this initial data, a lot of even the personal, interactions with the operators, everybody felt actually extremely safe doing the cases, like that. So I think the good selection of cases, I think, helped with that too. But this is the first information we got, so more to come on this. So.
But, for someone who is a bit, whose enthusiasm is a bit more hampered than these guys with robots, I must say this rate of 2% or 3% perforation, that's actually incredibly good, because this is just the beginning. It's only going to get better. That doesn't bother me. It's just the practicality of making it mainstream and really put it use it as a standard. And to me, you got to be better than the humans.
So we have a discussion in our lab all the time. How do you consent a patient if you're going to use a robotic system or not? you know, is this a special consent? So in cardiology, actually, you don't have a separate consent for that. But it's an interesting dilemma because some patients may feel good about it, others not so much. How much that discussion or separate consent is needed for that. We're not doing a separate consent. It's part of our regular consent. We will mention that we use a robotic system, but it's not a separate consent.
But only for on-label use of the robot.
Yeah, on label. Yeah. Thank you. Coffee break?
Yes, so we'll be back at 10:30. Different than yesterday, we're 10 minutes ahead. Woo-hoo.
That's very cool, man. So I mean,
Want me asking about the.
No, I put mine here instead of Dimitri's, and then we'll finish with ours.
Yours here?
Yeah.
Yours is gonna be direct chat.
Yeah, no, just updates and tools. Is that it? Welcome back, guys. So we're gonna start the last session before lunch here with 3 great talks. Again, we talked about this yesterday, and we had the distinguished pleasure to honor Tudor. Last time we did this before COVID, Tudor could not join us, but Tudor and Raul Nogueira had just published Dawn that changed what we do for stroke on the late window. So that award that Tudor got yesterday, in part, was due through his work with Dawn. Tudor Jovin is an icon on interventional neurology. Again, what he has done for the field, not many people can say. And for us, it's a pleasure to have one of his disciples, trainee kids, whatever we consider those that we have the chance to influence and help train. But phenomenal to call Tudor a friend from many places in the world that we bump in each other and we share experiences. And a pleasure to have you here, Tudor. Thank you for your time. I know your schedule. I know how much you travel. You probably travel more than Dimitris Lopez and Adnan Siddiqui together. So Tudor is going to talk to us about another barrier that between him and Raul was super fun at WNC last year to have side by side, each one of them present clinical trials that were instrumental in making it happen in China with the power of 1.4 billion. And here's Tudor is going to talk to us about posterior circulation thrombectomy, about the trial results. Thank you, Tudor, again.
Thank you, Ricardo, for this very kind introduction, but I don't think I travel more than Demetrius, just for the records. Anyway, this is about maybe the last bastion that needed to be conquered in endovascular therapy, because we didn't have any class 1 evidence to support treatment for basilar artery occlusion. Of course, we all were treating it, but it was not in the guidelines, and there's always risk that payers will not cover it and things like that. So I think the world needed the final proof for efficacy in basilar occlusion. And basilar occlusion is arguably the worst type of stroke. It has a terrible natural history, as you will see from the subsequent slides. It accounts for about 1% of all strokes and about 20% of all posterior circulation strokes. About 14 to 20% of patients that we actually treat with endovascular therapy are due to basilar occlusion. In terms of semiology, presenting features, there is a distinction between the distal and the proximal basilar occlusion. The distal lesions tend to be the kind of stroke presentations that we're more familiar with. The top, we call it top of the basilar syndrome. They're very sudden in onset, just like in the anterior circulation, maximum deficits at onset, and they tend to be embolic, many times cardioembolic. The proximal lesions are different because many times they are due to underlying atherosclerotic disease, high-grade stenosis that then go on to occlude, and they are preceded by more, or they present with more prodromal symptoms, vertigo, nausea, headache. It's more difficult to figure out exactly when the onset of these syndromes is, and that brings in some confusion as to indication for treatment and things like that. So Manifestations can include decreased level of consciousness, diplopia, dysarthria, drop attacks, tinnitus, a lot of very protean manifestations. So these are the proximal, more insidious in onset. And until recently, we didn't have that great natural history of this condition. Now we do. There's been several randomized trials now. And one thing is clear, that the natural history depends on the stroke severity at presentation, with severe presentation having a mortality of over 50%, and good outcomes, which in basilar occlusion, just because it's such a worse type of stroke, we consider a good outcome, even a ranking of 3 is part of a good outcome. So as opposed to anterior circulation, where we're more stringent in what we consider a favorable outcome, which I'm not a big fan of dichotomizing outcomes, but for the purposes of trials, we do that. In basilar occlusion, we're a bit more lenient, and even a ranking of 3, which is disability with inability to walk on your own, dependency, things like that, that's still part of a good outcome. That's how bad this condition is. And the other thing that became clear when people started looking at the treatment with intravenous TPA is that intravenous TPA works in basilar occlusion. All these numbers of natural history get better when patients get treated with intravenous TPA, and that has some important implications in the trials that have been conducted for basilar artery occlusion. This is prior to the randomized trials that I'm going to talk about. This was the most important data set for basilar artery occlusion. It's a prospective registry. People are putting prospectively cases where patients were either not treated with any kind of reperfusion therapy or intravenous or endovascular. Of course, endovascular at that time was rather primitive. There was basically the Mercy device or aspiration with small catheters. And the first signals were that intravenous TPA and endovascular are about the same efficacy, especially with regards to mild to moderate deficit at presentation. It looked like intravenous TPA had a bit of an edge over endovascular. And just like with the anterior circulation, a time-dependent relationship between efficacy and time to treatment, with patients that were treated earlier having higher chances of a good outcome based on treatment relative to time of onset. In terms of endovascular therapy, there are some particular aspects, and that relates mainly to these lesions with underlying atherosclerotic etiology, because that sort of mirrors more what's happening in the cardiology literature, where the cardiologists in STEMIs, in ST elevation MIs, have long given up on thrombectomy or even angioplasty. They just go ahead and stent the lesion. And that's perhaps where we're heading as well in basilar occlusion, where the underlying lesion is atherosclerotic, because we don't have to deal with, we're basically, number one, when the interventionalists here know that even in the era of modern reperfusion therapies endovascularly, the stent remains the fastest way to open an occluded vessel. And so when we put a stent there, it's the highest recanalization rate, most rapid, and it treats the underlying problem, which is a big predictor of subsequent reocclusion. These underlying atherosclerotic lesions tend to reocclude very frequently, and for that reason, the stent is kind of a definitive solution for that. The biggest problem when we put stents in the brain is that we need to use dual antiplatelet therapy, and we're worried, although it's not clear that the risk is very high, but at least we are worried that we're gonna have a high rate of intracerebral hemorrhage And certainly the advent of intermediate catheters has made stenting and the self-expanding stents has made stenting much more easier from a technical standpoint, but there's still some challenges, especially in the anterior circulation, to get stents there. And then there's long-term risk of restenosis and occlusion. And for clots that are stuck in a bifurcation, stenting remains something that we don't know how to address well. So, but certainly, I think that stenting in the basilar occlusion situation is something that we need to look more carefully at. We've been long known that even before we started looking at extended time windows in the anterior circulation, that in basilar artery occlusion, the time window may be a bit longer, and that's because of particularities, the collaterals, the brain stem resistance to ischemia that lend this condition particularly to treatment beyond the time window, the regular early time window. And just like in the anterior circulation, we've been trying to understand what predicts failure of obtaining a good outcome. And just like in the anterior circulation, the amount of infarct at baseline is a very strong predictor of good outcomes after the procedure. And for that reason, just in the anterior circulation, sort of emulating the story there, these investigators came up with the posterior circulation aspect score, which again is a poor man volumetric quantifying measure for the baseline infarct in the posterior circulation, being presumably even more difficult to determine than in the anterior circulation. But it's also a 10-point scale, and it just quantifies the amount of stroke in the posterior circulation. One problem with this approach is that it gives the cerebellum and occipital lobes the same weight or similar weights as the brainstem. And our own research from UPMC, of which Dr. Aga Ibrahim is an author there. You can see him. There's a poster that we presented at one of these stroke meetings. We have shown that by far the biggest predictor, as opposed to the anterior circulation, where the location factor is less of less importance. Here, the real estate factor, where the stroke actually occurs in the posterior circulation, is decisively important, with the brainstem being the biggest driver of outcomes, followed by thalamus. And so that poster actually materialized into a paper, and basically in basilar artery occlusion treated with thrombectomy, the strongest predictor of outcome was the infarct volume in the brainstem, not anywhere else. And with that, we came up with a prognostication score, which was age plus 10 times the brainstem infarct volume, and that would sort of drive your outcome. So now let's go to summarize the randomized trials that have been done in this space. There were 2 randomized trials, BEST and BASICS, both of which were negative trials formally. BEST was a trial conducted in China. Raul Noguera was part of the principal investigators. This trial randomized patients in the early time window. I think it went up to 8 hours. And the problem with that trial was conducted just around the time of the large anterior circulation stroke trials, was that there were a lot of crossover. So patients were assigned, randomized into the control group, but because of pressure by families to actually treat the patient, there were a lot of crossovers from the control group, the non-treated group, to the treatment group. So, but by the rules of clinical trials, and rightly so, these patients actually counted as controls, as non-treated, even though they were treated. The rate of crossovers was very high, 20 to 30%. So you actually had a lot of patients who were treated who counted in the non-treated group. And because of that, the treatment effect was diluted. The trial was powered for a 20% difference in outcomes, and the difference was there, but it was just about 10%. So the final result was non-statistically significant. If you analyze the data in the as treated, so in other words, not intent to treat, which is how the patients were randomized, but how they were actually treated, with meaning that the control patients were assigned to treatment. I'm sorry, that the control patients that crossed over were counted in the treatment group. That trial was widely positive, and that's a very important lesson for making sure that when you sign up for a clinical trial, you need to randomize trial. You need to randomize every patient, because if you don't do that, you're doing a disservice to the field, the patients. You're undermining whatever you're looking for to prove. And that was the story with BEST. We all knew it was sort of positive, but by the rules of the game, it was a negative trial. Basics was a trial that was run in everywhere in the world. It was international, run out of Holland, with most patients enrolled in Holland, but a lot also from Brazil. And it was a randomized trial with inclusion criteria of NIH stroke scale score greater than 10. As I mentioned before, we had this from the Basics prospective registry, this idea that the ones who are going to benefit most from endovascular therapy are the ones with the most severe stroke at presentation. The time window was 6 hours. Because the time window was 6 hours, most patients received intravenous TPA. The intravenous TPA works in basilar occlusion. So the control group had a lot of patients who received intravenous TPA, and that sort of, in my opinion, diluted the treatment effect. These are the safety outcomes. Higher rates of intracerebral hemorrhage in the endovascular therapy group, with numerically not statistically significant lower rate of mortality. And this is the primary outcome. 44.2% in the endovascular group had a good outcome, again, defined as 0-3, ranking 0-3, versus 37.7 in the best medical therapy group. You would say, wow, this is a pretty good natural history. All these patients did, 30, almost 40% of patients achieved a ranking 0-3. But the point is, most of these patients received actually intravenous TPA. And because of that, the difference was non-statistically significant. There was a difference, 6.5%, but the trial was underpowered to show this difference. And what happened is, during the trial, because they had very poor enrollment rates, this trial went on for about 7 to 8 years to enroll 300 patients. They changed the inclusion criteria and allowed patients with NIH stroke scale scores less than 10, 6 to 10. If they looked in the subgroup analysis at patients only with NIH stroke scale score greater than 10, that group was statistically significant in favor of endovascular therapy. So again, the clear signals here is that there is a difference in treatment effects, at least between patients who have severe stroke at presentation versus mild, and also in intravenous TPA group. So with all this in mind, when we designed the BAO2 basilar artery occlusion Chinese endovascular trial, we wanted to have a trial where, number one, there's not going to be that many TPA patients. So we just included patients in the 6 to 24-hour time window, and started out with an NIH stroke score greater than 10. So this was a randomized trial, randomized 1-to-1. The calculated sample size was 318 with a planned interim analysis at 212 patients. And the proportion of patients achieving an MRS 0.3 at 90 days was the primary outcome. The safety outcomes were the usual ones: mortality plus symptomatic intracerebral hemorrhage. And this was the study that I had the privilege to be a co-principal investigator on, together with my colleague, Chunming Ji from University of Beijing, Xuanwu Hospital. This trial took about 5 years to complete. It's just very hard to randomize patients with basilar occlusion. There were 218 patients randomized, about half and half. At the end, 110 and 107, one patient withdrew. And this is the data that we presented at the European Stroke Organization conference this May. The two groups were balanced in terms of baseline characteristics. You can see about 40% of patients were actually randomized after 12 hours. And the time from symptom onset to randomization was about 11 hours. The baseline PC aspects median was 8. We had restricted inclusion to patients with baseline PC aspects of 6 or greater. And then we also included in our included patients in our inclusion criteria. We only allowed patients who had evidence of small infarcts, particularly in the brainstem. That's the Pons midbrain index. And about 33% of patients had MRI for inclusion. The rest had CT. The location was about 50% proximal and only about 15% distal basilar. So that reflects the etiology in the Chinese population. They have a lot more atherosclerotic disease at baseline. And these are the causes of stroke by TOAST criteria. So you can see here about 65 to 70% of the patients had large vessel atherosclerosis. That's not what we would see here in Florida, for instance. It would be a bit more even towards atherosclerosis and cardioembolism. These are the safety results. There was a numerically almost statistically significant difference in symptomatic hemorrhages with higher rates in the endovascular group. But despite of that, a trend towards lower mortality in the endovascular group, a difference that was not quite statistically significant. And these are the primary results. 46% achieved a good outcome in the thrombectomy group versus 24% in the best medical therapy group. Only about 10–15% of these patients actually were treated with IV TPA in overall. So that's a 22% treatment effect, and it is almost the same as the other trial, randomized trial that was presented at the European Stroke Conference that I'm going to talk in the subsequent slides. So very, very similar results between these two randomized trials, which is great. They kind of validated each other. They were totally separate trials. So this treatment effect of 22% is very similar to what has been seen in the anterior circulation with a number needed to treat of 4, which is a very, very strong treatment effect. And all the other secondary outcomes were all in favor of thrombectomy. A statistically significant difference in ranking 0.2, ranking 0.4, and dramatic early improvement. Most of these cases were done with a solitaire device, so it was sort of a single device trial. And the reason for that is we planned it that way because the solitaire device in China can be detached, so it can be used as a stent. And we anticipated that there's going to be a lot of need for stenting in this patient population. The technical success was pretty good, 88% modified TQ2B, so 88% reperfusion rates, and about 37% of patients treated in the endovascular group underwent stenting, either by detaching the solitaire, or we allowed during the trial the use of other balloon-mounted stents because that's what the investigator were asking for. And then in the subgroup analysis, whether defined by age, NIH stroke scale score, amount of infarct aspect score at baseline, treatment with intravenous TPA, everything is in favor of endovascular. So that's the Bao-Chu trial. At the same time, Raul Noguera presented the ATTENTION trial, which is a very similar trial, also conducted in China, and there is no coincidence for that. Number one, basilar occlusion is very prevalent in China. Number two, we think that in Europe and North America, the equipoise for randomization was lost. So that's why these two trials were done in China. ATTENTION was a 0 to 12 trial, otherwise very similar. And the other difference was that the randomization was 2 to 1, not 1 to 1. Also, patients were selected based on an aspect score of 6 or greater in the younger population, and 8 or greater, just like in DAWN, in patients with or 7 or greater, and 9 or 10 in the elderly population. These are slides courtesy of Raul. Otherwise, the protocol was very similar, a multi-center trial in China, a sample size 342 subjects, randomized 2 to 1, with very similar primary endpoints as Bao-Chu and safety endpoints. And this is the sort of the consort diagram. They basically treated, this was a much more consecutive case series. They treated a lot more patients within the trial, and the ones who refused to participate were not treated. That was one of the difference with Bao-Chu, but otherwise everything very similar. Baseline characteristics very similar, except of course the time window from stroke onset to randomization, 5.1 hours versus 11 in Bao-Chu. And very important, the way we define stroke onset, just because of these insidious symptoms in Bao-Chu, we allowed headache, vertigo, nausea to be, that did not count as onset of symptoms. And here it was sort of an estimated onset of symptoms. So that's one of the issues with basilar occlusion presentation and time windows. Again, in ATTENTION, balanced groups, also stroke etiology, almost identical to the percentage, the large artery atherosclerosis percentage, almost 50%, with a smaller percentage of cardioembolism, reflecting the Chinese patient population. And also, just like in Bao-Chu, almost 40% of patients underwent intracranial stenting. This is the primary outcome for ATTENTION, almost identical with Bao-Chu. The only difference, the treatment group did exactly the same, 46%. They had a lower, 2% lower rate of ranking 0-3 in their control group. So their treatment effect was 24% versus 22 in Bao-Chu. So again, very, very similar results validating each other. Again, secondary outcomes all in favor of endovascular therapy, including patency, just like in Bao-Chu, of the basilar artery at 24 hours. Big differences in patency, 90% in the endovascular group and 27% in the best medical therapy group. And in terms of safety, they were able, because they had more patients, more power, to show a statistically significant reduction in mortality, not just a trend like in Bao-Chu, and also higher rates of symptomatic hemorrhage in the endovascular group as expected. Subgroup analysis, they actually looked at stroke etiology, and there was no difference in cardioembolism versus cardioembolic versus atherosclerotic stroke. So benefit again across all the subgroups. Very consistent results between these two trials. And also very soon after the presentation by Raul, there was a paper published in Circulation, the largest registry data of basilar occlusion to date. It's called the ATTENTION Registry, 2,000 and something patients. Also sort of patients who were treated, untreated, sort of a mishmash, endovascular TPA versus best medical therapy, no reperfusion. And those trials, those results basically mirror the randomized attention trial. So all consistent results. There are still some questions. One of them is whether we should intubate these patients in Bauchu and in attention. Not all patients were intubated. We're going to be looking at treatment effects difference in intubated versus non-intubated patient. Our own data, again, Dr. Aga Ibrahim is one of the authors here from UPMC and Emory, a combination, suggests that when we don't intubate these patients, there's no difference in outcomes versus intubated. So what are the unresolved questions for basilar occlusion? To me, the number one question is, because Bauchu and attention included patients with NIH stroke score greater than 10, for the most part, Bauchu had we also changed to 6 and greater during the trial, but most of the patients were NIH greater than 10. Attention only enrolled patients with NIH 10 or greater. So the question is, what do we do with these patients who have milder deficit at presentation? And do we give all the patients, regardless of time window, should we do intravenous TPA because it looks like it works in basilar occlusion? We don't have evidence beyond the 4.5-hour time window. And then adjunctive neuroprotectants, which I'm going to talk about more in the next talk. Adjunctive intraarterial lytics. There is a trial called CHOICE that has shown that when we give intraarterial lytics after we reperfuse the main vessel, and even in pristine angiographic cases following reperfusion, there's still benefit if we infuse TPA just to improve the microcirculation. So is that something that we should be looking at basilar occlusion as well? Anesthesia versus awake, it's not settled. And then what's the role of stenting and angioplasty? Should both be done? Can we get away just with angioplasty, or should we just not do any of these? And these to me are the big remaining questions in basilar occlusion. But I think that the fundamental question is, endovascular therapy effective? Does it improve outcomes in patients with basilar occlusion with moderate to severe presentation? The neurological deficit at presentation has been answered definitively by these 2 randomized trials. Thank you very much. I don't know if there's time for questions.
I think we have a few minutes. Anybody with any questions for Dr. Jovan?
Increased strokes related to vaccines?
No, I have not seen it. This has been looked at and published, but I have seen the one case of hypercoagulable state induced by vaccines with thrombocytopenia. It's a well-known syndrome. I treated that patient. That patient came in with sinus thrombosis and arterial strokes. She did actually well, but other than that, I have not seen more strokes because of vaccines now.
Thank you.
Thank you, Tudor. I have a question. So thanks for this. Like you said, this was something that had to be proven even though we were doing it. So I'm glad being involved in thrombectomy and circulation trial, I'm glad that I didn't have to randomize. Imagine a patient coming with NIH of 20 with a basilar occlusion. I'm glad that you didn't make me randomize that patient. And now for us in the US, is this now FDA approved standard of care level 1, or do we still need more evidence? And the second part of the question is, what should we do in our practice now with somebody with acute basilar occlusion and NIH of 3 or 4?
Yeah, it's 2 great questions. So, I'm not the one writing the guidelines, and I've been surprised by some of their decisions when putting out the guidelines. So I don't see how they're not gonna endorse thrombectomy for basilar occlusion as level 1 evidence because there's now 2 randomized trials. It's true they were not done in the US population, but there's also the subgroup analysis from BASICS that has mainly Caucasian patients where there is benefit. And, you know, I'm sure we will do a patient level meta-analysis of all these basilar occlusion trials. And just by the numbers, it looks like it's going to be positive. I mean, I haven't run the numbers, but I'd be surprised if it isn't. So I don't see how they're going to be able to not endorse this as level 1 evidence, but you never know. So we'll find out when the next, well, these 2 articles are in press now. I hope they're going to be out in a couple of weeks. So we'll see whether that's going to change the guidelines. I think it should. I don't see how it shouldn't. And then number 2, that's a tough question, and we don't have the answer to it. And some people just give IV TPA. I don't know that IV is necessarily better than IA for this kind of patient. I hope we're going to have some more randomized data to help us guide. There is there are a few low NIH stroke scale score studies ongoing now in the anterior circulation though, and hopefully they're going to provide some guidance. What I do now with basilar occlusion patients who present with low deficit is I put them in the ICU and watch them, and if they get worse, then we take them for revascularization. Even if they fluctuate a bit, you have a low threshold, but we don't necessarily treat them up front. Is that the good? You also have to have a very reliable ICU for that that approach to work. I would say if the patient is somewhere where you don't think that the ICU care is that reliable, and that happens all the times, people get worse and you know, we don't get notified about it, then I would have a lower threshold to treat that patient directly.
To the question maybe I missed, but the stented cases, about 30%, right? What was the protocol for antiplatelets during the trial? If you could comment on that. And then the other one is on the dissection cases, your approach today, how you handled the proximal dissection, distal embolization.
So for stented cases, the protocol was to give tirofiban. In China, they're big on tirofiban. Here we use integralin. It's they're probably the same. And ticagrelor is probably the best of all 3. So a bolus of tirofiban with a load of aspirin and Plavix was everybody got that. And then as far as dissections, I tend to stent them. Stent and then, you know, thrombectomy or the other way around. You know, if there's a good contralateral vertebral, then I tend to stent at the end. It depends a bit on whether this is the only vessel supplying the posterior circulation or not.
Anybody else with any question? Last question. Okay. Yep.
And you're going to leave it behind in ICAD. How do you clean off the thrombus that was ensnared before you deploy it?
Right. So you use the stent retriever as a stent retriever first because it's firmly attached to a wire. And that's actually how the Solitaire was initially marketed even in the US. It was thought of as a neck detachable and retrievable neck bridging stent for aneurysm treatment. But in other countries, they kept this iteration of the device. So you use it as a stent retriever first. You grab the clot, and then if you see there's underlying, and that's going to be your call as an interventionalist, is it a residual thrombus or is there plaque? But most of the times you can tell, or you know, it's possible that some of these lesions that were stented were actually thrombus. But you have residual stenosis, then you do angioplasty, and then you put the stent to protect the angioplasty lesion from micro dissections and things like that that promote reocclusion.
Time you deploy that stent, it's been cleaned off or.
Oh yeah, you
Yeah.
clean it up. We always clean it off, even when we use it as from one pass to the other. You just put it in saline or something, and usually everything goes away.
No mas. Thank you, Tudor.
Thank you.
Phenomenal work. Do we have a Matt online? We have the recorded talk, right? So we can go ahead and play Matt Gunas' participation, and again, frequent flyer. Always great to see the phenomenal work that he's doing. Today he's going to talk about evaluation of new tools and techniques for acute stroke treatment. Thank you again, Matt.
Good morning, everyone, and thank you again for this kind opportunity to present on the evaluation of new tools and techniques for acute stroke treatment. I've been with you virtually the entire time, and I have to say the content of the program has just been spectacular. These are my disclosures relevant to this particular talk. I am a paid consultant for Route 92 Medical, which I will talk a little bit about their device, but the majority of what I'm presenting was actually funded by the National Institutes of Health. I'm a preclinical guy, so I never get to name clinical trials. I'm always impressed at how creative all of you are in the audience to make really catchy names. And what I'd like to promote is faster, meaning first pass, TICI-3, easy to use with reliable results. I will spend quite a bit of this talk talking about the resurgence of neuroprotection. So what's going on with new devices? I think, and I'm just showing one example here, which is the Route 92 high point catheter that's delivered over a dilator called Tenzing, but there's others available as well. There's the Perfuse system. There's also by Imperative Care, the Zoom 88. I think getting the largest possible tube to aspirate the clot is really going to be a enormous advance in the field. And this is why. So I'm showing on the left here, this is a typical 070. So you take a small, basically biopsy of the clot, and then you cork this thing, you try to pull it out, and you rely on the cohesive forces of the clot to stay together, and they don't, they fragment. So you have distal embolization. Here we're showing delivering a large tube. So the Tenzing is placed just in the proximal aspect of the clot. You advance this large 088 system, and as you pull the Tenzing out, it's very similar to pulling a syringe plunger, and you completely ingest the clot without ever having crossed the clot. And we have evaluated this in vitro in our model system, and we have shown that it has very high first pass complete recanalization. So 90% in our very fragment-rich clot. You compare that to only 20% with the standard thrombectomy systems, the 070s and the 068s. With soft clot, it was 100% first pass recanalization. And what you see is really, if we take these data and put it in composite, it's an exponential function as a function of diameter. So in other words, complete clot ingestion is exponentially related to the ID of the tube that you deliver. So of course, if you don't cross the clot and you get complete ingestion, what I call the hoovering effect, you completely hoover the clot into the aspiration catheter. You have very little distal embolization, none in the large fragments and very little in the small category. And the question is, does this translate clinically? I think it does. I think our in vitro modeling in general does very well for clinical prediction. And so here is just an example of a case. You can see the Tenzing just placed in the proximal aspect of the clot, the large 088 tube being delivered over that Tenzing. And as you withdraw the Tenzing, it's very likely that you have complete clot ingestion. And when we tracked it, we did this work with Ricardo, as well as with Guilherme Dabu in the first 33 patients, consecutive patients that were treated with this technique we called SLIC, super large bore ingestion completely of the clot. We had 100% success in getting the device to the site of the occlusion. Of course, there might be some patient selection bias. Obviously, you're not going to take this large 088 tube and put it deep into an artery that can't accommodate the device. But in the selected patients, 100% success in delivering the catheter. TICI-2B, which is equal to or greater than TICI-2B, which has previously been defined as success, was achieved in the first pass in 82% of the cases. But the true first pass effect, which is TICI, modified TICI, greater than or equal to 2C was 71%. And this is in the first experience. I think that's going to improve as we have more cases available. What about stent retrievers? The Tiger 13 is quite an exciting device. It's very small, can be delivered quite distally, and it's constrainable. So you activate the expansion and compression of the device, and you can use that to try to facilitate better clot incorporation into the device. The Thrombex system is really exciting. It's basically two baskets that you can articulate. So you can literally sandwich the clot in between these two baskets and hopefully get complete recanalization. We've shown in vitro that it does have a very high recanalization and, reduces distal emboli. And then there's something we're working on with a group in France called Capto. It's a really exciting device. It actually uses peptides that bind to nets, which are neutrophil extracellular traps, which we know are abundant in emboli that cause acute ischemic stroke. And so it's actively grabbing onto the clot. So you can imagine the system we've measured again in vitro that it has a reduction of distal emboli and has a very high recanalization rate. But if you take what, Jan Gralla at ESPMNT last year presented the results of the SWIFT Direct study, which is using really the first generation thrombectomy system, the Solitaire. And what I took upon that, regardless of the true intent of the trial, was what impressed me, the rate of achieving successful recanalization, so that's defined unfortunately as MTE2B or greater, was 97%. So I think with these new devices, we're going to see very high first pass TICI 2C3. So the question is thrombectomy really the challenge? And maybe it is for MEVOs and VIVOs, but if you talk about the traditional large vessel occlusion, I think the problem, and as an engineer, I say this with a bit of trepidation, it's largely solved. So really, maybe we should turn our attention back to the brain. And of course, the era of neuroprotection, it's almost a dirty word in stroke. It was a disaster, billions of dollars spent with no good clinical outcomes or clinical effect. But that was in the absence of reperfusion. I think if we need to really reevaluate neuroprotection in the paradigm of successful recanalization or revascularization. And I think this is a landmark study being run by Mike Hill and Mayank Goyal. The ESCAPE NA1 ultimately was negative, but this is giving niretinide, which is a neuroprotective drug developed by Mike Tomiansky. And although the trial was negative, if you do the subgroup analysis, it turns out that patients that got IV thrombolysis with a plasminogen activator, the plasmin actually cleaved the drug. So when the IV TPA was given, it inhibited the effect of the drug. So if you look at the patients that didn't receive intravenous thrombolysis, there actually was a therapeutic benefit of giving niretinide giving niretinide in the setting of thrombectomy. So the ESCAPE Next trial is ongoing. I think the results will be in very soon. And I do expect that that'll be the first positive trial that combines a reperfusion strategy with neuroprotection, and that will hopefully set a standard of care to combine these strategies. Some work that we're doing, we're focused with a company called Focal Pool, again, funded by the NIH, to study the effect of focal hypothermia. As we know, systemic hypothermia is fraught with lots of problems, but the question is, can we use the fact that you are selectively in the target organ, can we use your catheter systems to deliver a cooling agent in conjunction with thrombectomy? And will that produce a benefit? The fundamental problem is if you take cold saline, and John Pyle-Spellman is the world's leading expert on this. If you take cold saline and infuse it through a catheter, unfortunately, you get about 1.5 meters that's inside a 37-degree water bath. So unfortunately, if you inject cold saline through, it's really going to be warmed. But if you take an insulated catheter, we can see that depending, of course, on flow rate, preservation of the coolant so that we can really reduce temperature. And this has been studied in China, just using a cold saline approach without an insulated catheter. And it has shown, the beginnings of potentially reducing the infarct volume by doing this cooling to the target organ. So we're going to study our insulated catheter so that we can preserve the cooling effect in a temporary occlusion of the middle cerebral artery in dogs with a coil. This was published by the Ohio State group back in 2007, so we adopted their model. We started cooling 45 minutes after creating a complete occlusion. The occlusion was then removed, simulating thrombectomy, and then cooling was continued for 15 minutes. We broke this into two phases. Our phase 1 study, we measured invasively with thermocouples in the brain, the effect of cooling in that target organ. And then we did a chronic experiment where we did the full cooling, survived the animals, and looked at neurological outcomes as well as imaging outcomes. And here you can see the model. So, we basically go through the posterior circulation to the middle cerebral artery with our microcatheter. We place a coil causing a complete middle cerebral artery occlusion. This is a very challenging model, but we were successful. And then we, in our phase 1, we delivered 2-degree saline at a flow rate of 20 to 40 ml per minute. And we cooled the ipsilateral brain to about 28 degrees. So you can see here's the data. On the ipsilateral side to where we're infusing the cooling agent, we have dramatic cooling, very deep, sharp, short duration cooling. Contralateral side, there was a small dip, and systemically, there was a very small change that could be just due to having an animal under general anesthesia and trying to maintain its temperature. But systemically, there was no significant change in temperature, but in the contralateral side, a small change, and on the ipsilateral side, where we're delivering a cooling agent, we really get a profound cooling of the organ. And so here's an example in our phase 2 study where we have the occlusion, we do the cooling, the acute MRI, just really a small bits here. 48 hours later, you see some edema of that ischemic lesion. Here's a control animal with a complete MCA territory infarction. And what we found, a very small sample size, but in our controls, the average infarct volume is around 4 cc's, which is quite large in the brain of a dog. In the cooling, we did see a small change in core temperature, which was not significant. We did have a small drop of hematocrit because we're giving a substantial volume of fluid, about 5%, but the infarct volume was really an order of magnitude smaller than in the controls. And the 3 animals that we were successful in, there was no deficit on the 30-day neurological exam. We've just recently completed, not published, a confirmatory study where 4 animals in each group of focal hypothermia versus control. And what we found is that the infarct evolution was changed. So in other words, the blue areas here were the completed infarct at immediately after the cooling experiment. And then we continued imaging and we watched the evolution of the infarct, and that's in red. And you can see very small expansion in the animals that were cooled as compared to here. We had a very small infarct in the control animal, but that continued to evolve. So it seems like cooling arrested the evolution of the infarct. And of course, this was a highly statistically significant. This is the growth of the infarct over that time period. And you can see in the controls, it was much higher than in the animals that received cooling. What about, I think this is a super exciting target, which is at our institution, I'll give you an example. It's a hospital 15 minutes away. It's a primary stroke center, not thrombectomy capable, associated with our system. So patient gets imaged, and despite the fact they're only 15 miles away, it's routine. And I know Demetrius has done a great job this morning in addressing the systems of care. It's such a challenge. It takes us easily 1.5 to 2 hours to get that patient from a hospital very close by to the thrombectomy procedure at our hospital. So maybe robotics or maybe AI algorithms will direct patients to the center. But what I'm wondering is if we can't just give a drug to buy the brain to arrest the infarct evolution, buy the brain more time, that might not be a more pragmatic approach. And so again, this is the model that we're using. We're going to create a permanent occlusion in the canine. We're going to do this by an autologous injection of a clot into the internal carotid artery. This was a technique taught to me by a good friend, Ali Shabani. This actually has a very rich history in the field of stroke. Before we had the rodent models, the dog model was the primary model of acute ischemic stroke, developed by Hill in the 1950s and pursued by Molinari in the 1970s. Of all of our animal modeling, this is the most reliable technique. We put a 6 French catheter at the origin of the internal carotid artery. We inject an autologous embolus made of the dog's own blood, and it routinely, consistently occludes the middle cerebral artery. So here's angiographic, both lateral and AP projections. You can see here the left middle cerebral artery before the clot is injected and after the clot is injected. And we have complete occlusion of the M1 segment. Excuse me. And we follow this in MRI to make sure the segment continues to be occluded. So here I'm showing the occlusion again. The biggest problem I had with our canine model is the variability, and this is again described throughout history, the variability of the infarct size. So for years, when I would apply to the NIH to use this model, they're like, the variability of the infarct is so large that you're going to need hundreds of animals. It's just impractical. And I hired a really smart MR physicist, Mohammed Shazib, and Mohammed told me, Matt, there's two distinct evolution patterns, and the problem is you're combining all the data. So he said, look, we have this fast progressors that dramatically, their infarct progresses very quickly. And we have these slow evolvers that seem to hang on for a while before they have the infarct growth. And what is really special about what Salman did was he was able to use a perfusion sequence that, when we create the embolus, and he was able to show that with perfusion imaging, I can predict which animal is going to be fast and which animal is going to be slow. And why that's important is if we're going to do a drug study, we need to randomize fast versus fast and slow versus slow for both the placebo treatment and the drug treatment. So this was a really important discovery in our laboratory, and he's able to do this reliably. And now I'm giving an oxygen carrier. So typically your hemoglobin dumps the oxygen around 40% tension, right? So if we want to get those pumps working in the ischemic penumbra, we need to tune that down to, let's say, 5-10%. So what we do is we give this oxygen carrier, and what I'm showing here in red is the progression of the infarct over time. And in red, it's a vehicle treatment. So there's a really rapid evolution of this infarct. And then in the yellow line is the dogs that got drug. And you can see that we can push this infarct evolution to the right. So we can buy the brain time. And if we look at the half point of the half of the infarct progression, you can buy about an hour of brain. So I think that this is a really viable and maybe pragmatic strategy for those patients who are not in a thrombectomy center. And you can see for the entire duration of our imaging, this is all done by diffusion weighted MRI, and we do analysis of the ADC, so quantitative analysis of infarct progression. And it correlates perfectly with our histological when we study the mitochondria death. So we're very confident in this technique. And what was also interesting is that even by the end of our 5-hour observation, the infarct had not completed. So we really think that this is a potential strategy to buy brain time. And then in blue, you see our slow evolvers with vehicle treatment. And you can see that, again, we can also shift the curve, even in slow evolvers, about 45 minutes to the right at the halfway infarct point. We are really excited that we're now able to actually perform a mechanical thrombectomy in a brain of an animal. So here I'm showing microcatheterization of the middle cerebral artery, deployment of either the small Tiger system or a baby Trevo, and we can actually do a recanalization experiment. Here's the post-thrombectomy image where we're able to create a TICI 2C outcome. And if we look at the perfusion imaging, this is prior to doing a thrombectomy. You see this large area at risk, and then this is post-thrombectomy with one small area of hyperperfusion, probably related to a distal emboli after the thrombectomy. So why do we need a sophisticated thrombectomy preclinical model? Because I think the ultimate solution is going to be a complex one. I think it's going to couple neuroprotection, and I don't just mean neuroprotection, one drug like niretinide. I think it's going to be a cocktail of drugs that are coupled with the pre-thrombectomy, post-thrombectomy setting, potentially including focal cooling of the brain. I am very encouraged by the concept of post-procedural thrombolysis. We have measured in our laboratory that regardless of what incredible technique you use to open up the proximal vessel, there is a shower of distal emboli, and most of 95% of those distal emboli are on the order of less than 50 microns. So nothing that can be addressed with a mechanical device. The question is, can you use post-procedural thrombolysis to take care of that? And there's some encouraging data coming out of Europe that might be a viable strategy. And of course, post-procedural neuroprotection. And I think to develop such a complex cocktail, if you think about all the knobs that we're turning simultaneously, we do need viable preclinical models to screen what is the optimal cocktail. So again, it's always an honor to be with you down in Jacksonville and talk about this exciting new future. But I have to say, even though I'm invited all around the world to talk about this stuff, there's a huge number of people who actually do the work. And I just want to highlight my partner, Vanya Anagnastaku, who did a lot of these experiments. Robert King, who is on our faculty now, he's an engineer who does a lot of the analysis. Mohammed Salman Shazib, who has been incredible in our image analysis, and a number of others. The list goes on and on. But just again, an honor to be with you virtually. And I wish you the remainder of the meeting to be outstanding. Thank you so much.
You there, Matt?
I'm here. How you doing, Ricardo?
Awesome, man. Any questions for Matt?
Matt, that was a very nice, you've done the job for me because I was supposed to talk about neuroprotection and reperfusion. So you primed the audience very nicely. And I completely agree with everything you said. They were kind of hitting the ceiling now of what we can do with our mechanical thrombectomy devices, that the next focus should be protecting the brain and so on and so forth. And I think this cooling stuff is very important because you also mentioned, and I agree with you, that it's unlikely that one neuroprotectant working on one mechanism of the ischemic cascade will be the winner necessarily, that the future is probably something that will entail some kind of approach that addresses all the aspects of the ischemic cascade. And of course, hypothermia is that, one of these approaches. So that focal cool work is really cool, no pun intended. So one thing that the Chinese group that has done most of the work, by the way, they're the Bao Chu people. They have reported that following infusion of ice cold saline in the ipsilateral carotid, that the hypothermic effect, you infuse for 10 minutes and then you have hypothermia for another 4 hours afterwards. Did you notice the same phenomenon, and how would you explain that?
Tudor, I was not aware of that. Thank you very much for bringing it to my attention. And regrettably, I have to go back and look at all of our animal health records to see if we continue monitoring temperature because it's in our protocol, but I never looked at that.
They put probes in the brain.
Yeah, so I have not done that for prolonged periods of time. If you looked at our data, there was rewarming when we stopped the cooling. So no, we did not see that, and I have no understanding of the mechanism. Obviously, Tudor, you and I are both big fans of hypothermia. It is a known neuroprotectant. The question is, and Pat Leiden is probably one of the world's leading experts on this, what is the target temperature and for how long do you do the hypothermia? And I don't have those answers. From a pragmatic standpoint, the way we developed our protocol was simply looking at the systemic effects of delivering large volumes of fluids, right? So that's why we did it for short duration. And we are seeing a benefit. But that was just pragmatically derived. It's not based on thermodynamics. So obviously, if you're pumping fluids, there's only so much you can put in. So that's where we came up with our protocol. But excellent points, and there's a lot of work to be done. And I'm curious, generally, both Tudor and others in the audience, I do think the cocktail is going to be complex. And the question is it viable for clinical trials to gradually turn all the knobs? I think that that's impractical, and that's why we're doing it in a preclinical setting, to try to come up with an optimized protocol so that then we can translate that to clinical study.
That's like the poly pill. You've seen the paper in the New England Journal of Medicine. You give people a poly pill as opposed to separate drugs. The rate of outcomes is dramatically reduced.
Thank you, Matt, again. Phenomenal work, man.
Oh, it's such a pleasure to be here, and continue to have a great meeting.
Awesome. Thank you, man. as Tudor already said, is a perfect segue because he's going to be talking about thrombectomy and neuroprotection. I think ties beautifully in what Matt just illustrate to us. Tudor.
Thank you again. So basically, as you can see, Matt and I share the same views on the importance of moving on to other approaches, and I do believe that this is the next frontier in large vessel occlusion stroke treatment. More than just looking at whether that device or that device buys us another few percentages in reperfusion rates or time, I think the gains that can be made with other approaches are much larger. These are my disclosures. And as Matt mentions, there is a revival of this concept of neuroprotection. Why is that? We know that number one, the outcomes in acute in thrombectomy are not that great. This is the Hermes data. It's a bit old, outdated. Maybe our outcomes nowadays are a bit better than what we saw in Hermes. 46% in the treated population. Maybe nowadays we'll do around 50% in all comers, 55%, but that's where we are. And I would argue that most, just like Marcelo said in his talk, I very, resonated with me that remark about the tennis player, that, we think that a ranking 0.2 is a good outcome, but the patients don't necessarily believe that. And I would say that most of us here in the audience would not be happy with a ranking 0.2. It means you're not working anymore. It means a lot of major implications in terms of quality of life. Yet we still define this as a good outcome. I think we need to reconsider what a good outcome is. And if you look at the really good outcome, a ranking 0.1, we are at 25%. So we clearly need to do better, right? And that betterment will not come from another thrombectomy device. I'm convinced of that. So there's different approaches that we need to look at. One is systems of care. That's another talk in and of itself. But another one comes from how can we augment the effects of reperfusion therapy. I do believe that reperfusion is probably the most impactful measure we have at our disposal, but that doesn't mean that we shouldn't look for other approaches that give us even better outcomes. And I think that certainly neuroprotection is something that we need to reconsider. And why should we reconsider it? This is the neuroprotection has been the graveyard of stroke trials. As you can see here, 160 completed human trials, none of them successful. It's been just one disappointing story after another. What have been trying to do with neuroprotection? Well, extend the therapeutic window for reperfusion, minimize reperfusion injury, and enhance recovery. That's kind of what we try to do with neuroprotection. The problem is, the fundamental problem, and the reason why it's justified to revive this concept is that all these neuroprotectants, and there may be have been some wonderful neuroprotectants that we passed the opportunity to show benefit. They were shown to work in very controlled animal experiments, like Matt Goonis showed in his presentation. He creates some very standardized, controlled model of MCA occlusion, and every single animal, every single neuroprotectant, every single strategy is studied in this very standardized model. But as opposed to what Dr. Goonis has done in his lab and many other researchers before him. When we go into the human world, until now, all these trials that I've showed that were unsuccessful, they just took all comers. They didn't have any kind of consideration for the status of the vessel. There were people with small vessel stroke, occlusion, no occlusion, open vessels, people who already reperfused, because the status of the vessel was never taken into consideration. So the most important driver of outcome has not been accounted for in all these studies. And now, with the advent of thrombectomy, we have a human model of reversible cerebral ischemia that can be applied and can reproduce the animal, the lab experiments that were done to establish the efficacy of a certain neuroprotectant. And I think that's the biggest difference. We now have the same kind of model that is being used in animal labs that we can apply to humans that we didn't have before. And that is why we should reconsider neuroprotection in human cerebral ischemia. There were other issues that were methodological flaws in the previous trials. One is that the treatment effect sizes were determined by infarct volumes, right? When we talk of this approach is efficacious in animals because it reduces the infarct size. But in humans, we use the disability scales as our primary outcome. And those two don't always correlate. So that's another, we didn't measure the same thing in animals and humans. And now the animal experiments are the methodology in animal experiments is getting smarter. The animal labs use now behavioral outcomes in these animals or measures of disability, et cetera, right? Stroke is most prevalent, as we all know, in the elderly population with multiple comorbidities, whether most of these trials just tested young animals. And there's been also publication bias. So that's kind of a review of an overview of the failed neuroprotectant drug trials that I was a co-author on, and we kind of summarized why these experiments, why these studies all failed, and why is it justified to readdress this issue. We need to also take into account, and that kind of ties into what Dr. Guni said about the cocktail of drugs, that the ischemic cascade is a very complex phenomenon. It's not only one mechanism of death. There's multiple mechanisms, and they all kick in at different time points. You first have excitotoxicity. You have these peri-infarct depolarization who kick in a bit later or almost at the same time. Then you have inflammation, which is a huge thing. That kicks in a bit later. Then you have apoptosis, which also kicks in later. So you need to address these mechanisms at the time when they're most relevant, right? So the timing of these drugs has perhaps not been the best, right? Depending on their mechanism. And sometimes, it's like a whack-a-mole. You hit the excitotoxicity, but all the other ones get augmented. And the end result is the same. So probably we're gonna need to hit all these mechanisms of injury at the same time, okay? And that's where the concept of cocktail comes. You address all these mechanisms at the same time. And that's very difficult because, as Dr. Guni said, when you do clinical trials, you can't use cocktails of drugs. The FDA was not gonna, regulatory agencies will not let you do that. So how do you actually prove these that a cocktail of neuroprotectant approaches works, right? This is again a recent review of neuroprotectant activities according to different drugs and approaches, and what the mechanism of injury they address. And ideally, we should give all these drugs to stroke patients. Probably would have more efficacy, but that's a challenge. We cannot do that from a regulatory standpoint. Another aspect that Matt has very nicely highlighted is this issue of fast versus slow progressors. Of course, we also need to take that into account, and perhaps it's something that we didn't add to our review, but it makes sense, right? Because fast progressors respond differently than slow progressors to certain interventions. And what is very important, again, the concept is that basically that's what we said when we wrote the paper about the fast and slow progressors in large vessel occlusion stroke, that when a vessel occludes in the brain, that you have growth of infarct, and the infarct doesn't form the entire area supplied by the occluded vessel, doesn't die off right away. It dies off in time. And there is a progressive growth of infarct until the entire area that is supplied by the occluded vessel has died off. And what we really didn't understand until recently was that this process occurs at different speeds in different individuals. The ones who have good collaterals or maybe other genetic predisposition, other factors that we don't understand that well, but there are these slow progressors. Those are the patients that drove the outcomes in the DAWN trial and DIFFUSE-3 and all these late time window. They are slow progressors. They still have salvageable brain despite being hours after occlusion, right? And there's the fast progressors, unfortunately. Unfortunately, there are a lot of fast progressors. They don't have good collaterals or whatever else they're lacking that makes them very vulnerable to ischemia. They grow their infarct very fast. And we've seen that sometimes somebody has witnessed onset an hour ago, and we do a scan and it's just a complete wipeout. And the classic teaching is go back and find out from the history that can't be an hour. No, it can be, absolutely. That's a super fast progressor. Unfortunately, as interventionalists, sometimes we see that because we can cause an occlusion and we know exactly when that happens. And sometimes we're unlucky and we see that even though we open up the vessel, the patient has a large infarct. That's a fast progressor. So one big task ahead in the neuroprotectant story is to transform all the fast progressors into slow progressors. As Matt said, buy some time, right? Different approaches. You can do that with drugs. You can do that with hypothermia. You can do that with collateral augmentation techniques. But the idea is that I'd like to see us 10 years from now or whenever, that everybody is a fast progressor, that when you call 911, EMS comes to you and you get this drug on board and you become a slow progressor. And then time is much less of an issue. You still need reperfusion because we know from DAWN and DIFFUSE and all these late time window trials that reperfusion is still necessary to prevent infarct growth, but you can slow down that infarct growth and you buy time until you go and open up the vessel with thrombectomy, right? So I think that's one of the holy grails of neuroprotection, transforming the fast progressors into slow progressors, ideally in the ambulance, at home, as soon as the sooner the better, okay? What's the prevalence of these fast progressor and slow progressors? When we defined a fast progressor as somebody who has a stroke volume of 70 cc's, which is about a third of the middle cerebral artery territory, within 6 hours, we thought that's a fast progressor. So if you infarct a third of the middle cerebral artery territory within 6 hours, that's a fast progressor. And we found in our paper that we published eventually that makes up about 25% of all stroke patients. Not that much, and then the rest are sort of another 25 are sort of intermediate. And then the slow progressors, which we defined as an infarct volume of less than 30 milliliters beyond 6 hours. That's what we defined as slow progressors. And that's about 50% of patients. And that's why there's actually a lot of slow progressors out there. That's why we could complete these DAWN and Diffuse 3 trials ahead of time, because we didn't realize that they're so common. But still, 50% of the patients are fast or intermediate progressors. So that's what we need to address before reperfusion with thrombectomy in terms of neuroprotection. How can we give these neuroprotectant drugs? Well, as I said, pre-hospital or pre-procedural, pre-reperfusion, a slow progressive cocktail. As I mentioned, that could be hypothermia, drugs, and collateral enhancing strategies. There are devices now that do that. We can give neuroprotectants intra-procedurally, like as you heard, hypothermia. We reperfuse the brain, or before we reperfuse the brain, we can infuse ice cold saline in the brain, or we can give these neuroprotectants intravenously or intraarterially during the procedure. If you, for instance, have a drug that only works on reperfusion injury, mitigates the reperfusion injury, it doesn't make sense to give it early before you reperfuse the brain. You give it after you reperfuse the brain, right? So depending also on the mechanism of action, you have to tailor the timing of administration to the mechanism of action. And then post-procedural anti-reperfusion cocktails, and very interestingly now, recovery-enhancing cocktails, recovery-enhancing strategies that we start learning more and more about, including, for instance, stem cells or other approaches that don't work on the ischemic cascade, but enhance recovery. How do we deliver those? Well, in the pre-hospital arena, it would be important to have something that doesn't require an IV, transdermal, intranasal, oral in stroke patients can be a problem because they can't swallow. Intravenous, of course, and then intraarterial, which has advantages and disadvantages. Now, in terms of cocktail, there is one approach that kind of covers it all. It works in all stages of cerebral ischemia, and that is hypothermia. If you look at the ischemic cascade, and I don't want to bore you with all these with the details, but hypothermia is a powerful neuroprotectant in the acute stage and also in the subacute stage. All these mechanisms that I mentioned earlier, hypothermia addresses them. But the problem is, as Matt Gooney said, that we have no idea whether it's him or Pat Lydon or whoever, nobody knows exactly. We haven't figured out the time window, the depth of hypothermia, how low should we go with hypothermia, the duration, and how we prevent complications, because there have the human trials of hypothermia have been disappointing. And a lot of that had to do with complications, pneumonia, things like that, infections. That's a real problem. And we need to figure out how to mitigate these complications. And as Matt said, this approach is very interesting because it may avoid the systemic complication and brings hypothermia where it is needed focally in the brain. And this is the group that has participated. We collaborated in Baochu in the basilar occlusion trial. They kind of paved the way for the focal cooling experiments or approach in ischemic stroke. They've published a lot, and this is a meta-analysis mainly of their publications showing that hypothermia, local hypothermia with ice cold saline infusion works, reduces infarct volumes, and does so only when or mainly when combined with reperfusion. So in and of itself, it's not very effective, but combined with reperfusion, it is very effective. And as Matt mentioned, the challenge is to find the right catheter that maintains that cool saline over the length of 1.5 meters as the fluid traverses from outside to the brain, and maintain that the temperature of the fluid. This is another interesting drug It's uric acid. It's a natural compound. There has been a phase 2 to 3 trial, a randomized trial that examined the role of uric acid in patients who underwent reperfusion therapy, intravenous and intraarterial. That trial was showed some signals of benefit, but it didn't quite make statistical significance. But there have been pre-specified sub-studies just having to do with the mechanism of action of uric acid. For instance, we know women have a lower concentration of uric acid, natural concentration. So the hypothesis was that uric acid will work better in women and in men, and that turned out to be true. The hypothesis was that uric acid will improve microcirculation in diabetics, and it turned out to be true in subgroup analysis of this trial, Urico-Ictus trial. Diabetics were found to benefit from more than non-diabetics from reperfusion therapy. And the most important to me such trial has been also a pre-specified subgroup analysis of Urico-Ictus trial that was conducted in patients who underwent endovascular therapy. So endovascular therapy plus uric acid. And you can see here, the number was very small. There were 45 patients who were randomized, but the treatment effect were really, really strong. So statistically significant. Again, it's a very small number of patients, hard to make much out of it, but they're very strong signals of benefit of this drug. Another interesting approach is glyburide, intravenous glyburide, the diabetic drug, which works on a receptor in the brain that prevents edema formation. Now, this drug has been shown to work in large strokes after in the delayed time window to just reduce edema in large strokes. But I think that this would be a very promising approach early in the stroke, because edema is an important mechanism that leads to infarct growth. So if you give it early, you could potentially transform fast progressors into slow progressors if you give it early and mitigate the effects of edema. And then the sphenopalatine ganglion stimulation is a trial that almost reached significance, very strong signals of benefit. This is a collateral augmentation treatment. You insert a needle in the sphenopalatine ganglion. That was done by a neurologist or ED physician. It's relatively easy to do with a time window of 24 hours after stroke onset. And this kind of improves collateral flow to the brain. And in patients with cortical stroke, this has been shown to make a statistically significant difference in the rate of outcomes between treatment and control patients. So that's another sort of promising approach. So because of this revival of neuroprotection in combination with stroke, there's so many drugs that showed promise. The NIH decided to take a methodical approach to this problem and selected 6 drugs, 6 approaches based on rigorous preclinical data. So these approaches had to fulfill certain criteria, and launched this program called the SPAN, Stroke Preclinical Assessment Network, which is a network where these 6 drugs and future others in the future were tested very rigorously in a completely blinded manner in all sorts of experiments, including all types of animal, young, old, comorbidities, behavioral outcomes, etc., at multiple centers. And I know that the result of this giant experiment is now known to a very small group of people. We don't know yet. It's going to be probably reported in a couple of months. I know there is at least one winner, one drug that has shown very powerful neuroprotectant properties and made the cut for what probably will be human trials combined with reperfusion. So stay tuned to that. Couple of words about the nerinatide. I think Matt mentioned this. This was a very important trial, the combination of reperfusion with a neuroprotection for a drug that works in the excitotoxicity in the very early phase of the ischemic cascade. There were some interesting preliminary studies showing efficacy. This is sort of how it works, as I said, in the excitotoxicity phase of the ischemic cascade. And this trial, which was completed and reported and published, included about 1,100 patients matched in terms of demographics. The patients received either placebo or drug around the time of reperfusion therapy. I don't know if you guys were a part of it. I think you were. We were as well at UPMC. It was very exciting, but it was not so exciting to hear the actual results. Overall, this trial was negative. But it turns out, so no difference between the two groups. But it turns out, as Matt Boonies mentioned, that TPA inactivates nerinatide. And these are some blood samples from patients enrolled in the trial showing that in patients who received intravenous alteplase, the blood level of nerinatide of the drug was much lower than in the ones who did not receive alteplase. So in fact, if you just looked at the no alteplase, no intravenous TPA patients, there was actually a very solid treatment effect, statistically significant, about 10% treatment effect on the ranking 0-2 between nerinatide and placebo, paralleled by mortality reduction and reduction in infarct volume. So because of that, of course, the trial was negative, but this finding encouraged the investigators to launch the second part of the continuation of this trial, which is called Escape Next, that enrolled patients only patients who did not receive intravenous TPA. This trial is almost done, and I hope it will be presented in February at the International Stroke Conference. So anyway, very exciting news there. Again, going back to this concept of giving the neuroprotectant very early in approaches that make sense, like excitotoxicity, collateral enhancement, oxygen carrier, as Matt showed, it is critical that it's being done as quickly as possible. And from that standpoint, what I was really excited about, and that was 2015, was to see that it is in fact possible to give drugs in the ambulance. This is the FAST-MAG study was done in Los Angeles County, and most patients in this trial received magnesium sulfate as a neuroprotectant, which didn't work, but it doesn't really matter. What to me, what was relevant is that you can organize a trial, you can make these treatments be available in the golden hour, the first hour after stroke onset, like in the FAST-MAG. And then nerinatide has a parallel trial called Frontier trial, where again, patients are being randomized and administered the drug in the ambulance. That's a trial that is ongoing in Canada. I'm very excited to hear the results of this study. The median time from onset to drug, stroke onset to drug in this study is around 50 minutes. So that's, again, proof of concept that you can give this drug in the ambulance, and this is what we need to see in the future. So in conclusion, I don't think neuroprotection is ready for prime time yet. We need those randomized trials. But the advent of reliable reperfusion therapies for proximal large vessel occlusion justifies a reappraisal of neuroprotection combined with endovascular reperfusion, mirroring the model of reversible MCA occlusion that we see in animals. So stay tuned. I'm convinced that in the future we will combine neuroprotectant strategies with endovascular reperfusion. Thank you.
Thank you, Tudor. Yeah, we are part of Escape in A1 and Next, and we're also collaborating with Italo. He has a oxygen
Yeah,
carrier.
I know it. I know it. That's also very promising.
Chimera, very, much earlier phase, but I totally agree. I think it'd be great to these
Yeah.
places that are 2-3 hours away that we can slow the progression and allow for the transportation. Any questions to Dr. Joe? Can we bring the microphone there, guys, please? Thank you.
Tô aqui ainda, ficar o dia inteiro. Já.
Thank you.
Claro.
You mentioned about the uric acid treatment as a possible treatment. Is this the same uric acid we're measuring in our gout patients? And if so, has anybody looked to see if there's any difference in the evolution of a stroke in treated and untreated gout patients whose uric acid levels are going to be quite a bit different?
Yeah, that's a great question. So there have been studies looking at levels of uric acid and outcomes in stroke. And lo and behold, there is a positive correlation, not necessarily gout patients, but uric acid levels, higher uric acid levels seem to have a protective effect. The patients do better.
Thank you. Any other questions?
So, thinking about cocktail and all that, so what do you think? I mean, there's people who routinely will inject a bit of verapamil. I mean, in Europe, a lot of people now use TPA. I mean, we'll have tendency to think about fancy new stuff, but what about studying those things like verapamil, for example? Anybody's thinking about just...
There have been studies of verapamil, of calcium channel blockers early in stroke, and not much in the way of signals of benefit.
But
and
again,
nitroglycerin too.
Yeah. For intervention?
Not for intervention, for early in stroke. But, I mean, I think that's why there's so many drugs or compounds or approaches that's why the NIH has taken this systematic approach and has studied very rigorously, first selected approaches that had some preliminary data that met certain criteria, very rigorous criteria, and then went on to test them to see whether the preliminary data was reproduced by these very rigorous blinded trials. And as I said, I know there is at least one winner. So I think that that's probably going to be a priority for the NIH to study that drug, because they spend so much on trying to find what are the best neuroprotectant strategies. But things may get a bit complicated because say NA1 is positive, then the benchmark will be reperfusion with NA1. It's your control group is going to be different. So it's a very dynamic, very fast moving situation. Sorry?
The Korean.
Yeah, there's a drug in Korea. I forgot the name. There's so many now. It's an explosion, and that's only what we know about.
I know this may not matter, but the mobile stroke units, do you see any role for them on the choosing which patients to be treated? Are any treatments that would be a contraindication to give if you have a hemorrhage, things like that?
Yeah, I think that I think that the biggest benefit for mobile stroke units is going to be trials. I agree with the speaker from yesterday, who I think was the director of EMS, right, Dr. Bradley? Yeah, Bradley. Here in this community, there's not that much of a role for it. I think there's no question it is effective, probably for patients who don't need thrombectomy, makes sense. But I don't know that it's so cost effective. In other words, it costs about 1.5 million to buy and another $1 million to maintain per year. The question that I have in my mind is, if I had this money and spend it on programs to improve stroke care, would I get better outcomes? That's something that is not clear in my mind. My guess is that the answer is yes. But I think for clinical trials, that is a very interesting approach. But I can tell you there are technologies being developed. I think eventually we're going to have a CT scan in a regular ambulance. That's really what I'd like to see, because I don't have a problem with a mobile stroke unit, but it delays transfers, it delays arrival to the hospital. So I'd like to see an ambulance with a regular device that can tell you if you have blood in the brain or not, and get TPA there. I think that'd be great. And I think that's where we need to move. And there are some companies that are exploring these kind of options.
Tudor, there's a question on Zoom. What about TPA? What I'm reading is that intra-arterial TPA during thrombectomy. I know you have a whole talk on that. Can you make a brief comment on that, using TPA in cases of incomplete mechanical thrombectomy?
Well,
or even complete?
Yeah, even complete, it turns out, I mean, maybe for reasons that and Matt also alluded to that, that there's a lot of sludging, there's a lot of impaired microcirculation. And all I can tell you is that this trial that was conducted on a very small number of patients, just about over 100, with initially incomplete reperfusion. But because of slow enrollment, they allowed inclusion of all patients, including the ones with pristine TK3 reperfusion. And that trial was widely positive. It was a randomized trial, small numbers, very strong treatment effect. I'm not sure I necessarily believe the treatment effect, but it's the direction. I don't have any reasons not to, to doubt the validity of the results. So I think we're not there yet necessarily to make this standard, but do we need confirmatory trials to look at giving TPA even blindly after we do our reperfusion therapies? Absolutely. And that's sort of emboldened me, if you want, to to be a bit more aggressive with chasing after emboli that were not recanalized, like the TK, the TK2B greater than 66 with an distal M3 that I'm, not sure I need to go after it endovascularly, but yeah, you can infuse some TPA there.
Great. Sounds good. We'll break for lunch. We'll be back at 1:10, guys. Full hour. Thank you.
Just a reminder, everybody, there are tables set up outside as well if you'd like to eat out there. Thank you.
All right, thank you, everyone. As everybody's coming in and sitting down, I'm gonna go ahead and get started with the next section. So this is an interactive section. We have some cases that we're gonna just go over and just open it up for conversation and discussion. So please participate. Thanks again for being here, and I hope you enjoy lunch. Hopefully this case presentation will not make you go to sleep after lunch. Obviously, you guys know that this is where we are. We're lucky to work at the Baptist. We have a dedicated, very comprehensive cerebrovascular program and an awesome team. Some of our team members are here today and some aren't, but we're lucky to have such a great team. It is because of the team that we're able to take care of these patients, and I'm personally very grateful for our fantastic team. All right, we're going to start with an aneurysm. Let me see. All right, 71-year-old with actually a few weeks of problem speaking and balance issues. And he came to the hospital. So the first thing we do is we get a CAT scan. On the CAT scan, we saw something suspicious. So then we moved on to do more other studies. And on the right of the screen, you can see that there's a area that is different colors. So that's a aneurysm that's shown on the angiogram. And I'm purposefully kind of going slow to make sure everybody comes in. But this patient had a few weeks of problem speaking and balance issue, and had this giant brain aneurysm. So the question becomes, what do we do for this giant aneurysm? I see Dr. Jobin is in the.
This is not a good problem to have. But the good news, I mean, obviously, this is something that likely has grown slowly over time. The brainstem is compressed, that it had time to adapt to that. We treat aneurysms in general, most of the times, to prevent rupture. And that's also one reason here. But this particular case here is a case of a mass lesion that you need to deal with. And so ideally, and I recognize that this is a tough location and may not be possible, but because this is a mass lesion that needs to be removed, and coiling or a flow diverter is not going to do that necessarily. It may slow down the pulsations within the aneurysm, but it's not going to remove the mass. Ideally, if possible, you would like to get rid of this thing, right? So how they do it, I have no idea. Carefully, I guess, right? Open surgery. But the first thing I would do is I would go to Eric or Ricardo and say, are you interested in this? Can you take it out? I'm not sure what they would say. I suspect no, but if they say yes, that's what I would do. And I'd be curious if they would consider some kind of an approach where they open it, suck out the blood, and then close it back, or something like that, to just remove the mass effect that this aneurysm is exerting. That would be my number one option. And if they say no, then we can talk about endovascular options.
Thank you.
So, I mean, I think that's the good way to look about this. The problem with dislocation in the basilar trunk like this is that it's really hard to access. So for people who are not fully aware with the anatomy, everything in the brain is operable. I always hate when we hear like it's unoperable. Everything is operable and reachable. It's just what you're gonna, what you could cause as problem or what you're gonna encounter. So this is an area really, really challenging surgically because all this aneurysm is, anterior to the brainstem. It's a really area really, really difficult to get to. There's all the cranial nerve wrap around. So to try to go ahead and clip this aneurysm directly, this is morbidity absolutely unacceptable. Now, one of the surgery that would be relatively small morbidity that could address this, there's a couple of consideration. Is first, whether this patient has good posterior communicating artery. If this patient had good posterior communicating artery, one of the safest way to go is to occlude the basilar trunk past the aneurysm under the superior cerebellar arteries. If you could show where that is, Anima. And this is an area usually that is pretty perforator free. And if you could clip under there, then the tip of the basilar is supplied by the posterior communicating artery, and the vertebrobasilar junction, the lower basilar system is supplied inferiorly from the vertebral artery. That's probably the best surgical option. And what's going to do is that obviously the aneurysm is not going to get the same level of flow, and eventually will just thrombose and involute hopefully. But that being said, there's still significant risk to that. So the question on the surgical standpoint would be, does this patient have good PCOM to consider a surgical option?
Thank you. Demetrius, any thought? This patient presents with a few weeks of dysarthria and problems with balance.
This one.
So the symptoms are relatively mild for the size of the lesion, and how old again?
Young, 50 something.
Yeah. So I think that I think what Eric said that was very important to do the angiogram, Alcock maneuver, just to see how the PCOMs are. I think will be crucial in that decision.
For this case, there is a left PCOM. I believe there was a left PCOM, but there is a PCOM available.
Okay. So I actually don't, I haven't done this clipping like that or trapping this. We tend to do endovascular this. If you were to do endovascular, you likely would have to consider flow diversion with coils, unfortunately. And I don't necessarily feel strongly about this treatment being much better than anything else. It's just been the alternative many times. But you bring a great point that surgery could be a relatively not as complex, not address the sac of the aneurysm, but actually the parent vessel. In this case, may fit that because of the space you have below the superior cerebellum. So I think that's very reasonable to consider.
Okay, Dr. Lopez, this patient is in Chicago on your table. How are you going to treat him?
I would flow diversion coils.
What delay aneurysm rupture would quote this patient for flow diversion coil?
So there not only that concern, but the other concern is, so overall, the risk for this case is definitely high, double-digit 15, 20%. It's a very risky procedure, not only because of durability issues, I would say recurrence is a possibility, or not be able to get rid of the mass effect. The other one would be the issue with having problems with immediate mass effect, requiring the decision about you take a tracheostomy, PAG, all these things are potential considerations to before or after shunting and things like that. So it's a complex, I don't think it's only rupture, Ricardo. I think there are other risks. I actually are more concerned about the mass effect that you can cause initially and causing instability of symptoms because of that. And also worry about the real ability to get rid of the aneurysm completely. This may not be over with one treatment.
So
the vote from the Brazilian table here, I was inquiring the team here. They said flow diverter with no coils. That's the Santa Catarina approach.
So I would be, my concern with that approach is exactly what Demetrius said. This is, even if it doesn't, if you don't have delayed rupture, you're likely to have some kind of a inflamed mass that exerts even more mass effect that can tip the patient over. So if you just do that without coils, I would probably put a shunt and, you know, maybe trach peg or we'll prepare for the worst. But I think that there's a few objectives here, among which also preventing of bleeding, but that's kind of the, there's more immediate objectives, and that is to remove the mass, prevent worsening mass effect, and then at the end, you know, also prevent this from bleeding. To me, the most logical approach, what I would do here is I would pack it with coils, because that's less likely to exert mass effect and inflammation around it. And that takes care of the mass, if you want, prevents inflammation. And then, as Demetrius said, this is for sure going to come back. When it comes back, either you pack it more with coils or you put a flow diverter at that time. But you do it staged so that you avoid this inflammatory reaction of a clot that can, number one, rupture the aneurysm, number two, exert mass effect on the brainstem.
Before Nima continue, we have a meta-analysis that I think finally we're going to be able with Medtronic to publish. If you look at the giant aneurysms, and we're not talking about basilar, we're talking about mostly anterior circulation. In Intrepid, there were some giants on the posterior circulation. But if you look at the M&M for giant aneurysms on Intrepid, Puffs, and Aspire, I think there are 120 giants. It's still the largest giant series. That's a 35, 37% major M&M. We'll talk about that disability through all kinds of mass effect, delayed rupture, so forth, so on. So I think that's one thing for the audience. Again, when you go home and you quote these people, if you see this patient, this is not a flow diverter, 3%, 5%, 10%. This is a high risk procedure. There is a significant chance this person could die from this procedure. On the flip coin of that, nobody knows for sure. If you look at all the data for stent coiling and clipping for these giant aneurysms, the data is retrospective. There's not much prospective series on that.
Tudor said, in anterior circulation, I think I have more experience with that, of doing a stage coiling first, and then there are some issues with that. But when you quote the risk for this procedure, obviously it is including all that the stages and you know, is the risk of coiling this while you don't have so many symptoms right now, let the inflammation take place or whatever healing takes place, and then as the recurrence is predicted to come, do a flow diverter at that point. Do we change the risk profile of the intervention? Because it seemed to me, if you do it all in one setting, definitely, I think 20, 30%, 35%. I mean, that's a very reasonable thing I can think of. Do we change that if we do first a coiling and then in a second stage place a flow diverter? I wonder about that.
Adam Arthur had a case just like this that he described, the fat man pants syndrome, where he put a flow pipeline and sacked the other vert, and 2 days later the patient just ruptured the aneurysm. It was a linear tear on the aneurysm because the clot got too big for the aneurysm. So we discussed all that. I don't know, Nima, if you want to show the team what we did.
So I think thank you very much. So to summarize, obviously we understood this was a very high risk situation. We did discuss options. We had actually a conference where we were able to discuss things that you guys just brought up. Obviously things that we had to also consider was hydro developing, so needing for EVD, and obviously post-treatment symptoms worsening. So we decided to do exactly what was mentioned. We went up and we used, basically plan was just to put coil to allow this from maybe help with the pulsation, and then perhaps come back and put the flow diverter. Obviously we didn't want to put the flow diverter right away because of the inflammation, mass effect concerning. So This is the system that we'd use. We would have scepter balloon into the P2 that didn't have the good PCOM on that side. In case we needed to place a stent, we were prepared for that. Then we put a microcatheter into the aneurysm, and we use this large coils. We were using the balloon as we were putting the coils for the first 2-3 coils. We got a good cast, and then we finished it. We were ready to put a stent if needed, but in this case, we preferred not to do a stent. Obviously, the patient wanted steroids. So this is the result. So you can see the basal artery is filling, maybe a loop there. At least based on this injection, there's not much flow going into the aneurysm. So we had a scepter that was a balloon that we placed in the aneurysm, basal artery, to prevent the coil from coming out. So we were happy. Patient actually did well day 1. Day 2, unfortunately, natural history of this is bad, but obviously surgical options were also without risk. So more inflammation and thrombus formation in the aneurysm causes mass effect. So even though he did good for the first 24 hours, within 48 hours, he worsened, mass effect, and bleed, and he did not do well. Any more comments about that? Questions? Yeah, so it's interesting. It looks pretty bad, right? But this is a slow, this is something that's been growing slowly. So he's been adapting to it to some extent. So he presented, he just had dysarthria and problem walking. Oh, he was fine. He was, yeah. He started having weakness on one side and then further deteriorated to worsen.
Did he bleed?
Yeah, first he had a mass effect, then he bled. Aspirin bladders. Yeah, so the first thing that happened post-op, we got MRI, everything looked good, he did good. Within 24 hours, he worsened with weakness initially on one side. We got MRI, more mass effect. Hadn't bled at that point, but then later he worsened and he had bled.
I was just curious, in Intrepid and all this, you were mentioning the case example of Adam Archer, but did any, because most of the puff and all this obviously was anterior circulation. So did anybody look at the angulation and the flow? Because this is a typical pure sidewall. So you wonder if the one that bled, it probably would work and look, it's probably not that many to look at the angle of flow.
Struggle when I look at this, and that's one of my favorite things about ischemic stroke. We're doing a clinical trial for every question that you have. You have a disease that we've been managing collectively for decades. There's no data to drive this. Again, we all have this. What do you do if again, if you do 100 clipping of this basilar with a good PCOM, what would be the outcomes? I remember being involved in a patient that we clip a carotid, and this patient just blew the aneurysm right under our eyes for a distal carotid occlusion here, as Eric was saying, would be distal to the aneurysm, right? Or you could go and coil at the neck. There are a couple of different ways to do that, but it's humbling to look at this, think, oh, we have good ways to manage that, and still lose somebody for a disease that should be treatable. So I think not having data to drive that makes it, I think, much harder, because again, next one, probably Nima will go put a clip there and then you have a complication with that, then we'll go back to the other side and we keep so a hard one.
Challenging for sure.
So you mentioned the surgical option would be to put a clip above the aneurysm across the basilar just under the SCAs. If you do that, obviously in the short term, there's a lot of blood flowing into it. Do you do anything like temporarily occlude the dominant vert with the balloon for 10 minutes? Not just...
So if you look, so that has been looked by our mentor Spetzer mostly, and if you look, it kind of we feel that those system, we kind of look at it like a garden hose that is wide open, and then you would put the clip distally, and there's still the pressure in the entire system. But the truth is that when you clip distally, there's no more demand there. So for a fraction of a second, the pressure increase and then it dropped right for a second. But That fraction of second, you don't know, but right after that, if you look at those pressure, they're really, really low.
But there are cases, just like the fat man pen syndrome from the flow diverter, that you clip the aneurysm in a day or two. Columbia, I don't remember if it was Ben Stein or Bob Solomon, have a series of those with distal occlusion that the aneurysm end up rupturing a couple of days after. So that same thing, same concept, right? If you think about, okay, there are a couple of perforators there, the flow is diminished, but not completely gone. And if the wall let it go, you may have a leak, and it doesn't take much blood to get. But again, that's a terrible problem. I don't think anybody has the answer. But the analogy here was, we think what we learned from giant ophthalmics on Aspire, Intrepid combined, there is a close to a 10% delayed aneurysm rupture with flow diverter alone. Talking about data with pipeline, not different with Centri. We also had delayed rupture on giant aneurysms there. But if you look at that on puffs, Aspire and Inspire, that number is significant, much lower on puffs, but was there as well in one case. So the analogy was, okay, maybe if we coil, let it cool off, contemporize, then come with the final solution, but didn't work. So.
Thank you. Moving on to the next case. 64-year-old female presents with left side of weakness, slurred speech, wake up. So last known well was the night before. Patient was outside the TPA time window. You can see that we got the brain images, and on the CT, you can see that it's hard to see here. Maybe there's a small area, but aspect at that point was calculated for 7. We do perfusion, which kind of tells us the penumbra, the area at risk. And this is the CTA. So at least based on this imaging, the patient had high NIH, scan didn't look too terrible. And then for the audience in the room, this is looking at the neck, the jaw is right here. This is a common carotid artery, this is external, and you can see that you're missing the internal carotid artery. So the question now is, this patient comes with this problem, what is the next step? Anybody wants to take a stab at this? What do you do next? All right, do you want to pick on Dr. Robinson? Dr. Robinson, thoughts, questions, and your plan? Good question.
I asked if there was an intracranial occlusion on the CT injury.
There was no intracranial occlusion.
And what is the patient's blood pressure? I think would be the next question.
180.
Okay. Well, given that, I think they presumably the left carotid's open and the verts are open. They have a circle of Willis that should supply the intracranial supply. So this is showing that they're acutely symptomatic from this, is my point.
Right. So what is your plan?
Yeah, so I think the plan for it should be to open that carotid.
Okay. So I think things that you brought up were very good. So the first question, like you said, was, is there intracranial occlusion? So no, the intracranial occlusion intracranially is open. But I think this is very important, right? So this is a acute stroke. So the patient's NIH is 20, and this happened overnight. So we know that this is acute stroke, so symptomatic carotid. It's not a chronic carotid occlusion that's been going on for years. So how would you like to open up the carotid? And Dr. Hanel, you want to take over?
No, I just want to ask a question, Mike. If the NIH is true, not 20, would that change your approach?
Yes. Yes, because we have a decent chance of hurting the patient and making them a lot worse. So keep them stable.
I shared that thought too, but NIH 20, right? Even though you don't have large vessel occlusion intracranially, you've seen that with different heights of occlusion of carotid, cervical or intracranial or skull base, not the carotid terminus. So well, how are you going to handle this? What are your tools?
So the first step, I think, is to cross the lesion whether that is with, with the wire, whether
What is your access?
my access for this, I would want a large guide catheter and probably a balloon guide catheter, because I don't know if I'll be able to have distal protection for a typical angioplasty and stent. So have proximal with a balloon guide catheter. So I would have that in place in the common, and then the next question is cross the lesion and try to avoid a dissection with either your 035 wire or a micro wire. I think I would prefer to try it with a micro wire. So I'd have a walrus type guide catheter in the common, and then have a micro wire with a micro catheter. Hopefully, if that would pass, then get the micro catheter into the distal cervical carotid, prove that you're in the lumen, not a dissection, and then exchange in a longer micro wire in that, micro catheter out, and possibly put a distal protection device across that if that'll pass, and if it doesn't, then balloon out and stent.
So a couple of things to consider, right? When you see an occlusion at this level, there's a 50-50 that the occlusion is really there. And Raul Nogueira published that on a nice series of that when he was at Emory. It looks like the occlusion is there, but there's a good chance, 50% based on his paper, that this could be a carotid terminus or a carotid occlusion, or there's no outflow for the contrast. Just like we talk about distal occlusion, right, for the aneurysm, there's no place for the contrast to penetrate that carotid. This may look like there's an occlusion there, and the occlusion is way higher. So we decide, because we chose the walrus, and I think the next picture I think tells the story, unfortunately. Oh no, here's just what we decide to do. But we started with the walrus, and this is what we got. So we put the walrus right against that, and we aspirate on the walrus, and that's what we got. We got a big worm.
Interesting, the syringe you use to do that, is this like a second flow? You use a 60, a bigger?
No, we used the pump, but there was no flow on the pump, and we had to pull back the walrus. And when the walrus was already a arch, there's still no flow. And then when they're coming through the groin, we decide to change the syringe to get the pump, because then we put the pump on the groin sheath to keep aspiration on the groin sheath. So that's why you get the clot on that. So we switched from one to the other.
So that's interesting, because I've seen cases like this that we would keep the balloon guide in position and finally milk the clot through it with a larger syringe. I think the pump is a continuous aspiration, but if you do a syringe, you get an intense, it's, I don't know, I would say that it would be nice to keep the access so you could see what happened. There was no distal embolization, it was just all in the carotid. I see.
Dr. Jovin had to step up, but if not, I would ask him this question. But since he's not here, I'm going to ask Dr. Nima. Do you think it make a difference, a syringe or a pump, Dr. Nima?
So actually, we did test that in our lab. Actually, let's see, our guys here. So we actually connect the pump and the big syringe, and they have the same aspiration force. So does it make a difference? But like you say, it's continuous.
It's for a short period of time. Exactly. There's no question that we've seen the same type of, whatever flow reversal minus 1,000 mLs per second reverse, but that whenever there is a limit for the suction that you're going to be able to do, and then it stops when you feel the syringe or something, with the pump, you're going to be more continuous. So I think that there is a difference on that sense.
And I think this morning, talking about technology and all this, I mean, the pump we're using, it's ridiculously primitive. I mean, this is like a pump, like same kind of pump that you connect in the wall of a patient in their room. So there's a lot of technological changes that are possible there. Like there's a lot of work on cyclical pump, on smart pump. In the peripheral field, they're already using pump that recognize whether you really have a clot while really well engaged. And basically you could increase your suction pressure quite a bit. So there's different things that are available that's probably going to happen pretty quickly. There's companies right now that dedicate all their interest basically just on maximizing pump efficiency.
So this is the going back and taking a picture, and obviously the vessel is recanalized nicely. And then I believe decided to put a stent because there was still a. Okay, moving on to the next carotid occlusion. Yes, go ahead. So the question is, if there's a occlusion intracranially, so let's say M1 was occluded, would you go across from the other side? I'll let others speak, but I think for our approach, the first thing is try to get the vessel open. So I will reserve that in case I cannot go from the occluded vessel.
And you could transform a bad situation to a way worse situation. And, that's one of the problem. All those tools we have, we don't have a way to secure the clot. So, you saw it earlier, like, there's a lot of possibility of the clot breaking loose or emboli. So if you come from another circulation, there's nothing that prevent this clot to stay with you as you're pulling everything. So you could, suddenly pull your thing and now you're occluding the other side of his little emboli and all that. So again, it's kind of, we do that to treat other pathology that there's not this, we're not bringing things with us like aneurysm, sometimes things like this. We go from one side to the other, but for stroke, some people have done it, but it's usually, a pretty last resort.
And another thing, Jason, for me, if there is an emboli on that side, it means that occlusion is fresh. And a carotid that is occluded, in general, carotid that is occluded for 3 months, 6 months, a year is not going to give you a fresh thrombus. I think that's very unlikely. So that's why when I see a patient with a syndrome like this, I don't know if we're going to have time. Nima has one that he had a patient with bilateral carotid occlusions, and which side you treat. That was not another cool one. I don't know if we're going to have time to show that one. But for me, if this patient has an age of 20 with a right carotid occlusion, that occlusion just happened. So this is fresh clot right there. All the tools that we have are big bore guys, and even to pull a solitaire to an ACOM, as Eric said, I would have coronary spasm.
All right, thank you. So keep talking about carotid occlusion. I'm going to go through this case a little bit faster, but this is a little different. So this is a 58-year-old who presented with stroke 2 weeks ago at another hospital, and actually he was referred to us for this carotid disease. What happened was he presented to us, we put him on, he was only on aspirin for some reason, so we started him on aspirin Plavix, and the plan was to follow him as outpatient, but the patient came to the emergency room because he continued to have symptoms, and actually when we got an MRI, he actually had new stroke. So 2 weeks ago had a stroke, comes to a clinic, you put him on medications, aspirin Plavix, statins, whatever, and then he comes back with more symptoms and a new stroke. Here the perfusion imaging when he presented, and on this is a CTA, you can see that the MCA is open, so intracranially again open, same as the previous case. However, I don't know if you could appreciate, but there is a carotid occlusion on the left side. So having said that, I thank our research fellow for creating such a beautiful pictures. I did not do this. But anyway, you can see that there's no flow going to the left carotid side. So on the right side, there's flow, the left, there's no flow. For sake of time, we can probably just talk about what do we do here. You want to take a stab at it, or just keep going? The NIH is mild, so this is a little different. So he's NIH at the time that he represented with the stroke. He had, I believe NIH was like 4. He had leg weakness and dysarthria, but it was not an acute stroke.
So this is his second stroke.
Correct, recurrent stroke while on medications. I'm sorry? Good. Yeah, so we had allowed his blood pressure elevated, and when he presented, his blood pressure was actually pretty elevated. It was like 180s, 190s.
It sounds like you need to open the carotid. The issue, you have a picture when he was not occluded from before, when he first presented, that could give you a hint of what disease was there before, because it sounds like an acute occlusion. And before he was having either, TIAs or strokes from the symptomatic stenosis, I assume. And then now it's occluded.
No, I think, I see what you mean because of the.
Yeah, the
outside
previous,
facility.
exactly, yeah. But this is a case for sure. If you're gonna do, I'll probably do endovascularly, but if I would have let me see the arch there. The balloon guide is very helpful in a situation like this. And I think that you want to have flow control here. I think that would be one tip to have. I don't think you're gonna have to cross this doing an aspiration early on to interrogate. That is reasonable.
What about that heavily calcified plaque on the carotid? Does change your management? Endovascular versus surgical versus contralateral carotid?
Yeah, I mean, I see what you're saying there, but that amount of calcium, I think it's calcified, but I don't know if I would say heavily calcified. So.
We're, for the audience, we're talking about here. So this is, there's no filling on the left carotid.
Nima, can you show there?
The right carotid has, oh, I'm sorry. So medical management, I think here is important. So aspirin, Plavix, blood pressure, as Dr. Chamsani brought up.
Yeah.
But when we saw this patient, this is an arch run. You can appreciate a little more about the anatomy. Let me see if I can pause this. How do I pause this? Can you pause it? Perfect. Thank you. So anyway, the right side actually we did measure it. It was not that high. It was only 50% or so. So we decided not to do anything about the right side. The left side was the one that was causing problem. I don't know if you can see that on this angio, but the other problem was there's no good collateral. So this patient had no good ACOM, no good PCOMs. That's why he's probably one of the reasons he keeps having stroke. So no good collaterals, carotid occlusion. Can you play, please? Oh yeah, so you can see that the narrowing was not too bad, but there's no ACOM. So sometimes you can open up another vessel to augment the flow. You can see that there's no right A1, so the left hemisphere is not filling. And there's a very small PCOM, pause if you can. Actually, just keep going. So there was just a very small PCOM that was filling that left hemisphere. That's what this guy was living off of.
Nima, who's playing there? Can you go back a little bit? Just drag a little bit. Keep going, keep going. A little more. Stop right there. So can you point, Nima, to the carotid siphon filling?
Yeah, so you cannot see, but there was a very small PCOM filling here. And what Dr. Hanno is bringing up, which is important, is with that small PCOM, you can see that there's a retrograde filling of the carotid artery.
So Dr. Spatzler published this in the late 80s, 90s. They put a scale when they used to do thromboendarterectomy for these patients. The lower you see contrast returning on the carotid cavernous petrous, the higher the odds that you open the carotid. There's a good distal vessel to allow backflow. So you open the carotid and you regain that. So that's very important. The angiogram is very important. Sometimes you can see that on CTA, but I think the angiogram brings great information here, because if you see no flow below the stomach, then you may be dealing with tendon stenosis and things like that.
Thank you. Can you? This is the carotid, right? So AP, you can see that the carotid is the cavernous, so there's a loop there, but yeah, that's the carotid, that's the AP. Correct.
It comes all the way to petrous, so that's a good sign.
Play, please. Keep going. So here, put a wall, handled it, aspirated. I did not get a long clot this time. So went through so as Dr. Robinson brought up, first you have to cross the lesion. So we're able to cross the lesion here. You can see, keep going, please. Keep going, please. So across the lesion, and do we like to use a distal protection for these? So microcatheter, do injection to make sure that we're in the true lumen. You can see that microcatheter injection, there is a problem, right? So there is a microcatheter is there, but there's a problem here. Regardless, we're in the true lumen. Keep going, please. Distal protection placed, angioplasty, then stent. So you can see the stent is placed. But as I mentioned, there was a problem up there. Keep going. Which the problem ended up going from here to here. So now we stented it, we had a distal protection, but a blood clot had gone from here now to the M1. We kept access at all times. So we went up with the aspiration catheter. Keep going, please.
And that's protect.
When I remove the distal protection. No, I thought it could be a plaque and tandem disease. But obviously it was a clot, so the clot migrated as soon as the flow was restored. And but thankfully in this case, we're able to open up the M1. And this highlights another point of endovascular, right? Because we were able to open up the M1 since we were there. The patient actually did well. It was minimal strokes, and you can see the post-op MRI, not much different. And he was discharged day 5.
Nima, would you consider in the first time around when you cross with the microcatheter to drop a stent retriever distally?
Great point.
And then do a thrombectomy first, because
Would you use that instead of the distal protection device?
Exactly, with a proximal protection, then use a balloon guide, right? And then do the so believe me, we had a discussion like this, and the criticism that I received for doing that is that, oh, you're crazy, you're going through a plaque and you're gonna just, but we're gonna stent that anyway. So I'm thinking maybe there's a benefit to trap the clot, whatever clot is in there, and give you the best chance to clear the lumen. Then you stent afterwards, but all under balloon guide. The only problem in this case, you have to inflate the balloon guide in the common, so you may lose the flow to the external. In this case, you're not getting external flow, but in some cases, that could be the only flow you're getting. So because you had a PCOM, allows you to inflate the balloon in the common without having ischemia while you're doing all that. Because it takes a little time to do the thrombectomy plus place the stent and all that.
Another interesting idea now that we have catheters like Route 92, right, with the 88, you could do dotting, right? Instead of using a balloon, you put a base camp and go through the stenosis with the 88. So now you're dotting the stenosis and you have a great suction tool right there to clean that carotid. And once you take out, sometimes if patient has a good profile, stent. If patient doesn't have a good profile, even avoid stenting. And that's another one that we don't have an answer yet. And there are probably 2 clinical trials coming, randomizing for stenting versus not. But it'll be interesting. I think it's a hard one. Nicely, those are red clots, respond well to thrombectomy with aspiration or stent retriever. So.
Thank you. So moving on, 35-year-old high blood pressure presented problem speaking, NIH 4, so this is now a low NIH. Patient was outside time window, and we do a imaging, and this is a lateral, this is a sagittal view, and you can see that there's a cutoff right there. So 35-year-old problem speaking, and that's the CTA.
Define probably speaking, because I have that and I don't think I need a thrombectomy right now.
All right, fine. That's a great point. And what I want to bring up is, at least in our practice, we deal with, we react based on disability. So for me, disability is very important. We're not accountant. The NHL4 may mean numbness, dysarthria, and facial droop, maybe with a little bit of not able to say the age. So that will give you 4, right? That to me may be not as disabling, but if somebody is having difficulty bringing the words out or understanding, that's a disabling condition. This patient had expressive aphasia. All right, somebody take a stab. What do you want to do now? Treatment. You guys heard about stroke treatment all morning. We have a 35-year-old. There's a problem. So what do you guys want to do? Good. This patient is a I'm sorry. So let's talk about.
Yeah, it's too distal. Sorry, it's too distal.
Sorry.
Yeah, no.
Can't do
But it's a MIVO trial though. But no, it's definitely a great case for the distal trial when we start enrolling on that. But I have to say, with this disability at 35, we probably would go after this. It's did he get? You said outside of the window TPA. Now the question is, I think it's a good discussion. How do you deal with this? We actually recently had a case with the aspiration through a 21 microcatheter, and you could try a 35 zoom or something like that, but I don't like so much stent retriever at this level, but it is possible to use. Of course, I do have only recommendations to bring your intermediate as close as possible to avoid stretching the anatomy too much. You really want to keep very little of that play between the stent retriever and the aspiration if you were to do that. But I have to say, we had some luck with corking with a small, even as small as a 21 catheter. So.
Thank you.
Ask one of our stroke neurology fellows here, not ours, UF Shan's with Dr. Scott Stillman and great team there. Roberta, what do you guys think? That this is a 35-year-old, your stroke neurology fellowship, what do you think? No TPA? Is this something that you could do a wake up stroke protocol? What do you think? You're happy, right?
Okay. I think we can all agree that it's 35 years old. I'm 37. I would like to think that's still a very young age, dominant hemisphere. I definitely would like to be more aggressive if we could. I would discuss this with the IR team and see if this is something they could potentially go after. If not, there's a couple of trials, the Extend trial, the Wake Up trial, that we could see if we could consider if they are a candidate, at least for TPA. But I would try to push to get some form of intervention on them.
Thank you. So why in NEMA you guys don't even bring Extend and Wake Up?
So this patient, I don't believe, was a wake up stroke. He was outside the time window. But no, that's
so. Can you refresh the crowd for Extend and for Wake Up? What are the time windows?
So Wake Up Stroke is a trial looking at. Actually, Roberto, you want to talk about? Actually, I won't put you on the spot. So the Wake Up Stroke was a trial looking at patients who wake up with symptoms and MRI. So if it's positive on DWI but not yet on the flare, the idea is that this could have happened within 4.5 hours of the patient waking up because it's not a flare yet. So the study basically looked at that population with TPA versus no TPA, and the patient actually who got TPA did benefit. And it was not safety profile wasn't that bad. Extend was the one that looked at perfusion, I believe up to 12 hours, if I'm not mistaken. And if there's a perfusion mismatch, they also benefited from TNK versus no thrombolytic. So basically, the idea is use imaging to give thrombolytics rather than salt and just time. We do, but I think there are challenges. So MRI, that's going to take forever. I think Dr. Day is here. I enrolled one, or I did one. How many have you done? Not enroll, I mean like do wake up. Go ahead.
Microphone, if not, the guys on transmission cannot hear you.
Oh, good. I've used MRI to try to help diagnose stroke, not necessarily a time window. And I've done it 6 times since I've started. And I would say 1 out of 6, I got the imaging in a half hour. The rest, it takes an hour. And I think to make this work, if we're going to triage MRI or for the later wake ups, is we need an MRI only for stroke. It's our MRI, not a Jaguar's knee MRI, not a back MRI, not a headache MRI, but a stroke MRI. Until then, we can't do it.
But I think perfusion could help, right, Dr. Chamsani?
I know. I mean, I was going to add to Jason. I've done 2 in the last 6 months. Wake up, one at north, one at south. I mean, the endovascular team don't hear about it, but because usually those patients that go for thrombectomy prefer thrombectomy. I know they prefer thrombectomy. With obviously is more efficacious treatment, so we go with that option. But when patient is not candidate for thrombectomy, we have to think outside the box. And I actually was very impressed at North. The only problem at North, you have MRI tech from 8 to 5, Monday to Friday. So you have to be lucky within that time window. Otherwise, on the weekend, you're not going to have any luck. Same thing at Clay. South is actually very good in terms of MRI capability.
So in this case, I think one thing that helps in this situation is perfusion for me. Even though I'm showing you a nice image, remember, we look at these on our phone and it's sometimes hard to see this blockage on the axial images. So I think perfusion, even though we now rely on it to exclude patient for proximal large vessel occlusion, in distal occlusion, I think perfusion is helpful. So anyway, so this is the patient's perfusion for the reason that everybody mentioned. This patient is young, disabling condition. So we decided to intervene. Here you can see the same view. The blockage is right here. And the system that I used in this setting was Aristotle 18. I like that. It's a little less traumatic, and Phenom 21 and Zoom 45 actually track very nicely. Here you can see that the microcatheter was here, the 18 wire was there, but just that I was able to get the Zoom 45 into the clot. As Demetrius brought up, I don't like to use stent retriever in this distal lesion as much as possible, because when you drag those, it can cause problem. So pure aspiration, and you can see that recanalized there. And thankfully, we have these tools that allow us to get these lesions.
Do you infuse Mirinone or any calcium channel blocker afterwards? Because you may get some spasm from that catheter manipulation. So it's not unreasonable sometimes in this case to have a mix of Mirinone or calcium channel blocker.
Can you do that after?
Yeah. Yeah.
Very good. All right. So we're at it. Yeah. Otherwise I wouldn't be presenting. I'm kidding. No, he's fine. He's talking. He wanted to go home right after that. And he kept it. Cardioembolic. He was 35 and he had a heart failure.
And just for completeness, right? There's an education activity. God forbid you perforate that vessel, right? So that is the downside, and that's why we need clinical trials, and that's one of my favorite things about ischemic stroke. We will have a clinical trial showing for this patient with medium-sized vessel what is the profile, because the profile for natural history of this is way less defined than what we have for large vessel occlusion. So I think we got to see how these patients do without intervention at 90 days, and how much morbidity we're going to add from trying to get. This case went great. What if didn't go well, and now you have a 35, right, 37-year-old female with a big hematoma because you perf an artery. So that's within an age of 4. So those are things that I think data will help us a lot.
And even there's another possibility there, which is that you have a partial recanalization, some spasm or distal embol. Now, when you stop, right, how many tries? So that's the other part of how much you push. So having the CTP in the room, that is an interesting thing, because you can actually reproduce with rapid or vis the same image you got before post-treatment on the table prior to get out. Because here, many times the ticket score is not really applicable to this. So I think that is interesting to have extra information of the distal circulation and the core while you're doing the case as time goes by.
Very good. Thank you. I think we're out of time. Any other questions, comments?
I think if you want, we can do one more, man, because we have time at the end because Raul couldn't make it, right? So we have two of the talks that will become one. If you want to show one, do you have one more case?
Yeah, I'm trying to figure out if,
Bilateral carotid
Right,
occlusion.
this one.
That's a good one.
sorry.
Yeah,
Okay,
that one.
there we go.
Yeah.
So this is a 54-year-old who presented with problem with balance for a few days, and then initially symptoms were mild, so resolved, but then worsened with right-sided plegia, difficulty speaking, and left gaze. Did receive IV TPA. Once the symptoms started, transferred to our facility, NIH high 22. After the patient presented, we did do a head CT. The head CT looked good. We do our protocol perfusion and CTA, and this was the perfusion. So let me see who I'm going to pick on. Dr. Hannah, you want to pick on someone? Tell us what they see.
Sophie in the room, I don't see the.
I think Sophie's working.
She's working. So
Any of the from Brazil? Anybody? What do you see? Thank you, Dr. Chemisani. Great point.
there's volunteering here.
Thankfully, the patient had pulse at that point.
You go, Chief.
But thank you.
You're it.
Thank you. So obviously there's a large perfusion deficit here. So I would like to see the CTA.
But it's a little unusual, right? So this is both hemispheres. So the question is
it real? Is this artifact?
Artifact, real, exactly. Is the patient's heart is pumping like Dr. Chemisani brought up? So what's going on? You know, for the CT perfusion, we do have these maps, sometimes helpful for you guys to look at where they pick the artery, where they pick the vein. That's the red and blue. But this was real. And the CTA did confirm that, I'm trying to remember if I have a picture of it, but the patient had bilateral carotid occlusions. Both MCA intracranially filling. So we're dealing with a bilateral carotid occlusion and patent intracranial vessels.
So bilateral carotid occlusion, what are you gonna do, Mike? Which carotid are you going after?
I'd like to look at the verts too. Like, what's the origin of the verts? You know, with PCOM, like, I think we need to understand his hemodynamic circulation.
There's a small PCOM filling both MCAs. Next.
Dr. Robinson is well trained for his boards. He's asking for more images.
You don't get a dedicated angiogram to decide what to do next.
Okay.
You have to make a decision.
And he was most symptomatic from, I believe it was the left hemisphere, right? Because he had right-sided weakness and.
Yeah, so right-sided plegia and left gaze.
Okay, so I needed to make a plan without seeing a CTA based on this information.
US or what? It's good. Don't be shy.
From acute bypass to acutely opening the carotid to
say bypass is Marcel here?
No, I think we need to acutely open his left carotid. Presuming that's what's down. But
so let's say I was on call.
This is not my case. It's his case. Yeah, but no, but my thought process when I saw this case after is exactly like yours. What's the symptomatic carotid, right? If this patient had a right carotid occlusion, it's very unlikely with a left carotid, you're going to have a right MCA syndrome. This is very unlikely. So in my opinion, so my thought process is exactly like yours. For me is an acute left carotid occlusion that is probably impairing both his hemispheres based on the perfusion, but acutely left because the left hemisphere is more symptomatic, as you said. So that was my thought process too. I don't know if it's right or wrong.
Yeah, so I think clinical information is very important, right? We're not just a technician, we're a clinician. So this patient had problem for a few days, so probably putting everything together, carotid, probably had disease, had TIA, but then he's presented with the right side is plegic and looking to the left. So he's trying to tell you that the left side of his brain is acutely became a problem. Otherwise, why would he wake up with one-sided plegia? So as Dr. Hanna brought up, we discussed this. I don't remember if it was the middle of the night, I think it was, but sometimes hard and like, okay, where are you gonna go? But symptomatic vessel was the, and by the way, just because CTA shows occluded vessel doesn't mean that it's occluded. There's about 10 to 15% time where CTA shows occlusion, you do an angiogram directly and it may not be occluded, be high grade. So angiogram did confirm bilateral carotid occlusion. A left carotid was the target because the patient did have a left MCS syndrome. This is a nice picture of the posterior circulation. So I did do a vert injection, Dr. Robinson, but you can see that there's not much filling both carotid. So he was probably feeling both hemisphere, mostly to that carotid that shut down all of a sudden. And you can see that and then I think we talked about this extensively. So I opened up the left carotid. You can see that it's cross feeling very nicely with the acute stenting, and he did well. Actually went home with an NH of 0 from 22. So I think I'll stop there.
I'm just gonna, again, Marcelo, present what happened if you don't have these resources. This is one, Marcelo, that a trauma endarterectomy would do the patient the same thing that a stent. I'm positive if you open this carotid and take the plaque out, the patient will do. The downside of that, as Nima pointed out, we have the luxury where we live that we can do this in a hybrid room, and then you open the carotid and inject contrast right there and you see if there's anything distal. When you do this in a regular OR, you just have to allow back bleeding and hope that there's no clot that stay behind, but it's totally a viable option to do a trauma endarterectomy. Both carotids are occluded anyway, so the patient doesn't have flow. In a desperate measure, that's definitely fair game.
Yeah, I think it.
Yeah, avoid hypotension.
Yeah, of course, endovascular would be always the first option. The previous case is, if by any chance you could not open the carotid, what would you do? Keep trying. That's a good
Or what was
answer.
the previous
How
case?
many times?
It's interesting. That is at one point you have to figure out.
Use a microphone, please. And could you repeat the question, please?
So if you cannot open endovascular in the first attempt, what you keep trying to do? So first answer was you keep trying the same strategy for, it's a time clock, trying to go against time too. I think in general, you have to establish in your head how much time you allow yourself. Are you going to do 10, 15 minutes, in trying the same technique? Sometimes you may have to change the axis. We have some ways to go direct carotid puncture, radial, femoral, if that's an issue, that's called. Sometimes it's just different equipment. So you have different wires, thicker wires, smaller wires, more support. So I think that it's definitely, you have a lot of options. I think the importance is not to stay too long with one same plan. You have to kind of go down the list of different options you have. There is a way to escalate that. The last resort is you can always, of course, go to surgery. That's an option too, if you can arrange that on time. But as you're waiting for OR team to come, not infrequently you could potentially consider go around the other side. And that's the technique. The rare times we've done going across ACOM is actually in a situation like this, you just couldn't get through it. And you just open a stent and let flow go across while you're trying to figure out the next step. And you could actually potentially go to the OR with a stent retriever open to allow flow to the MCA via the contralateral side if that was occluded. So that's a possibility. I do a mini, like a bypass or shunt while you're waiting for the OR.
Right, good. Yeah.
It's a hybrid approach. Something would you consider?
You want to tell us more about that, Gustavo?
I kind of regret now.
You asked for it.
Yeah. So I think the guys from Iowa had some experience. I think we had one case recently with Dr. Nima, and Dr. Hanna ended up getting involved. So basically it's a similar case. I don't remember exactly, but the patient had a carotid lesion. Carotid occlusion, was symptomatic, acute symptomatic. And unfortunately, they were not able to cross the lesion. So what they ended up doing is bring this patient, wasn't a hybrid OR, was in the IR. So they opened like a regular endarterectomy. They were able to open a carotid, get the wire, and push the wire through the plaque. I think.
So literally what we did, we opened the carotid, did an endarterectomy and helped Dr. Nima push the catheter on the other side of the occlusion, and then close the carotid, he stent everything in the way out. So it's just no, because TCAR, you're getting your cut is for access, right? So Nima, this was a common occlusion. So Nima tried to poke, and he was able to get all the way to the bifurcation, but not there. So it just opened there. The patient had some reconstitution of the internal from the external, so it was a common occlusion. So it just helped opening common to the internal, and once he got on the other side, just closed and dart and stent and got out of there. So it's just it's great to have both tools available.
All, or you were truly
No,
to
it
the
was a
lumen?
super hard calcified plaque.
I see.
Probably why.
All right, thank you, everyone.
So Dr. Nogueira had a family emergency, so we exchanged one Brazilian to another. And by no means I can replace Raul, but I'll give you guys a little tour de France of what's coming in terms of new gadgets and new tools for stroke intervention, and different degrees of data they're going to be collecting on these tools, from single arm registries to randomized trials. This is naturally teamwork, and it does take a village, and I'm really proud of mine and ours. I think it's phenomenal to be able to do what we do. There is tons of data to support what we're doing, and it's great to see a lot of groups represented here that are doing this all over the city, the country, and the world. There's tons of data. So if you open the vessel, or as our Canadian friend, Dr. Hugh, like to say, GTFO, get the beep, 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 vessel open. It works. It works on the early window, and Tudor had to step out, but this is the work of Tudor and Raul that we're proud of being part of that. On Dawn said up to 24 hours, and naturally 24 hours is just a suggestion. If there's no stroke on the CT, you have a large vessel occlusion, it can be 36, it can be 48, it doesn't matter. If you open the vessel, the brain will follow with less data. With that, stroke had turned into a interventional surgical entity. And it's great to see Marcelo and Luca and others thinking about how can we integrate microsurgery into that. And the cost of all this is a very complex situation. But for the United States, as you guys see here, we're talking about up to 300,000. If you think about the number one disease before this event, 2015 and on, so it's very new for us, right? This is a 7-year episode in healthcare, human healthcare. This is very young. It's a 7-year history here. This will continue to grow, and we see this on our sites, and we see this all over the world, that this continues to. And now we're going through smaller vessels or mid-sized vessels and so forth and so on. So if you look here, and that's very important not to keep that, not lose that perspective. When we say, oh, you have up to 24 hours, it doesn't mean that you're going to sit down and relax. Oh, I have up to 24 hours. So that's a little misconception that can come from that, is the quicker you open the vessel, that's the slide here from Jeff Saver. And this analysis, the quicker you open the vessel, the better for the patient. Yes, you have up to 24 hours with level 1 data, but the quicker, the better. And here is his famous slide. I love to quote this to my patients, and I focus on the aging. A stroke, your brain is fast forwarding a couple of years, and don't be too hard on yourself, because you just aged 10 years or you just aged 30 years, depending on the size of your stroke. There's so many fronts that we're trying to get better, and you heard already all day long from all the speakers where we're going. So I'm going to skip through those that were talk already. I'm going to focus in a couple of different ones. Dimitrios talk about that. On the bottom here, I think that's Cerebrotech. I don't think that's even alive anymore, but there's another company that I'm blanking on the name right now. What Tudor mentioned to you guys, trying to detect blood on the head before the patient hits the emergency room. A CAT scan on an ambulance or on a helicopter is a great idea, but it's a very expensive. We thought about that when Eric and I joined Baptist. It's $1 million a year proposition. $750 just to buy the machine, but to keep that operation and running, it's a very expensive proposition. It has to make sense financially to the city and to the region. What is super cool that is going on is this type of detection trying to happen with mind rhythm. What I think is super nice, and Dimitrios gave me this one, is an app that is going to try to detect the stroke. So you have grandma that is smiling a little different. Maybe instead of all you do and teach Cincinnati, everybody can learn that, right? We all try to educate people about that. Maybe there'll be an app for that. You just put a little iPhone or Android, whatever you carry on your pocket in front of grandma smile, and the app will keep doing that for you. And the app will say, okay, this is a Cincinnati 3 Lambs 5, take grandma to the IR or dial 911. This is Viz. We're just starting our journey with them. There are other products available. It does allow for very nice integration between about what we do for stroke and allows for communication. Started with ischemic stroke, and you see this. It is super cool that we can be sitting here. Dr. Nima is on call. He can get this. He doesn't have to fire his computer. He can immediately, it's just like have a PACS in your pocket. You can look at a CTA with a lot of details. And our tele group with Dr. Chimai Son and others take a lot of advantage of that and help a lot of people from being very quickly available and connected to this through Viz and through Rapid. But they're not stopping there. There is aneurysm detection. It was super interesting to talk to the Viz team and hear what's going on with aneurysm. For example, if you upload all your previous CT angiograms from the last year, and let's say this hospital had 29 aneurysms diagnosed on the last year, when they ran all the CTAs through a Viz algorithm, they found another 25 aneurysms that were missed by radiology, up to 9 millimeters in size. So the machine is agnostic, and it doesn't get offended to say, oh, you missed that, you missed that. It's just going to be just reading that and say, okay, I think there's an aneurysm here. So I think that's going to help a lot. Another cool one is pulmonary embolism. They're already running that. We're using that for our subdural hematoma trial. As you guys saw, Dr. Rice showing that yesterday. One that I was supposed to talk to you, and that's the reason we moved the talk here. We had this discussion yesterday, and I know many of you could not be there because it was a long day for everybody. But with our EMS symposium that Wendy and Dr. Nima and Brad Elias put together, we talk about this. We are on the verge of trying to or considering evaluating, assessing the value of changing the process on the systems of care in stroke. If you think about, if I out of a sudden here, I'm going to tell you guys, I have a bad chest pain here on my left side, is pressure is going to my jaw. You guys are going to dial 911. The ambulance is going to park here. They're going to do a 12 lead EKG on the back of the truck. And I'm not going to go to whatever Mayo ER, Baptist Beach. I don't know what is the closest here. I'm going to go straight to the cath lab. I'm not going to go get a CTA when I get there to see, did this guy have a coronary occlusion or not? Let's try, let's decide. No, you're going to go straight to a puncture, radial or a femoral. And why we're thinking about that, you saw here over and over and over today, when we start this, and Eric and I brought this to Baptist, where Rapid that we used back then was our big brother. We had a group of neurologists that was growing. we're trying to implement intervention. We rely a lot on CT perfusion. That was the field back then that we taught CT perfusion maybe, and Dawn, as you remember, was purely CT perfusion based, and we were part of that. And there were a lot of other clinical trials that were driving that on CT perfusion. So till 2016, we taught, okay, we are driving the intervention based on CT perfusion. But this has changed significantly. I would say 180 from that. Aspects is queen or king. Aspects dominates today our decision up to 24 hours, where Dawn and diffuse rely on diffuse to rely on MRI or CT perfusion. There are tons of data supporting that. If you have a good aspects, if you open the vessel up to 24 hours, the results on the late window are as good as. So good aspects. What about bad aspects? Maybe patients with aspects of 6 or higher, they benefit. So we just start getting more and more inclusive to the point that if the patient doesn't have a horrendous stroke, and Tudor talk about in extremis, they are randomizing patients with an aspect of 0. All those points are gone. And they're going to randomize for intervention or not to see if it makes sense to treat these patients. So we can detect that on our flat panel CT that we have on every single of our cath labs here. We have luxury in our country here in the West that we can do a CAT scan on the table. The more you image these patients, so if you stop at the R to do a CT, Dr. Nima showed these numbers yesterday. What is the number, Nima, for Baptist? Door to CT?
15 minutes.
15?
1-5.
Yeah, so you invest 15 minutes to get a CT, and the more imaging you add, the more time you invest, to the point that if you're gonna do a CTA and a CTP, you're probably talking about 30 to 40 minutes of investment for all that to be processed in a system that does a lot. 253 on the last 12 months to be precise in terms of thrombectomy. If you had MRI for wake-up protocol and others, in France, the whole country runs on MRI, so they're better than we are. But if we add MRI, it does delay even more. So the more you image, the more you delay. Nima put this together. When we arrived, we put rapid all over our hospitals, and we have a different profile. If the patient comes straight to the mothership, you see the number there, takes on average back then in 2015, 17, when Nima published that, you see that the number that is 48 minutes. So if this patient comes from an outside facility and land or drive to the hospital, you see that the number is 12 minutes. So that tells you exactly how much time this process takes, because the patients are coming to the hospital anyway. So if you bypass the emergency room and bypass the imaging that you invest in assessing this patient, naturally, there'll be the medical assessment of this person that you're going to invest a couple of minutes, but you save right here 30 plus minutes of that intervention. These guys did that first. Naturally, that study is not direct to the cath lab, direct to the cath lab for patients that already got standard imaging, but that show a 30 plus minute difference. Dr. Mark Riba, their dear colleague from Barcelona, and their team in Spain, they have a very organized system in Catalonia. They did this randomized trial where they randomized the patient to go through a standard imaging process versus go straight to the cath lab, get a CT on the table to see if this patient has a hemorrhage or not, and go intervene or not. So here is the direct to angio or a direct to CT. And those are the results of their study. You see here they enrolled 174 patients, and you see exclusions there, end up with this 73, 74 patients on either group. And you see here a significant difference in the modifying ranking scale for the group that went straight to the angio suite. And that's a lot here. I'm going to skip for that for sake of time, but that's significant difference in time. You saw on Nima's paper a 12 to 42. This is an 18 to 42. And you see here, the door to reperfusion, you save about 30 minutes. That's expected, right? Because that's the time that you would invest to do all the imaging that we typically do, namely CT, CTA plus minus CT perfusion. So the Catalonia study, Mark Ribos' paper, is driving two protocols, one that we adapt, waiting for the FDA to give us clearance to be part of this call. We trust, where Mark Ribos and Raul Nogueira are the international PIs. The idea is to randomize patients. So EMS is calling, I have a patient with a LEMS of 5, I'm coming to our emergency room. The idea is 8 to 5, working hours, Dr. Day is on call, they're gonna call Dr. Day here, this patient is coming, this patient is a we trust candidate. Talk to the family, are you okay with us doing randomization? So you start seeing that it's not easy to make that happen in a clinical research environment, because you got to get a hold of the family. You got to call the cath lab. Are the machines available? Oh, Dr. Nima has a patient in room 6. Dr. Hanno has a patient in room 7. So a machine has to be available for that to happen. And then you think about randomizing and bypassing. That's going to happen, is happening. This randomization is already ongoing. And we're about to embark on that, doing for these patients that go direct to angio, a cone beam CT on the table. And that's we trust, plan to enroll 564 patients. We know it's going to be a slow enrollment because of all the logistics, and it's going to be only early window with a high NIH of 10 or above. So we're talking about large stroke, easy to detect, try to bypass these images. Dimitrios alluded to that earlier. That they are working with Siemens on that, where with the Siemens machine, they can do a CT perfusion type of picture on the table and have that analyzed. So we trust is a Philips machine study. This is a Siemens machine study. I'm gonna skip this. Tudor talk about this, Matt talk about that. So I'm just gonna, this is just to quote Matt Hill there. GTFVO, so you can read that. I'm going to skip for that. This is the one that Tudor didn't have a chance to address. We are enrolling on that with Italo Linfante from Miami, trying to use this molecule that there's oxygen delivery at much higher concentrations than our hemoglobin can carry. So this is an attempt to give time for us to open that. And this is a phase 1 study. This is not randomized or just giving a drug and see how the patients behave. This is a case from Italo Linfante. You see here an M1 occlusion, good profile on the CT. He opened the vessel and the patient did extremely well. So there's a lot coming as Tudor told you guys, and I'm going to skip that. It's funny, just anecdotally, the medication looks like blood. So you have to educate your team. This is not a blood product because it's red and it looks like you're giving the patients something like that. And that naturally there's implications. What we learned that this molecule does interfere with your PTT, and Italy is going to present that at ISC. You see these patients artificially with a elongated, and our team here, critical care team, I'm blanking which one, maybe it was Dr. Morada, if I'm not mistaken, is the first to say, okay, this patient PTT is elongated. So that triggered an investigation. That was a very common finding. We know hemorrhagic complications, just the method of measuring a PTT that gets interference from the molecule. This is just one slide. Dimitrios talked about this beautifully about robotics. Adnan Siddiqui did this nice mapping of access, and that may make sense for robotics, and I'm not going to go back to that discussion, so I'm just going to skip through that. But I'm going to cover here just a couple of different tools because there is a lot. Every time you open your eyes, there's a new aspiration catheter, a new thrombectomy, or a new balloon guide, and you see here the plethora of companies that are trying to get to this market, because in the US, this is growing at a 5 to 10%. In China, this is growing at 30% rate. So naturally, when there's money, there are people that want to be part of that. New stent retrievers. We just finished a study with this guy here that is called the NIVA stent retriever. The idea is to have rolled to have holes on the stent retriever. So when you're pulling the clot can get trapped on that instead of escape the stent retriever. And that's going to be boring because I cannot control the video from here, but you see just the thought process there. And that's not NIVA, this is Tiger, where you can control the opening of that. As a company, Israeli now, Chinese, that you can massage the clot and open. They come in different sizes, so you can go in the smaller vessels with their Tiger 13. We're part, again, this was a single arm study. We did enroll patients at Baptist and show nice outcomes. Again, single arm. You can make a single arm study look really good. Sometimes not what we want. I think we are at the phase that we should be comparing this device head to head to have a clear idea if one is better than the other. I don't think it does any good for us to have 13 different stent retrievers on the shelf for many different reasons. New aspiration catheters. Again, we were part of Compass showing that these procedures are kind of equivalent, aspiration and stent retriever. Does size matter? Absolutely. I think you saw Matt Gunas and Matt, Raul, and Adnan Siddiqui did a great job in simulating these interventions, showing that the bigger these aspiration catheters, the higher the odds of this clot ingestion and avoid. Matt showed beautifully today, trying to pull a clot from the head, the tail broke and went upstream. So if you don't stabilize the clot that we believe that the stent retriever does, these clots can fly away. I'm glad the cap was there. So this is the evolution. This is a Quill Turk paper just showing the penumbra catheters evolution from the 41 to the A68. Now we are at 88. And there's a Minneapolis company come with a 96. So it seems like the sky is the limit. How big can you get? And these catheters just keep getting better and better. So a lot of aspiration catheters from the 0.70 and around. And you see many of them represented. You have catheters on the stick like the Mivi that Dimitrios illustrated earlier and the Route 92 that Matt illustrated, and I show you here in a second. And there's a whole race of people trying to develop 88 catheters and funnel type of catheters. This is Route 92. We enroll a couple of patients there, randomizing this system against Stryker Vecta 74 for aspiration for large vessel occlusion. It is a system with a guide, long sheath, a catheter on a stick that I call high point, and a super nice, slippery, lubricious dilator that I call the Tenzing. And with that, you can push this all the way. And here's a case from a video from Matt Gunas and Ajit Puri. You see that snake navigating all the way to the siphon of the carotid. Can you play that again on the left side? So you see here the case from Ajit that he's pushing the 88 on the M1, and on the left, your right of the screen, you're seeing the model just showing how well this navigates, and it works very well and makes for procedures really, really quick for aspiration with a nice ingestion of clot. And you see here another one. You see here on the lateral how that navigates without a wire. So you're going Cobra, you're going without a wire, just pushing the Tenzing, and this navigates really well and get where it needs to go. This is another case from Ajit, has beautiful recording of this. And he puts, I'm gonna skip this for sake of time. We showed that earlier. This is just a M1 occlusion. And here you see single aspiration, 7 minutes from groin to M1 reopening. Can you play this video, please? Okay, never mind, it's playing now. So we knew that this was there on the CTP, and it would just have the same stroke that was already established there. Ajit and interventions like to put fancy names in things that they do. He called this the slick technique, and he put together our series. And my mission with our research fellows that Eric and Nima's names were not on this paper. They deserve to be there and they should be there. They work on the patients. The Q catheter, this is MIVI. Dimitri showed that earlier. I'm not going to go to that again. Similar concept. We published this with David Combs and Alex Bernstein, showing that if you think about the way flow works and your aspiration works, is R to the fourth. So depending on the length of your tube and diameter of your tube, you're going to get your aspiration power. What happened with a lot of these catheters, for example, if you have a 0.70 catheter, this catheter is 0.70 from here to the outside of the groin. What happened with Route 92 and MIVI, you cut the tube. So your 70 or your 88 tube is very short. And once you connect on the big catheter, you have a much bigger inner lumen, inner diameter, and you're going to aspirate with a higher aspiration power. And we show that in the smaller the catheter, you see the difference here with the 3 max to the so this makes a lot of sense for smaller vessels and smaller catheters. You see it's 250% more aspiration power on a 3 max compared to a on a Q3 compared to the 3 max. This is a distal embolic, quote unquote. It's called the DAISY. Sorry. It's called the DAISY. This is essentially a little ball of polyethylene that you can go beyond the clot and open. So the clot cannot break loose and go upstream, and they are about to finish their clinical trial. This is another aspiration catheter family called Zoom. They also have an 88. So this patient has an M1 occlusion. And you see here that with okay collateral. So we're going through the groin with a Zoom 88 and Zoom 71 together. Zoom 88 could not go beyond the siphon. We pushed the 71 on the M1 and reopen the vessel. This is a funnel catheter that I told you about. This idea from a guy named Mark Rebo again. What about if you don't do a balloon here? What about if you put a stent-like structure that is not deployable and you arrest flow when you're pulling the clot inside? So I told you about funny names. This is called Anaconda. And here is Dr. Rebo's Anaconda that should be coming. Tudor, do you know when they're going to start trial with that?
They completed the trial in
Europe, yeah.
Going to go for FDA approval now.
Without
but,
US trial?
Yeah, I mean, of course, that's the strategy, but they finished in Europe. The results are pretty good. They're just published recently. But to me, the initial...
So that's the Anaconda there.
The initial intent was to put that in the MCA, and it turned out to be very difficult. Hard. So now that it's, and it was intended to be used as an aspiration device. And now you kind of have to stop before the MCA. And to me, this is going to be now a balloon guide catheter, right? Yeah. A gentler balloon guide catheter. Yeah, I think that's going to be the application for it. But it turns out that if you aspirate even from proximal with this, you get decent results, but you have to use a stent reaver.
Yeah, thank you, Tudor. So this is another one that is called Ceretrieve, similar concept, new balloon guide catheters, and I'm going to expedite here. I don't know how we're doing with time, but you got the picture. There's a lot coming. This is an 87. There's a 94 balloon that just got approved, and it can fit the Vecta 74 inside the 94 in Neuroco balloon. Tons of data. Adnan Siddiqui is starting a randomized trial for balloon guide catheter versus no balloon guide catheter because there's no level 1 data. But when you look at the data, there's an overwhelming data showing that if you have a balloon guide, the patients would do better. Again, you just saw this case. I'm not going to show you again. That's a nice in extremis case in honor of Dr. Job. No, I'm kidding. This is an extreme size clot. You see there's a worm. You saw that earlier. I'm going to skip that. We got excited with funny things when you're interventionalist. A large clot. I'm just going to skip this. This is just more thrombectomy showing balloon guide. This is a cool one. We did the first head-to-head comparison with in the modern literature with Raul Nogueira and the team, 50 centers all over the world, randomizing patients to Solitaire versus a German company / Chinese company named Phenox with their stent retriever called Preset that was designed by the same guys that designed Solitaire. So we're going to be presenting the results of that at ISC next year. But that's our goal, right? This is a true ticket tree. You see the MRI of this person. There's no DWI hit on the MRI. That's what we want to accomplish. We got lucky on that.
So what do you call that? What's the patient's diagnosis? No, seriously. I mean, we proposed the term reversed ischemic attack because it's not a stroke because you have no proof of damage.
Good point.
It's not a TIA because that's spontaneous, but no journal has bought the concept. So we abandoned it. We had described a couple of patients like that.
So if you,
In Brazil, we call that a miracle. That's like, you're just like.
That's what Robert would say. He's a miracle. But I think that's interesting what Dr. Jovin is saying, right? This patient came with a stroke syndrome, but you do an MRI post-op, there's no stroke. So do you tell this patient he had a stroke or not? That's an
So the
interesting
first version was aborted stroke. Then we said it's a too political of a term. And then we said reversed ischemic attack. But maybe we can add more cases. And
I have two guys that are eager to learn that, eager to write that and add cases and get that resubmitted. What is not on the guidelines, we talk a lot about that. Pediatric patients, we are collaborating with the Stroke Net in a trial on that. We know about Endolo. Tutor is already running a trial on bad aspects, and I put 0 here in your honor, Tutor. In Extremes is the only one that is adding 0. The others, like Select 2, that just got completed, among others, are going for aspects 6 and lower. What about Beyond 24? Tudor and Raul in China already answered the posterior circulation. Not about MIVO, we're about to embark on that. What about tendon occlusions? There's a lot of data coming, and I think that's super cool that we can rely on that to make our clinical decisions on data. That I think is very, very reassuring for us and for our patients. So this is what is coming, and I think there's much more. For sure, the only constant that is changing, this is evolving. There's a lot that is coming, and what is the nicest part is on the best interest of the patient, and we see a lot of patients going back to normal function. As Nima showed yesterday on his video, that's true Lazarus effect. You see somebody plegic and aphasic, and all of a sudden, oops, she's back to normal life. I think that's very inspiring to get all of us in this room. With that, I'll stop, and then we can discuss any of these gazillion topics that we touch superficially upon. Thank you.
Thank you. Very exciting. Any questions for Dr. Hanel? Don't be shy. You guys can ask any question you want, whether or not you're related or not.
Ricardo.
Yeah. Yes.
It's Marcos Rota from Brazil. How are you?
Hey, Marcos, tudo bom?
Tudo bem.
How you doing, man?
Fine, and you?
Great. Thank you for following us there on Neurosurgical TV.
Yeah, very nice presentations. So I would like to make a comment on your presentation. If you accomplish to prove that the direct to puncture is better, I think in Brazil it's going to be a huge difference, because here when the patient goes to another hospital that is not a stroke center, he will lose the therapy, will not be transferred. It's not only 30 minutes. It's not going to be treated. So that's going to be a huge difference here. You know that, don't you?
I think direct to angio is not going to be something that is going to be applied, Marcus, in every single place. I think you got to adapt that to your local reality. In some places, it's going to make sense. In some places, it won't. It is very hard in our country. And Brazil is a bit similar to the US on the sense that there is a huge competition. So if you look at São Paulo and Marcus works, it depends depending where you are, there will be areas with 5 comprehensive centers within 3 miles. So where this patient is going, different than Canada, Portugal, France, Germany, where these are centralized, and these patients are going, the mothership where these patients will go, it's different. So I think we have to learn, and at least, as Tudor said, to be level 1, you got to do 2 clinical trials. We're working on a bigger one outside of Catalonia. And then we have to see where it makes sense. Another point to just segue in, and Tudor is a big fan of the topic and an expert. I'm going to pass the microphone to him and he will answer with us, is systems of care. Is Dr. Nima going to sleep at the hospital waiting for a stroke patient to arrive? Are you going to run this from an 8 to 5 and then it will stop? What about the IR techs? We have the luxury of having 2 of our techs staying 3 to 11. So we are doing this in a version up to 11 p.m. that we know if you measure, that's higher chance of getting a stroke hit. But there's a lot that is going to have to adapt. So this is, I think, is a very, very preliminary idea. We have to run this and see how that's going to go. But from the timing perspective of intervention, it makes perfect sense. We save 30 minutes easily if you bypass all the imaging.
So okay, you made a great point, because, and I can tell you, I come from a country that is not as sophisticated in terms of medical infrastructure as here or Western Europe. I come from Romania, and I think centers there, I imagine, maybe I don't know, are similar to Brazil. And I think that in places like, these countries, the direct to angio approach makes even more sense. Why? Because the CT infrastructure is not as good, so that takes even more time. That's what the guys in Romania tell me. A CT,
yes,
it's a lot more.
That's what I was talking about.
And the angiogram is because the cost in the US has a lot to do with human work. So the salaries are higher and in the US and lower in these countries, the cost per angiogram is much lower. So it makes even more sense to go directly to angio over there. And then finally, a lot of people, when I tell them about this direct to angio, how much sense it makes and so on and so forth, they're saying, well, yeah, but you can't afford it. It's not cost effective. And that's not true. Even here in the US, if you think about it, if you have 100 patients with an NIH of 10, 85 will have a large vessel occlusion. They need to be treated, right? So if you take them directly to angio, you save the 100 CTAs and 100 CTs, and you do only 15 useless, if you want, or futile angiograms, right? So if you put one verse and you reperfuse the brain in 85 patients 30 minutes earlier, which also translates into healthcare cost, I think that you come out more costly with a direct to angio approach. The only problem is we need more angio suites, we need more techs, we need more, but even the additional workload is not that high because you're only doing 15 cases out of 100 additional, and the rest you just treat in the patients that you would treat anyway faster.
But the only thing, right, Tudor, if the system today is patient hits the ER, goes straight to the cath lab, you have to be there, right? Because we all, quote unquote, take advantage, right? This is parallel processing everything that we do. So a patient is going for a CT, okay, pre-notification. When Nima came, we start doing that. We saw the numbers and everything that we did became quicker because of that. But we have to dislocate. If this is 9 p.m., I'm here, I have 25 minutes to drive to where to where I am. So there's a whole adaptation of the system. So we're not going to need 3. We're going to need 7 stroke interventionalists. So it's a process.
Yeah. So Marcus, that's the question I had for you, Demetrius here. So the cath labs, the cardiac cath labs in your hospital today, how they operate, is that direct to angio, or how that works there for cardiology?
It's for me, the question?
Yes, yes.
The cardiology is direct to angio.
Yeah. So you have
we should do the same.
Yeah, you have some infrastructure already. So that's the answer.
The reality that you mentioned about Romania, I was in the Philippines with Dr. Aldana and his foundation in June. That's exactly the reality. There is much easier for Dr. Powicks to take a patient from the ER to the cath lab, to the angio suite. They have a Siemens. They don't have CT, CTA readily available. So it's easier for them, and they do that for aneurysms very often. They do the CT on the table and do the angiogram without doing a CTA. So every country, every region is going to have their own reality. So,
Ricardo, what I meant is that we should inject this culture in the emergency treatment. So the patient goes directly to the stroke care system, not in some hospitals that are not prepared to treat it.
no, absolutely. We had this discussion when Eric and I started. We take a patient to a hospital in 7 minutes. It's not a patient to a hospital. It's the right patient to the right place the first time. Every time you stop in our region, if we stop at the wrong place, you're burning easily 2 hours. And that's, I think, is a conservative number. So you're spot on. It's an endless task, Marcus. We changed the rule in the state of Florida through SNIS and Get Ahead of Stroke. A LAMS, Dr. Elias addressed this yesterday. There's a law in the state of Florida. You have to go to the closest comprehensive stroke center. That helps. So I think you guys got to do something on the same direction in Brazil. You guys are doing great there.
Thank you.
One problem with using the cardiology as an example is they have a biomarker test or a physiologic test with an EKG, and they can select the left mains from their EKG. We don't have that luxury. Well, true. Yeah, you said if it's 10 or greater, it's going to be 80%.
No, you're going to find hammers, and there'll be a 20-25%. That's what Mark Rebo found. I think it's 23 on the paper, if I'm not mistaken, on the Catalonia study. So there'll be 1 in 5 that you don't find anything or found a bleed or so forth and so on. And it does put a stress on the system. So it is a change.
But in cardiology, the same too, that you do have, right? So I think that this is going to be, I don't think we're too far from even their chance of having false positives, false negatives.
Ricardo, it's Matt Gunas. Can I ask you a question?
Hey, Matt.
I'm just curious, if you go along with the model that you're suggesting, how do you solve the workforce problem? So there's going to be lots and lots of thrombectomies. Aneurysms are stable, if not going down. How do you keep a sufficient workforce that's trained to do all of these procedures?
As I said, is a process, right? I don't think this is something that so we have 3 people that share call with a very appreciative help of a 4th guy that is coming out once a month. I'm not getting younger. Nima is still really young. Eric, I'm gonna let him speak for himself. But again, it would be, if this today somebody said, okay, you're gonna start doing this tomorrow, I may be reconsidering what I'm doing with my life. But if you have give time, we can accommodate, man. And I think this is, again, this could never miss the point that this is about the patient. It's not about me. It's not about, so.
You mentioned Mark Rebo. What do you think of that model? I mean, Mark is fantastic. He's a good friend, but he only does stroke. He doesn't do aneurysm. So what about thrombectomy trained specialists?
So I think we would need, I think we need to rethink. I wish we could do this instead of having 4 comprehensive centers, if we have 2 with 6 people in each one of them, probably today we could even do that. So there's no shortage of people getting trained. We have a lot of young, brilliant people getting trained. I think it's just a matter of saying, okay, we need more people and establish the process on that. Tudor and Eric can try to grab the microphone here. I'm just holding from them. So here's Tudor.
I mean, listen, very briefly, that's why I was so, you're absolutely right. The clear need in this field is for elective procedures, right? Because then we can hire also more people and have them do cases during the day, not only at night. And so that's why, for instance, I was so excited by Tom Oxley's presentation, because if you start doing stents for epilepsy monitoring or Parkinson's disease, then I'm not worried about your concerns. But absolutely, right now, we don't have. That's imperative for our field to find elective procedure. The endovascular shunts, chemo, tumor embolizations. I mean, we need to go beyond just acute stroke and emergent cases.
Tudor, I completely agree with you. I think we need to expand the field into other disease states. I think that's a very important point.
So 2 points. One, to get back to direct angio, I think it's interesting because it opened the door as well for hemorrhagic disease, because then you have patient in the angio suite and you have hemorrhage. Why don't inject something intra-arterial and start, attempting something to decrease the risk of expansion of hemorrhage? To get back to the manpower, and I mean, the truth is that I have a bias. I'm originally, I was born in a wonderful country north of here. A system like Canada is doing way better as far as, process and organization for treatment of those diseases. And if you look in the United States, I mean, for trauma, what happened should, I think it would be fantastic if we could reverse engineer what happened in stroke and have really dedicated center. And there's too many in many places. You go in South Florida, I mean, there's a comprehensive stroke center every place you turn around, and it is not in many community for the greater good of the patient, because having more center that do still a small amount of patient, it's not helpful. Those systems are not well oiled. Those processes are not well oiled. So I'm always have a mixed reaction when I hear there's not enough trainees. The truth is that there's probably enough trainees. There's just a poor organization. And I think it's important as well to change the way we look at this. For example, if we accept that is the right thing to do and you need people in the hospital, that's the health system as well to accept that, you have somebody who sleep in the hospital that does not, generate much revenue as per what they're looking into. But obviously that's the greatest thing for the patient. So everything needs to be also modified accordingly. And that's obviously a challenge as well. While more and more healthcare system are absolutely not driven by physician, but from administrator.
Eric, it's an excellent point. And by the way, Boston's a great example, right? There's probably 10 hospitals within a 5-mile radius, all thrombectomy centers. And wouldn't it make sense to coordinate so that, you could rotate through the hospitals? But of course, that's not being done.
Thank you very much. Great discussion.
Thank you again. Thank you again, Tudor, for joining us. Safe travels. It's impressive, Matt, to see that you're there all day long with us. It's hats off.
Hey, brother, I'm just sorry I'm not there in person.
We put you down already for next. We'll send you the date next week. Our next speaker needs no introduction. Dr. Nima is going to talk to us about TNK versus TPA for acute ischemic stroke.
All right. Hello again. Thank you for staying here this afternoon. Great conference, exciting talks. I'm going to talk about TPA and TNK in 15 minutes. That's the time I have. And we have a break. And after that, we have a very exciting talk on pediatric stroke. So stay there. And then we have cocktail hour. So I was selected to give this talk, although I am very interested in this topic. I don't have any disclosure, but I do have to thank Dr. Caitlin D'Souza because she helped me with some of these slides, or I stole her or took her slides with her permission. So as you know, stroke happens because you have a clot that goes up to the brain. So that's the embolic stroke, or you have atherosclerotic disease from artery to artery. But it's all about this thrombus and clot. And the thrombus clot forms because we have the clotting cascade, which cross-link the fibrin. And then we have the platelet-rich platelet that aggravates and causes clot. So these are the two pathways that we have that cause this problem. So depending on the etiology, obviously we try to prevent it from forming by using antiplatelet or anticoagulant. But if it does form, then what do we do? Well, there is the way the TPA works is it activates plasminogen to plasmin, and plasmin cuts off fibrin and degrades fibrin, so then dissolves the clot. So the good thing about this is if you don't have clot, if you give TPA to normal people, it shouldn't really cause any problem, right? So it works by activating plasmin to degrade, to get rid of fibrin. So that's the thing about TPA. Now, the dose, you give it 0.9 mg per kg, you give 10% as a bolus, and then you give the remaining over 1 hour. And I'm going to talk about this a little more, but think about it. So we have nurses here, we have APPs. I mean, dealing with the drip and hanging stuff, I mean, that's time consuming. And then you have to take the patient to different places. So for 1 hour, you have to infuse this product. Obviously, there's a cost associated with it, but we do have prominent trials showing there's a benefit. So IV TPA within 3 hours is standard of care, FDA approved, up to 4.5 hours is what we give it. And INDS was the trial that basically started showing benefit of TPA, and TPA became FDA approved in 1996. This was an interesting new trial that showed, yes, IV TPA, especially within the first 3 hours, has a very, very good fragility index. And I like to think of Dr. Naval whenever I talk about fragility index because he gets very excited about this. But the bottom line of this slide is, nowadays with the trials, we know that the TPA trials are very effective. All right. By the way, TPA is time dependent. So sooner you give it, better it works. So number needed to treat, you can see that improves sooner you give it, especially within the first 90 minutes. So how about TNK? What is TNK? Well, TNK is connector place. It's a recombinant TPA. So basically 3 sites of the TPA was changed and it became TPA. It's used in STEMI. So actually it is standard in STEMI. There are trials and it is available. So why the appeal? Why do people start talking about TNK versus TPA? Well, it's supposed to have increased fibrin specificity and maybe longer acting and can be given as a 5-minute bolus. That for me is the attractive part of TNK. Like we talked about, giving the bolus, hanging it over an hour, TPA can be problematic, right? Where you can just push a drug within 5 minutes and then you're done. You don't have to worry about dealing with the drip. So that's the appeal. But what is the evidence? Well, by the way, going back to the appeal, I talked about the time, half-life, but there are also a cost. So TNK may be cheaper. So what's the evidence in stroke? Well, that's where it gets messy. I was looking at these trials, to be honest, my head starts spinning. There are many trials, no solid phase 3 randomized trial head-to-head. So what do we have? Our summary of many trials. So in 2010, basically, we tried to figure out the dose of the TNK. We found out that 0.4 milligram may be increased risk of hemorrhage. So let's not use that dose. Then in 2012, Australia found that actually TPA maybe opens up the blood vessel a little bit better than TPA. Then we have other trials in 2015, 2017, which did randomize, but the smaller numbers, they stopped early. and none of them show superiority of one versus the other. Extend IA was an interesting trial because it's a trial that actually looked at TNK in large vessel occlusion. And it did find that when you give 0.25 milligram per kg of TNK versus TPA, actually more patients with LVO have recanalization, meaning that TNK may be better at opening up the large vessel occlusion compared to TPA. And basically these are the results of Extend IA. And the meta-analysis of TNK versus TPA in 2019 again showed no inferiority. So I think at this point we know that even though we don't have level 1 evidence, but I think we have not proven one is better than the other. And this pooled baseline analysis showed the dose, perhaps a 0.25 is a dose that we need to use. And again, non-inferiority is what we've seen. There was a recent trial in 2022 in Canada, which looked at TPA versus TNK within 4.5 hours. It was a randomized trial. And the rate of good outcome, again, surprisingly, in TNK was 36.9, in TPA was 34.8, meaning not significantly different. And rate of hemorrhage, pretty same. So bottom line, I keep showing you the evidence, or at least I kept looking at the trials, and I see that, okay, doesn't look to be much different between the two. So interpretation of this trial was, it is a reasonable alternative to TPA, all patients who present with acute ischemic stroke who meet the criteria. And there are obviously ongoing trials, so we're going to learn about them. One of these trials, Timeless, is the one that actually we are involved, and I hope that we can at least enroll one more patient. Basically, we're giving TNK within 24 hours based on imaging in a large vessel occlusion. So here is the question, and I hope that I can maybe start a debate. So at least within our Baptist system, there is a chance that we could switch to TNK. Maybe we will, if we can all get convinced or not. So what do we do now? So I showed you some evidence. There's no non-inferiority. So do we continue the current method, what we do with TPA? Do we consider changing TNK to certain population, maybe just the LVOs, maybe some non-LVOs? Do we combine them? It does make sense for transfer patients. One, obviously, there are a few challenges. Some of the trials that we're involved with, because TNK is not FDA approved, we're not able to use TNK. So if you give TNK, then we cannot enroll those patients in the trial. Obviously, there are other challenges, right? So you have to change the whole process, the ER. I think we have some people from the emergency room, from pharmacy, from different center, but we do have TNK available. And that's one thing that we could do. So that's all I have prepared, because I was hoping we can open up some discussion, and maybe some of you guys can help change at least my mind, because I'm not 100% convinced, to be honest. I know what I prefer personally, but maybe you guys can help change maybe Dr. Hanel's opinion on this matter, or I know Wendy has a strong feeling about certain things, TNK being one of them. I know our pharmacy has some preference, but to be honest, we don't have evidence, so I cannot stand here and tell you one is better than the other, but it does have some appeal. So with that, I thank you for your time, and let's have a conversation. Thank you.
Don't hide your feelings, man. What is your preference?
I think I've expressed my preference. I mean, look, if you give a drug, let me go back. Whoever have given TPA have dealt with problems, right? There was a most ridiculous problem that I had faced, which was Joint Commission gave us a hard time, because when you give the drug, the end part of the drug sometimes doesn't get flushed, because I don't know the details. I guess you have to manually flush it or whatever. So there's some TPA left in the tube. Now, trust me, this is not something that I would ever thought of. I'm like, what does that even mean? So bottom line, there's problem goes with TPA. Now, let me tell you another problem. So Another problem is you give the bolus and then you hang the continuous, right? What if the continuous doesn't get hanged? It has happened. And then you transfer the patient, right? So now you have to transfer the patient with the line for 1 hour. The nursing, there's a lot of work goes into that. You have to take the patient to MRI. You have that going on. So there are issues going on in this 1 hour infusion, which I have a problem with. So if you tell me 5 minutes, give this drug and done, man, I think I would go with that.
Good. Oh, no, I was just gonna agree with you, Dr. Nima. When we get patients.
Thank you,
that-
by the way.
You're welcome. When we get patients to the OR, we're getting them transferred to us. And when it's a quick thrombectomy, then they're going to be transferred to the ICU. That could all happen within the 1 hour TPA timeline. And that's a lot of different hands on that patient. And you're relying on this process of TPA to continue seamlessly through all of that. Whereas it sounds like TNK, it could be all done with just one nurse or one provider giving the drug, and then you're done. It just seems like a safer option.
I'm a big fan of if you do what you've always done, you're going to get what you've always got. And so from the evidence we've seen, or at least we heard in the nursing session as well, there's a little bit more evidence to see that this is slightly safer, and the administration, at least the peak times and all those things take a little bit longer. So it seems a little bit safer as well. And definitely trying to get a patient on the table when you're handling drips and all of those things, could be a little bit easier. So.
Yeah, so I'm a stroke fellow here at UF Jacksonville, and we use TNK. And I think from Baptist experience, I know that you guys catch a lot of patients that are being transferred to downtown for procedures. So instead of doing the drip and chip, that requires special staff to be able to manage drips and be able to transport these patients, you can just give it go. So I'm with the, pro TNK, I guess you could say, where one, it's more cost effective for the patient. It has higher specificity to fibrin. So you would hope that it's more specific to the specific clot. And I believe, if I'm not quoting incorrectly, that there was a less or smaller chance of having outside of, or I can't say the word, of generalized bleeding because of the higher specificity. So I think it's better, especially if you're on the receiving end of several outside hospitals, that the give and go is probably the way to go.
Thank you. There's a question on that.
Thank you. My preference for transfers from, especially with an LVO, to use TNK, but there's one big dilemma that I don't think we can look at it lightly. Is one drug is FDA approved, one drug is not. And when there's a complication, the patient's gonna ask you, why do you go from an FDA approved drug to a non-FDA approved drug? When I approach our colleagues in Brunswick and Camden, that's their biggest concern. And that's why what Sandwich mentioned also in Cornell, they're waiting because it's not FDA approved. So that's something that's hard to digest. And I'm not sure also from the reimbursement standpoint. I know it's cheaper, but would the insurance companies pay for it as well, since it's not FDA approved? I don't know that question.
Yeah, that's a tough one. The FDA is one of the problems, but we can make a system-based decision, and that will become not an individual decision, right? So if you can, as a center, we can say, system, we have decided that, so it wouldn't be individual physician because you're not really choosing.
Dr. Nima, just from the ER standpoint, I think, especially when we are transferring patients from the freestandings and the nursing staff, this is no brainer that J&J is better for us. But Dr. Chamsani mentioned something about the FDA approval. I think that we all agree from the nursing standpoint, and for us, even during the calculation, you have to calculate and you have to dispose the remaining of the TPA. So I think that once it gets approved, based on the studies that you mentioned, I think consensus that we just go with the TNK.
Yeah, unfortunately, I don't think these studies are going to let. I don't think the component. I don't know if there's somebody from Genentech in the room, but I don't think there's not even an idea from Genentech to submit this to the FDA. again, if you think about 3 to 4.5 is not FDA approved, and we do this off-label use based on American Heart. So maybe what's going to happen, Mohammed, is TNK will become class 1 evidence from American Heart, and we're going to use TNK just like we do TPA from 3 to 4.5, because that's not FDA approved. And what applies to TNK clinical trials of thrombectomy, most of them also applies for TPA from 3 to 4.5. So if the patient gets an IV TPA 3.5 hours post symptoms onset, this patient is off-label use of a medication. So I think American Heart and Stroke Association may settle that for us, because if it becomes class 1 evidence on their side, that's just like giving TPA from 3 to 4.5 is the same type of off-label use with implications related to that. But I think it'll be more palatable. I don't think the FDA, that I'm aware, Raul Nogueira and I with Siddiqui brought this up to the company, to Genentech. I said, look, this is a problem for us. Why, you guys? And there was a bunch of no direct, no intention from the company to take this to the FDA. That would help us to go in that direction. I struggle because 40% of our patients that we enroll in clinical trials from neuroprotection, and now not candidates anymore, but before, but new ones coming. If you use an off-label use of a medication, that patient cannot be part of a study. So we will deprive patients from the potential to get what is coming next. But again, I see the momentum in the room, and I think Pittsburgh, we talked to Tudor, they are TNK, Demetrius, they are TNK, and I think when Wendy's ready, I think we're just going to pick a date, and naturally we'll have to discuss that internally. But I think Wendy wants to give a long time to think. She's thinking about September 15. I'm kidding.
Right behind you.
So when it comes to off-label and medical legal, we have a lot of, we're allowed to use a lot of medications off-label, like Neurontin is used for everything, but it's only used for diabetic neuropathy, but they use it for tooth pain. So I don't think you have to worry about medical legal for off-label. If you do get in trouble with something legal, you're going to be judged if you deviate from standard of care. And so if you're using the thrombolytic within the standard of care, your peers shouldn't hang you.
American Heart does have a recommendation, I believe, that does says that, you know, it is reasonable alternative. So we do have guidelines, even though it's not FDA. So.
Jason, just a word of caution, is way more complicated than that, because if you are off-label, it's not your peers, is the lawyer and what's going to be created just because you made a decision that is not 100% on the book. And by all means, off-label is our middle name. Plavix is not approved for anything that we do. We do because, okay, this study showed that, and there's some evidence of that. So off-label in neuroscience, that's if you don't like to do off-label, you're on the wrong side of the moon. But again, it can bring, and I'm aware of other situations that the off-label use of a device specifically create all kinds of questioning. Why, doctor, you chose to use that if you have other alternatives that are on label? So that if the patient doesn't bleed, great. If he bleeds, it may be open to a question that may not go anywhere.
But I mean, really, as a system, if you change your protocol, I don't see today's with TNK, I don't see how that would stand. But with that, any other questions, comments? Anybody likes TPA? Nobody else said they really love TPA. No? Okay. Yeah. Okay. All right. All right, guys. Thank you very much.
So we're gonna do a 15-minute break. We're gonna do the drawing really quick.
Try not to trip on the Okay, guys, really quick. We're going to do the drawing for today's gift basket. So stay put for a second? No, nobody's staying put? Okay, well. Abby's gonna. All right, here we go. You ready? All right. I'm not looking. Okay, today's drawing goes to Nanita Chang. Is that it? Is it Chang? Yay! Awesome. All right, we have a lovely.
We're going to the break. Okay, now we'll go to a 15-minute break and we'll come back for the pediatric stroke session. Here we go for the survivors of 3 days of affairs. Last session. And don't forget, we have a free drinks and food and celebration. It's a nice Friday afternoon. You can dance if you want, show some moves. Our last session is full. I'm glad I didn't record that. That was strategically planned. Thank you, sir. Last session here, and we talk about direct to cat lab, so that 4:35 session that you have there already happened. So we're a bit ahead of schedule, thankfully. So the last session is going to be focused with two sessions, one talk from Cincinnati Children's Hospital and a little discussion with case presentation from one of our own from Wolfson Children's Hospital. The first session is Dr. Sudhakar Vadivello from Cincinnati Children's Hospital. For the record, Dr. Robinson just moved from Cincinnati here. So he used to be there in locum. They do a phenomenal job in pediatric cerebrovascular care. So pediatric stroke intervention, what do we know? I think, do we have this recorded or we're going to do it live, Dr. Vadivello?
I can do it live. I'm prepared to do it that way if you'd like.
No, that's perfect. Let's thank you for joining us. It's a pleasure to have you here.
Dr. Anal, I appreciate it. Thank you for the invitation, and Dr. Abram and Dr. Aldana. I really have enjoyed the conference thus far, and sorry I can't be there in person. Hearing more about it, partaking even this way, I would say I'd love to be there in person next time. This is really good. I've learned a lot. So I appreciate it. Thank you for the time. I'm going to go ahead and share my screen and start this presentation. And I'll switch this around. Okay. Are you guys able to see that? Or is it sharing?
Yes.
It is sharing. Great. All right. Well, thank you very much. The title is Pediatric Cerebrovascular Disease and Stroke, but obviously for this conference, I'd like to say intervention in pediatric cerebrovascular disease and stroke. And I think that's really the entity here. And you see the subtitle there, Call for Innovation and Current Management Approaches. But I'll tell you that the real word here, the key word is call. I think in pediatric stroke, there's a lot of interest. I think there's intervention in itself as an innovation for pediatric stroke, but I think there's a bigger call for, when we talk about off-label use or on-label use and how we apply techniques and things. I think number one, we just need to get back to the basics for trials to be able to say, are we trying to go forward with the right things in place, the right metrics? So call for innovation is really key here. I'm an endovascular pediatric neurosurgeon. I'm housed at Cincinnati Children's. I handle only kids and young adults in this fashion, but we come across some very interesting cases along the way. I do have a few disclosures. Unlike other speakers here, all of these are unrelated to the presentation in a sense with patents on intellectual property and things. And I would like to thank Dr. Mike Taylor. He's our child neurologist here at Cincinnati Children's, who has been extremely instrumental in continually refining our acute pediatric stroke alert, which is a difficult task in this freestanding children's hospital. It seems like it's a never-ending battle with different disciplines involved. I think there's three objectives that I would say that we want to focus on. One, I just want to illustrate or show you guys some of the current difficulties we have with acute pediatric stroke, intervention in specific. And then second, the application of various management strategies in cerebrovascular disease. I know today is more on the mechanical thrombectomy side or interventional side, but there's also a concern towards aneurysms and malformations earlier in the conference and things. So I would say that there's a various management strategies, and I'll house that more in the idea of what appears to be an acute stroke and ready for large vessel occlusion thrombectomy versus your stroke mimics in pediatrics. And then again, to reemphasize what's been talked about quite a bit here in this conference, which I think is amazing, the importance in molecular and genetic basis towards how we have or conduct management principles going forward. I think in general, this is kind of a general introductory slide, pediatric stroke burden. 2 to 13 and 100,000 seems quite minimal compared to what was discussed on the adult side of things. But I would emphasize the second topic or bullet point, which is lifelong disability. Talk about 7 to 14% mortality and 70% morbidity when we talk about pediatric stroke in general. So there's a good reason that a lot of drama happens when there's one child that comes in with stroke, and we would say, boy, did we handle this correctly? Could we have done better? Should it have even been handled at all? But either which way, good or bad outcomes, creates a lot of talk or discussion points. And I think that second bullet point gives you reason why. I think a lot of times we think plasticity, neuroplasticity in the young age, or the multiplicity of collaterals gives us somewhat of an alibi to say, you know, these patients are probably doing okay if they already have a small stroke in place. Do we really need to go forward? And I'm going to show you cases in that fashion as well. But presentations of acute pediatric stroke, I would say that number one, getting back to some of the basics here, when there's attempts at randomized controlled trials for kids with stroke, we really need to get to categories, and that might help us understand who's really in an acute fashion presenting with a large vessel occlusion, or somebody that can be on the table, or somebody that can have IVTPA. So when we get to the categorization, I would say that Tim Bernard's study in 2012, during the time of trying the TIPS study, which I'll get to here in a second, really talks about the categorization. Is it thromboembolism from cardiac disease? Is it arteriopathy? Is it thrombophilia, inflammatory? So there's a multitude of causes of why a child might present in the ER with very similar acute stroke presentation. So it's hard to decipher that. And one of the biggest problems is getting to the diagnosis, and thus a delay in going on to that treatment if it's a hyperacute therapy. So why is it reasonable to even discuss mechanical thrombectomy for kids when we have failed trials to begin with for children? We see that hyperacute therapy really has an extended window, and I don't need to speak to this audience too much on diffuse 3 or Dawn. What it in a summary tells us is that, boy, there's an opportunity here when most kids present greater than 6 hours to even consider getting to a diagnosis and even looking towards therapy going forward. I think that if we look at even thrombolysis, IVTPA or IATPA, and we look at TIPS or the TIPSTERS studies, which are our pediatric stroke studies going forward, these were attempts in 2010 to 2013 trying to look at this idea of hyperacute therapy. And if we look at cases or retrospective studies at single centers, we can even see that mechanical thrombectomy is actually pretty reasonable to consider. It's feasible to do. And when we look at many different centers, there are stroke centers that have handled kids, and even accumulating the evidence even from adults and trying to extrapolate may be reasonable to do this, but in a similar fashion. So in 2019 in stroke, there's considerations for kids where it's number one, very reasonable to consider if there is a disabling neurologic deficit, if there's a large vessel occlusion that can be identified. And it seems reasonable for kids of a certain size, and the decision is made in collaboration, not isolated in rural hospitals and things of that sort. I think if we get to a point where we have a good collaborative sense to understand this is the right thing going forward, it is very reasonable to consider it going that way. And I think that gets to the next point, which is to establish systems and pathways to be sure that we can deliver safely hyperacute therapies. And I think that's really the point that I'm going to talk about here with the TIPS trial coming up next, which is this. So what do we do when we see literature that's out there with case reports on individual cases or single centers that have a number of cases put together? TIPS is a trial where they looked at thrombolysis for pediatric stroke within a certain time period. However, when the trial was open and funded through the NIH and StrokeNet between 2010 and 2013, it ended early. There was one patient that was enrolled of 93 that were screened. So there was an early closure to this, given the difficulty of enrolling patients going forward. I will actually back up a little bit. Let's see if it'll let me do that. Well, it went right through my slides here, but I'll tell you that the last study that I want to show you within this animation here is the results from the Mr. Clean registry. So the idea of looking at kids from this, looking at children that are less than 18 years of age. And what that really gets into is the idea that here are patients that fall into the randomized clinical trial, but have been treated in a prospective manner for this trial, but are all less than 16 years of age. And with that being said, this is great to compare certain kids that have been treated. Now, not many were in this study, only 9 children throughout the time frame here. However, 13 months to 16 years of age, all of them were cardiac based as far as their etiology with thromboembolism. Half of them were LVADs, so in real dire need, and the other half still cardiac, but did quite well when not on LVADs. So very similar to the SPORN study with looking at the Save Child's scenario, where they're looking at both US and European centers that handle children with acute pediatric stroke. So with that being said, there is a basis moving forward. I think in comparison to TIPS, the idea that we're trying thrombolysis and couldn't accrue, there was a lot of scenarios that made it difficult. And one of the things was just having centers that were ready and enabled. There was less than 25% of children's hospitals that were ready to have a stroke arrive and be able to be treated. There wasn't a pathway that was in place. After that study closed, or by the time when they had closed the study and looking at the variables of why that wasn't successful, greater than 80% of children's hospitals or centers were pediatric stroke ready. So having that protocol in place was a key caveat moving forward. And when looking at TIPSTR, which was an analysis of looking at those patients in that study versus what's been reported, they realized that a lot of things were underreported or not well reported when you're talking about developmental disease. You're talking about kids, whether they're 6 years old or 16 years old versus a 6 months old as well. So with that going forward, development seemed to be a key criteria, and the right metrics going forward were not in place. So a lot of things from the basics of pediatric stroke to be able to move forward with randomized controlled trials, we're just not there yet, but getting very close to those kind of scenarios. What's great about this trial is that it lets us understand that even within a large registry, even looking at randomized controlled trials, we have some patients that are following suit and can do well. So there is an impetus to say that, yeah, I think it's very reasonable to look at cases going forward and to say that if they meet criteria, they may be somebody that can go on to a thrombectomy. But I think in children from other disease states, not just large vessel occlusion, we consider blood and vessel anatomy. So we look at rheology and arteriopathy. That means, what does a blood cell look at from the inside of the blood vessel? Should that be taken into consideration when we talk about pediatric stroke? Because we're really talking about a treatment risk profile going forward. Is it okay to just say they've got great collaterals and they've got neuroplasticity? Maybe they have a small stroke, but I think they'll do well past that. How is it possible that we can look at the blood cells and their interpretation, or arteriopathy? So I'll give you an example. You know, a child comes in with sickle cell disease, but showing us a large vessel occlusion. Should they go forward or should they not? It makes it very difficult to say what that risk profile is. Is there an association with moya there in that child? And is that something that we can get to right away with CT and CT perfusion, or should we be looking at MR and things of that sort? So that gets me to point B here, which is stroke mimics of a thrombus associated with LVO. And then point C is biomarkers in kids. If it's that difficult to get to a diagnosis and to do that quickly, should we be looking at other biomarkers that take into account things like blood, so rheology or arteriopathy? So one thing that we're looking here at Cincinnati, both here at Cincinnati Children's and also at University of Cincinnati, is the idea behind quantitative arterial torch velocity. Does that index tell you anything towards kids with the possibility or the enablement of having a stroke, or enablement of even doing a treatment that can be successful going forward? I have the luxury of being surrounded by a multidisciplinary team and being able to look at different disorders that may present with a large vessel occlusion. So it makes it easier to get to definitive diagnosis, at least a bit quicker, but still a long period of time. But in general, it still comes down to the question of to treat or not to treat. And here are the challenges that I'd like to identify here as one of the major concerns, which is delay in diagnosis. Stroke mimics. Is that why we can't get to that diagnosis right away? Or is it social standpoint when a child can't advocate for themselves to tell you what their symptoms are and for how long? Age, size to treat? I would argue that, yeah, I think that's a very important point, but not as important as the two topics above that. I do think expertise in a comprehensive stroke network is important because there are a lot of times that, and we've seen them referred in where somebody undergoes a thrombectomy that probably did not need to, and it was focal cerebral arteriopathy or other scenarios going forward. Coagulation status, all things that matter, but at the end of the day, really only 2% of AIS children receive TPA in these studies going forward. So it's really hard to identify these correct patients going forward. At the end of the day, we'd all agree that goal of intervention is to prevent stroke. So I only wonder if we should be adding in, and this is what we think of in pediatrics, vessel disease recognition. So in general, I have a summary of multiple cases, and I've starred 3 of them that I think are important for today's talk and things. So I'm going to start out with the first one, and I kind of reordered these for this today, just hearing about how this conference was going and things. I thought this might be the most beneficial route going forward. So case number 2 is an 11-year-old with a past medical history of rheumatic heart disease requiring a mitral valve replacement in 2016, consistent lab draws with INRs that were oscillating between subtherapeutic to supratherapeutic and rarely perfectly in the middle. Had chronic left-sided weakness that's been ongoing for greater than 5 years, working with occupational therapy and the meds listed, but he woke with a facial droop, significant left-sided hemiparesis, and a CT had performed at an outside hospital. And what I'm not showing you right away is that this is during the COVID pandemic. This is during the shutdown in 2020. So it made it really hard for patients to advocate for themselves, number one, and number two, for a child to advocate even further with language barriers and for their families to say it's okay to go to a hospital setting. But despite that, this child presented multiple times and likely for things that we know of now with multi-inflammatory syndrome a priori, a few weeks prior, and then coming forward with 2 ER admissions before getting this head CT. And the CT, you can see here on your right picture, you've got a hyperdense MCA, you've got ischemic stroke, insular region, deep brain, an aspect score of 5 and an NH stroke scale presenting at 8. The CT angiogram really discusses going right at that thrombus, so large vessel occlusion, but there was great collaterals and there's a stable infarct because we really repeated the CT, CTA moving forward as they were trying to be transitioned from the outside hospital. And when we look at this, we'd say, boy, I see that distal MCA. It looks really good. There's good collateralization. I see the ACA as well. I see a PCOM. I think there's good sense that that stroke may have occurred and we may be done. Do we need to go forward? And that becomes a question. Is there evidence to back this, especially when a lot of the things that we do in pediatric stroke or cerebrovascular care are off-label? Or in some cases with certain devices not indicated for pediatrics. So it makes it very difficult when those kind of labels are even put in place. We have a clot burden score of 4 in this case, a collateral grade of intermediate. And then we went on to a CT perfusion, but I'll tell you, there was a lot of discussion even to go on to this, because during the pandemic shutdown, even when you're in a regional or a comprehensive stroke center, and I think very highly of our Children's Hospital and the stroke system that's set up in place to be in collaboration with UC, even the perfect system breaks down, especially in things like a COVID pandemic, and the lessons we learn from that can really move us forward. But we depended on an ambulette protocol to help move us for a CT perfusion when an MRI was not able to be performed because of the heart valve replacement. When we go forward with a CT perfusion, we see a great mismatch ratio of 6.7 and 87 cc's, thinking going forward that there's an opportunity to treat here. We don't think that this is enough. There's a lot to lose if we leave this alone. So going away from time-based to tissue-based was very helpful here, because what I didn't tell you is that this patient was last known well the night before and awoke, and I'm going to show you the time frame, at 6 in the morning with this stroke. And by the time they were ready to be on the table, we're looking at an average of 17 hours, between 14 to 21 hours later from that last known well. So how do we go forward with considering endovascular or thrombectomy going forward? Well, 139 cases of pediatric EVT, a scientific statement, evidence to date would suggest level C, class 2B recommendations. And I think even with that, we would say that it's, again, very reasonable, and in a comprehensive center may be appropriate to look to go forward if you think it's necessary. And I would say right off the table, when I hear discussions of should we just skip the CT and go from, or CTA or MRI and go from that CT to the table to look at our angiography, that may have been helpful because here our CTA shows us great collateralizations distal to the MCA and our ACA well there. But on the first run on the table here, I didn't see any ACA collaterals. I don't see the distal MCA. So obviously a change, and right off the bat knew that we were going in the right direction. So very proud that we went and moved forward there. As far as access, this child was 11 years, so very easy to get access. I use an ultrasound guided dermatotomy technique, very similar to what you'd use for transitional dilators or radial access sheaths for younger children. We designated this as a level A surgical emergency, even though we were already delayed coming in. We didn't want to take any more time off. So we went forward with a direct aspiration technique. And doing this, we would see, despite tortuosity being a concern, not in this case, and a lot of times with the cardiac patients I've had to deal with large vessel occlusions, sometimes that clot can be very sticky, chewy, even somewhat calcified or hard. So that makes it somewhat difficult. Here was not the case. And even right now, we're looking into the clot composition from a sense of, is this more COVID related? What can we learn from the fibrin composition and things? So that being said, the thrombus was extracted and the patient did quite well from this. You can see here TQ3 revascularization, one attempt, did quite well. Mild spasm that did not need to be treated, did very well. And I can see the ACA collaterals and distal MCA quite nicely. If we look post-operatively, we can see that really everything was essentially stable and things look good. He did quite well being on post-op day 1 with aspirin, transitioning to or adding in Coumadin, and then going on to be discharged home on post-op day 5. Short-term follow-up at 4 weeks, he was back to his baseline with resolved facial droop, a slight leg paresis that he's always had working with occupational therapy. And even now, years later, he's back to playing soccer and also teaching on the sidelines and things. So doing quite well. I'd say going back, what did we learn when this was somewhat of a difficult case in decision-making and things right off the bat? You know, at the outside hospital, they're associated with a local group that handles thrombectomies and has a local stroke network there, somewhat outside of our network. And the decision was to maybe delay or not treat. And then the decision was to call us directly here at Children's to move forward. And appreciative that they did, because here we were able to get a great result, but not an easy decision to make. And you might say, well, really, how much did the COVID delay or COVID pandemic really delay things? Well, if I look at pediatric EVT and COVID, there's 3 cases that were reported that clearly describe the case in essence on each of the cases. One was associated with multi-inflammatory syndrome, very similar to this. COVID-19 with respiratory symptoms, an outpatient that recovered prior to their presentation with an acute stroke, meaning 3 weeks prior. And another that was identified with COVID-19 positive on the stroke presentation on arrival. So all is well here with the idea that COVID-19 was there with symptoms prior that seemed to resolve. And this is all prior to vaccination status. We didn't have great COVID-19 tests to begin with at that time. But here's our timeline to give you an idea and where the decision was being made. And this is why I purposely put this towards the end of this case, was the idea that you know, we're at an outside hospital on arrival at 7:02 a.m. Last known well was 10 p.m. the night before, but really this patient presented a few times over the last several weeks prior to that, likely because of COVID. Wake up stroke at 0600 outside hospital, ED 0900 with the concern of evaluation for stroke. CT head at 10:02, discussion, review and accepted, arrives to Cincinnati Children's, difficulty with understanding, can we use our MR, can we not? And then had to be ambulated over for a CT perfusion when the decision was made to go on with a perfusion sequence rather than just going off the CTA. And with that being said, you'd see that significant time delay from 140 to 609, and it was a killer to sit there and wait and wonder why this patient is taking so long when I feel, and Mike Robinson, who's here in the audience, would tell you, I could just push the patient across the street. Why did we have to wait for this? But this really gets to the point of protocols. And I think there's a recent paper here in JNIS where we talk about what did the COVID pandemic do to us when we look at comprehensive stroke centers versus non-comprehensive stroke centers. We take a bigger impact in the comprehensive centers. And it seems ironic that that would happen. But when we have such a protocol and we're so dependent on some of these protocols, sometimes when there's a change and we're not notified of it or know of it, it becomes a real problem. And I love the idea of how you guys have a coordinator there that helps with moving all these bits and pieces. And I think from a children's perspective, that's probably one of the next systematic steps that we need to get to, not just being pediatric stroke ready, but have a coordinated network that way, not just a network. So finally, groin access at 7:18 p.m. and the results that were shown. I would say with this case alone, the challenges that were identified here was that number one, delay in diagnosis was a real problem going forward. I think we did not think that there was a mimic. We thought that there was this large vessel occlusion. It was just the idea of, should we go forward with that diagnosis or not? And delay in the treatment. And part of it's just getting to that expertise to be able to make that decision to go forward. I think in general, specifically, the regional transport protocol was our biggest problem moving forward. I think that could have helped with timing, but at the end of the day, whether it was 6 hours or 7 hours versus 17 hours, I think we still had the right to move forward, and I'm glad that we did either way. So the things that we could definitely improve on, and I think that pandemic shutdown really gave us an opportunity to say, how can we refine our system moving forward from a stroke net perspective? I'll go back and say that, you know, sometimes not all cases are so obvious with large vessel occlusions. I'm going to go to this one, which is a 4-year-old with 2 months of repetitive outside hospital ED visits before they finally got a CT scan and some concern for hypodensity. And you can see here on their MRI that they went on to get, after being admitted, a number of small collaterals and things, and they weren't really sure why these TIA events were happening. So then they called us and referred down, and we get an MRI and MR perfusion with hyperperfusion in certain areas within the scheme of multiple vessels. And we also see hypoperfusion in other areas. I put them on the table. We go forward with looking at what this may be, and we see puddling of contrast as a keynote term, and we even see transdural collateralization with our external carotid artery and things, and we'd say, boy, this looks very akin to cerebral proliferative angiopathy. And that's exactly the case. We moved forward and said, boy, you know, here's one where there was consideration at the outside hospital and the ED where the interventionalists had thought about putting them on the table for a possible stroke, a 4-year-old with concern, but on that CT and then MR seemed a bit odd. So glad they were able to get the MR and then make the phone call to not put on the table for that reason. So stroke mimics happen even with the same acute presentation going forward. So here, I think, learning from this case, regional collaboration is very important. I think having that comprehensive stroke network saying, I think Dr. Hanal, you made the mention of, you know, maybe more interventionalists need to be at one comprehensive center rather than having multiple centers with multiple interventionalists everywhere. That might be the parallel approach. And I absolutely agree. I think from a pediatric standpoint, I think that's what we're seeing here. You know, a greater collaboration regionally to try and get to one center might be the way when there's an opportunity for more time to get to the right diagnosis. And I'd point out that even social delays were part of the issues here. When you have a 4-year-old that can't advocate for themselves, part of it is family awareness and understanding what happens. We don't think of stroke in kids, at least for parents, not to the level of knowledge that we do for adults. So that can be very helpful going forward. On a contrary, and I know that I've got just a few minutes left here, I want to go to this video gamer that we talk about, or loosely coin him with. and say that here's acute left-handed paresthesias, neck pain, headaches, and a very similar scenario presenting to the ED at an outside hospital on the adult side. Had a CTA, and it was even put on the table with that CTA concerning that there might be an aneurysm associated. So they did a digital subtraction angiography and identified cerebral proliferative angiopathy. And purposely, I put this case here to mirror the other case. And to know that even with this acute presentation that sounded like an acute stroke, here we have a hemorrhage, a large temporal hemorrhage. And really, this patient presented 4 weeks prior, should they say 3.5 weeks prior, with a small subarachnoid hemorrhage within the parenchyma concerning much akin to a trauma. But this is a video gamer. He wasn't out. He didn't have any trauma, things of that sort. It was spontaneous and identified with cerebral proliferative angiopathy. He was transferred here, hospital day 4, for further acute care. Using cross-sectional imaging, I agreed that there was an aneurysm. And moving forward, instead of revascularization, microsurgical revascularization, like the other patient who underwent, this patient I took to the angio suite and did targeted embolization of the aneurysm, knowing that there was a mild spasm in the traversing vessel that goes on to this small aneurysm, treated this area that was within the level of the hematoma, and has done well without repetitive hemorrhages, and we're currently following now long-term. So I think there are definitely opportunities to use intervention in pediatric stroke for not just large vessel occlusion, but even for other entities of stroke as well that we see in kids. And I think the idea of intervention is in general for pediatric stroke is novel or innovative, but we have a lot of room to move forward. So that being said, I'll go right to my concluding slides here, which are the difficulties in acute pediatric stroke intervention really go into a number of things that you guys have talked about, where a lot of it's still awareness in kids. I think it's not only important to incorporate our child neurologist and our pediatric trained interventionist, someone that has familiarity with children to be able to do this, but also our diagnostic neuroimagers, our diagnostic neuroradiologists, to be able to say that we want to go on to that MRI or CTA. It's not so easy in a children's hospital to make that decision or pull that trigger. There'll be a lot of discussion both ways. I think there are very few standard outpatient cases that come into the ER. Actually, most of them are coming in already admitted in the critical care units. So coordinated regional comprehensive care is really important. So I stress the idea behind coordination, which I loved hearing about a lot in this conference. I do think neuroimaging, we have a lot to work on as far as biomarkers, from collateral evaluation to tissue-based approaches with perfusion. Very much is that a key strategy for us here. I think the selection criteria really, we need more biomarkers. From arterial tortuosity index is one that we're looking into. But at the end of the day, I would say the call for innovation really move forward with at least a call for pediatric approved interventional devices, or at least taking the label of not approved for pediatrics off devices. I think that can be very helpful moving forward. At the end of the day, Dr. Aldana and Dr. Abram, they both know, they've been here to our conference that we host out in Aspen. It's a little plug for our pediatric specific cerebrovascular disease and stroke conference out in Aspen during the summertime. Ironically, it's beautiful, it's fun. The next conference is in July, so I encourage anyone interested in pediatric stroke and cerebrovascular disease to try and come out there and join us. But with that, I'll end and say thank you very much for this opportunity. I very much appreciate it.
Thank you, Dr. Vedvela. Great talk. I don't know, what do you think makes more sense? We have Sam. Tell me again your last name. Kamarov. I didn't want to assassinate Kamarov. We have Sam Kamarov here representing Dr. Abram that could not be here with us. He's going to present a case of a pediatric stroke for us. Can we keep the screen up there, guys? Here. So do you think it makes more sense to go through him and then we'll discuss, or shall we discuss? Because it's all on the same. And do you have time to be with us for another 30 minutes or so?
Yeah, absolutely, no problem.
Because I think the discussion of Sam's case that we did a couple of weeks ago or last week, I don't remember, will tie right into your great talk, and a lot to discuss. I'll have the question for you. How are you gonna get that label out of those catheters? That is a tricky one. Do we have Sam's talk, guys, ready to go? Thank you, Sam, for doing this. And So we got Sam to present the case, and then we'll go through the discussion of Dr. Vadivelo's talk and this case presentation about barriers. We have essentially all of us that are brave soldiers this late in the room as the panel. So Kifun, Eric, Nima, Demetrius, myself, everybody else with Dr. Vadivelo and Sam here to discuss. Please, Sam.
Sure.
Thank you. Thank you for doing this.
Thanks for having me. So I'm kind of filling in for Dr. Abram, Dr. Aldana kind of at a last moment. But mine talk is going to kind of tie into that as far as pediatric stroke, but we're going to be looking at kind of barriers and how we can kind of fix those barriers and optimizing stroke care in pediatrics. Obviously, as a resident, I don't really have any disclosures. Not that lucky. So first, for a case presentation, we have a 15-year-old morbidly obese girl. To put into perspective, she's about 300 pounds with no known history of head or neck injury. She initially came into the hospital after a motor vehicle accident as an unrestrained passenger. And this is going to tie into some of the social aspects, and a little background was that she was either with, was under foster care, is with someone else not related to foster care, where the driver told all the kids in the car to unbuckle their seatbelts, and there's this misnomer of whether or not he purposely crashed the car trying to kill everyone in the car. She was ejected and surprisingly only ended up with the left distal humerus fracture. Head CT at the time, due to the incident, was read as normal. Her initial GCS was 15, and she was taken emergently to the OR for fixation of her fracture. The next morning, she was doing well post-op. Between 7 and 8 a.m., whenever the nurses were rounding, there was no noted neurological deficit. She was doing well. She was last seen at 8 a.m. At 8:15, she yells for help. I think one of the medical assistants runs in there and notices that she has an acute left facial droop, left hemiplegia, diminished sensation in left extremities, and also some mild dysarthria. At that time, a code stroke was called. Her initial NIH, and this was by one of the neurology residents, the child neurology residents, was an 8. So she did have no effort against gravity in the left arm, some effort against gravity in the left leg, no ataxia. She couldn't really do anything with her left side, so you can't count that against her. Some mild sensory loss on the left side, and then mild to moderate dysarthria. So kind of a timeline of the events. So nursing bedside assessment, because they come in and start their duties at 7 a.m. So then they're rounding on their patients, and then has a nursing assistant at 7:15, at which time she was seen normal. 8 a.m. eating breakfast, no issues. 8:15, that's when her neurological deficits were noted. And then 8:30 was the code stroke activation. In that 15 minutes, rapid response is called. And for us, a rapid response is usually a PICU nurse, and it's a senior resident from the general pediatric team that responds. And then one of the nurse practitioners from the trauma pediatric surgery service was also present. 8:40, she was actually in the CT, and at least at our institution, CT is not our first choice recommended. As she just had new metal implanted in her arm, we didn't know if it was MRI compatible. We couldn't get in touch with anyone from the orthopedics team to let us know. So instead of waiting for imaging, we went ahead and took her to CT, which noted no acute intracranial bleed or infarct. At 9:42, after battling, getting in touch with ortho, who said she is MRI safe, first we took her down to the pediatric MRI. However, due to her elbow being kind of fixated and the fact that her body habitus was larger than your typical pediatric patient, she actually could not physically fit into the MRI scanner at that time. And then the adult hospital at Baptist has 2 MRI suites. We were directed to the one in the basement, which actually wasn't the correct one we needed to go to, and then she had to be brought up to a different floor. And then once she presented to the right MRI suite, then they were stopped by staff. And lately they've been requiring all this paperwork for you to fill out as a staff, even though this was an emergent situation. So that took about 10 or 15 minutes extra out of our time. At 9:42, she did get an MR brain, MRA head and neck. which did show acute infarcts in the right basal ganglia and posterior limb of the internal capsule on a right M1 LVO. Also, I believe a right A3 occlusion as well. Less than an hour later, she was in the OR with Dr. Hanna for thrombectomy and recanalization. So these are just kind of some of the pre-thrombectomy MRI. So you can kind of see, I try to slice as many pictures as I could together. Up top is your DWI, where you can kind of see the infarct in the basal ganglia, and then obviously the associated ADC pictures below, which kind of led us to believe this was real and not fake. And this was post-thrombectomy, where you can see better vasculature or better flow into those areas, showing improvement. And this is the part where I'm going to ask for a little bit of help on Dr. Hanel's part, since he actually performed the procedure.
Oh, very interesting, and I'm curious to hear others' thoughts. Where did this come from? But you see that she has a M1 or dominant M2, if you call that early branch there. Maybe we can get the pointer there, Simon, I can point so everybody can see there. Thank you. So we see here that she has, am I on your way there? You see here, there's an M1 or M2, if you call this anterior temple, let's call this a dominant M2. And also interesting, she has a A3 clot there. So we don't know where this clot came from. We did thrombectomy here first. If I'm not, do you have the device that we use on the talk? But we did a primary thrombectomy here primary aspiration thrombectomy here. And then for this clot here, we did a mini pinning with I think we use a solitaire 3mm and a 3 max. This was a single pass, a Tiki 2B. Then this was 2 passes. And I don't know what is coming. So there was a residual thrombus, and we were discussing this earlier. There was a branch here. If you look at the ACA, where that ACA, where the first branch will cross that, that's not uncommon, the prefrontal gyrus branch. So there was a clot there. So she got an aspiration there with a 3 max as well. And that's so three thrombectomies, M2, A3, M4. We use again, she's pediatric by name, by size, she's adult size. I think we use an 8 French short sheet. Did you do that with me, Mike? I think it was Sophia. I think it was an 8 French. We're doing it.
I have to ask a question.
Say that again.
I have to ask a question. You know, this is a pediatric case, right? And her metal hardware is within the last 20 years. All metal hardware in the last 20 years is MR compatible. So I struggle with this because, you know, our colleagues in France are doing MRI in 99% of their stroke patients. And I struggle in the United States. Are we not too conservative with ordering an MRI?
Yeah, on this case, she just had the metal implant and with the same hospital, right, Sam?
Mhm.
So that was not a big deal. But I'll tell you, man, there's metal there. The MRI tech is not going to put that, at least on the adult side. I don't know, on the pediatric, Sam can answer that better. And so doctor can talk about the Cincinnati Children's. But our MRI techs on the adult side, if there's metal, they will not put that patient on the table. So.
Mhm.
It's the same at our place. And I'd like Sudnagar to comment, because I think this patient should have had an MRI emergently.
I agree, but I also disagree. So I think that forget about MRI. How old is she again? 15?
15.
Yeah. So what do you need an MRI for? You have acute neurological change and you get a CT, and the next step was a CTA, not an MRI. But obviously in pediatric, I understand it's different.
No, but I think it's a good point. I mean, for the same reason that, you know, 15 years ago, I mean, a radiologist would delay for like, wait for a creatinine for a stroke patient. You know, at one point you have to have your priorities straight. You look at all those data for CT scan for children for risk of tumor. The truth is that those are all epidemiologic data. You know, it's those data are usually a bit weak. But even if you take the worst projection, you probably create one tumor every 3,000 CT that you do on kids. And there's probably a huge bias towards the younger and infant. This is a patient who has a stroke. This is a bad problem. Do we really care in the short term of the brain tumor that she has 3,000, 1 out of 3,000? Exactly. So, I mean, why? Yeah. Dr. Sudhakar, what is the protocol and what's your thought about this in Cincinnati?
Yeah, so I wanted to go back to the comment of metal and MRI. There are things that we do in ENT and neurosurgery even where it's not MRI compatible. Auditory brainstem implants, certain companies for deep brain stimulators. You may say we're even MR conditional, where a sequence for looking for perfusion imaging here may not be applicable. So the idea of just taking the MRI and saying that certain metals are compatible, I think is correct, but not all sequences in MRI can be used appropriately for this in comparison to what the approval is for that metal object being there. So it gets a little tricky sometimes with these. So I don't think it's always the case that we can take every patient with metal to an MRI suite.
Do you have a cutoff? So again, I think Eric said, and I'd like Sam to weigh in. She was on the CT. She is plegic. There's no blood there. Do you guys have a cutoff where, okay, if it's a below 5, below 10, or whatever, you favor MRI? Do you have two standards, or you just drive by one? Because I can tell Wolfson, we are an MRI driven. So the adult side is all CT driven. The pediatric is MRI based because of all the stroke mimics and so forth and so on. So do you guys have a cutoff in Cincinnati or in Chicago, Kiffin?
Yeah, I would start out with the Cincinnati. I'll tell you that, boy, we definitely favor our MRI perfusions. And when we can't, and something like this, I would say that there would have been strong consideration to move forward just off that CT going forward, just given the idea that the patient was in the hospital. There's a known entity of when this started. In comparison to the case that I presented, where time frame and the repetitive events of coming into the hospital were difficult, here I think it was a little bit more clear cut, where I do think it would still be monumental to go right from CT, CTA to the angio table, even in our institution, and to avoid a CT perfusion or avoid an MR study. But I think we would have given that good consideration. Always easy to be Monday morning quarterback.
In Chicago, in our two children's hospitals, we've just recently moved away from 100% MR studies for all of our kids. So we've set a protocol if they're 12 or older and of a adult size, really, that we move to CT, CTA. And then younger than 12, we will consider on an as needed basis. If you have a 10-year-old, again, of adult size, and that's at the discretion of the pediatric neurologist who's present, neurointerventionalist that's responding, and the multidisciplinary team that's there. I will say that we have not, if we feel we need perfusion, we prefer to do MR perfusion. And I would also just say that we have a very strict MR stroke protocol. So we have really delineated the exact sequences that we want in the MRI scanner, so that we're not, really it's cut down to about 11 minutes total of time that our sequences will take in the scanner.
I just have to say from personal experience, you know, my 7-year-old son knocked himself out playing on the playground, and I intentionally didn't bring him to the emergency department because I knew they would immediately do a CT to rule out hemorrhage. Instead, I woke him up every 4 hours and checked him out and made sure that there was no change. My point being that I really think in this country, being so MR adverse is not helping us out. I think MR in this case, and I understand she had specific issues that made it more complicated, but I think being MR adverse in pediatrics is a real problem.
Matt, I think this is, well, anyway, I think the point is more like have a workflow that the stroke team gets activated, and you have, in our case, we have used the same app system that we do for adults. So I think that as soon as you can get a stroke team member to participate on that code, then it will get, I think, even though you have a protocol, these nuances of if somebody looks like an adult and is going to delay a lot to get the MRI, I think then the CAT scan, we refine that age based on these observations, but being part of the codes is the first. You need to have a workflow in the hospital that recognizes that we get involved early on these cases, either from ER or inpatient. So I think that is probably the lesson for me. I think the MRI CT scan discussion is secondary. First, you need to have a stroke team that is willing to assess these patients. Many hospitals, you have the adult side and they don't mix into the pediatric side. And I think that in our case, at least, we cover both sides of this, and it helps to use the same workflows we learned from adults into the pediatric side. So I do feel that early knowledge from the stroke team helps to determine what's the best course to take.
Yeah, I think that's exactly the point. Sam, I know you reviewed the case. You probably know better than all of us. And I was asking Nima here, when did the interventional team got involved? Because that's a problem. I think we all lived through that. I would love to hear from the Cincinnati guys. On the adult side, we know that if this is a patient comes through the ER is one situation. If the patient is an in-house cold stroke, that comes with all kinds of problems. And Nima was just telling me here, again, just
yeah, so no, I agree with you. The workflow is very important. So we work in adult hard for a dedicated workflow. In pediatric, obviously, it's more challenging. So here, thankfully, we do have a workflow in place. So now, if there's a code stroke, the code stroke gets to go to the pediatric neurologist, but also the interventional and the vascular team also gets notified. Yeah, at the same time. So that is a workflow that we put in place. Now, how many thrombectomies do we do in peds? This is one of the cases that somehow it fell out and it did not come to the interventional. Can you go back to your time frame? So here, the issue is when the code stroke was called at 8:30, we did not get notified. So I got notified at 9:40 or 10 o'clock when the patient was actually in the MRI. So you can see there's a 2-hour delay from the code stroke to the thrombectomy, which could have been avoided.
But the people that when you activate this chat or the stroke navigator is the same stroke navigator that has for adults. Is the same or is a different team?
No, so we have a system that's called telematic.
Yeah.
And supposedly this should go on this telematic channel. If you saw something different, Sam, please, when they investigate that, like we do with every single case that we think there was a little problem delay here and there. Here you see a 1 hour there. We're not happy with that. Naturally, patient did well, but there's a room for improvement there. The fellow, that is the person that respond to our code strokes, should never be paged by him or herself. In this case, fellow is a scrub doing cases, pager rings on that phone was never answered. You cannot stop there. So if this is a big brother go through 20 people, okay, who answered that? So that's what one of the problems that we identify, because ideally, if you have somebody with a high NIH, plegic, going to a CT, and we get notified right there, look at the CT is negative, you look at the size situation, I think all of us would talk and say, no, let's go ahead and do a CTA.
But Ricardo, this is the whole point. The way we use our activation is that really the whole team is notified at the same time.
No, we too, but the problem is that the person that activate did not use the correct channel, use a
Yeah.
wrong channel. That's a problem.
yeah.
So we can have all this beautiful system, but if the activator doesn't use the right channel, the system doesn't work.
But the reason is because the person didn't know about this. I see.
I would say too, one of the things that we learned as we went to develop the process is, you know, of course, this is reviewed at a pediatric committee meeting, stroke committee meeting. So I don't know if there's a separate meeting that you have, so you review that. And of course, having one channel only that is able to be communicated on, we actually send, in addition, our APC goes and our adult stroke coordinator and goes to all pediatric stroke alerts. So because we are certainly way more used to responding because of just the sheer volume of calls that we get as the adults, we can help drive the pediatric team on kind of timeliness, what we need, what's next steps, neuroassessment scales. And the other piece is we push the pediatric images through Viz. So we're able to see those in an immediate time as well. That's been helpful for our team's process.
Sam, your thoughts? I know you have some more slides about the system, and then Dr. Vadivelo, you have any comments?
Yeah, so I'd agree very similarly to you guys. The interventionalist is not notified right away. For pediatric stroke alerts, whether it's in the hospital, out of the hospital, it goes to the child neurologist that's on for the pediatric stroke alert. And they're in coordination with University of Cincinnati stroke alert team. So there is a centralized coordinator that helps distribute that information. But the access to me or to others from an interventional standpoint, there could be a time delay there. So I do agree that having it all or everybody all on the same app can be very helpful there. Or one channel, to use the same coded terms.
Do you want to go through your barriers there? Do you identify some?
Yeah, because I think it will tie in some of these aspects.
Hey, Sam, can you hear me?
Hey, Dr. Abram.
Hey, this is Harry Abram. I appreciate Sam helping us out. And I had been the director of the stroke program at Wolfson's for maybe about 10 years now. And I think for this particular case, some of the issues is that child was on the trauma service, which is near the children's hospital, but it's not quite where all the pediatric doctors typically are. The child actually went down to MRI scan immediately, but because they couldn't get it because of the hardware issues, the CT scan was right next to it, hence the CT. I believe they tried a CT angiogram, but they had IV access issues. And so it kind of went back and forth from the CT to the MR. But I think all things being said, the outcome was really good. And I think the team worked well. But I think it's really good to hear from the Cincinnati group, because I think every hospital, even that top 5 children's hospital, has similar issues as a smaller hospital that we do. So I really, I appreciate that perspective quite a bit.
So just to kind of keep going, some of this stuff I already mentioned, so I can move along. So really we look at kind of the barriers in pediatrics as far as getting fast care. And just to quickly highlight, so a 15-year-old obese but previously healthy girl, status post left humerus fracture repair, ended up having new onset neurodeficits the next day with an MRA confirmed right M1, M2 LVO affecting basal ganglia posterior limb. Due to recent surgery, not a TPA or TNA candidate. Taken to OR for thrombectomy for evaluation, recannulation. Post-procedure MR with interval improvement. And actually just to tie up at least the clinical aspect, she actually regained basically full function and had no neurological deficits after a couple of days. So just to work up, because in pediatric, especially like I do my adult rotations at Mayo Clinic. And so if someone comes down to the age of 40, then obviously like anywhere else you do kind of your stroke and the young workup. So for us, we do that with every patient. So we started off with the T with bubble study, but it was normal. Hypercoagulable workup was unremarkable. All of her inflammatory markers were normal. There was no signs of any rheumatologic disease as well, which is kind of the main aspects that we look at. And I'll get into that in a minute. But she was started and continued on daily aspirin as you would almost any other stroke patient. So some causes of pediatric strokes that's a little different than adults. You can have multiple etiologies that hinder diagnosis, because as in kids, one of the last things you kind of think about is, could this actually be a stroke? So it's not exactly the first thing on people's minds. You have variable risk factors, whereas in adults, you have a lot more atherosclerotic, cardioembolic risk. Here you have more congenital versus rheumatologic, inflammatory, or just cryptogenic causes. We don't have really great guidelines to guide us in our treatment. So a lot of it is taken from either different institutions and implementing it, or kind of tweaking it to fit our own way at our place. There are many barriers to rapid diagnosis. If you're under a certain age, some people are very hesitant to start irradiating, say, a 6-month-old or a 2-year-old, depending on what the need is for, especially with the CTA and a CT perfusion. And for us, there are multiple specialties involved, as we have sometimes no idea where the etiology came from. So if it's rheumatologic, you have to figure out when a rheumatologist can weigh in and do their workup, or you have infectious causes, or you have any other specialty that could be involved. So how do we kind of break down these barriers to improve kind of optimizing stroke care in pediatrics? One, I think increasing community awareness, letting people know that strokes in the pediatric population do happen. It's not just a misnomer that it is a purely adult or anything like that. Increase physician awareness. And I think this one for our system can kind of play a role, because if we get caught in the middle of the night, there's no pediatric neurologist fellow to go in. Sometimes if we think we need to go in, then we can. However, otherwise it's just the ED that's doing their assessment. And typically, not always an NIH is done. So kind of teaching ED folks how to do a pediatric NIH, I think, could be of benefit. Or because we're the referral center for a 2 or 3 million population, because we take everything from the Panhandle down to Daytona and then half of Georgia, you have these remote community hospitals who don't deal with pediatrics, who are then calling us 3 or 4 hours away. And so you kind of have to walk them through on how to look at a pediatric patient with potential stroke. So you have a lot of delay in diagnosis. Mean time from symptom onset to parent seeking cares, roughly 1.5 hours to 21 hours, so almost a day, because who's going to think their child is having a stroke? Median time to radiologic confirmation can be 15 to 24 hours. So by then, you're obviously outside of any point of TPA or TNK if they're old enough and able to receive it. You kind of have other factors which play a role as admission for other illness, delayed consideration, accessing MRI, because if you are usually above 6 months old to about 10 years old, you're going to require sedation. Thankfully, at our institution, we have a rapid sequence for MRI that usually only takes about 10 to 15 minutes. So, in well-behaved kids, they can sit there, or our teenagers can. But if you have a 2-year-old, you know they're going to move. So then you have to make sure you have a pediatric anesthesiologist. You have to make sure you're going to have line access. And then it's just a matter of if the MRI is available. And for us, if it's at night, it's a matter of if an adult MRI is available. And along that line is having adult MRI technologists also being comfortable working with the pediatric population. Weekend and after hours can be difficult, whether or not someone has to come in from home, or there's anyone staffing the pediatric MRI at that point, or we just have the availability of staff. Parents don't always bring their kids directly to the ER because they just play it off as the kid hurt himself, or they think it's transient, because once again, who thinks a 5-year-old could have a stroke? Symptoms can be gradual, altered consciousness, mild stroke, or physician bias, kind of like what I've said before already. So these are the kind of clinical presentations for childhood stroke. The majority of it is hemiparesis, but of course you can also have other things. More people might think about a migraine with hemibody paresis versus actually a stroke cause. Some visual field deficits, kids aren't good at telling you what they're actually seeing. So how can you estimate if they're having neglect or what kind of visual field deficits they're having? Kind of one that I like to point out is seizures, because in neonatal strokes, the first presenting symptom of a neonatal stroke is seizure, and not actually any sort of deficit neurologically. So we just had a case where we did have a baby who presented with neonatal strokes, was on phenobarb. Mom had a history of cocaine use, so maybe she had fetal strokes. However, baby ended up having GBS meningitis. That was most likely causing the seizures instead. So obviously there's a lot of mimics. Sadly, we do see a lot of them. That's actually the majority of our stroke codes. I think a big one that we see is a kind of a Todd's paralysis. And I had one personally where I had a kid coming in, and unknown whether it was like intussusception or anything else that was abdominally, because he kept gripping his stomach. And then my attending was in the room, saw that he had a right facial droop, called a code stroke, and then ended up having a left lung tumor. But that considered for stroke code for the facial paralysis. Once again, complicated migraine where you can have hemiparesis that will eventually resolve. One that we've actually had a couple of cases on is tic paralysis, where we've worked up stroke versus Guillain-Barré, and then a whole list of other things. So it's really trying to tie all this together, so you're figuring out multiple things at once, usually with kids. One, I think, is educating on a pediatric NIH stroke scale. And obviously, a lot of it's observation. You play with kids a lot. That's how you kind of figure it out. And then MD Calc actually has a pediatric stroke scale on their app, and they tell you kind of what to do with kids in those situations. So the American Heart Association actually recommends MRI over CT just because it's more sensitive. As in our case, our female didn't have anything on CT, but thankfully she was able to get an MRI. Like I said, I already discussed this with kind of considerations with getting MRI in children. For us, because there is no really stroke trials in the pediatric population, there is, I think it's actually a little bit more than 101 sites of these main children's hospitals across the world that basically submit all their stroke cases. So there can be some comprehensive database as to finding etiologies, kind of what was done pre and post, as well as kind of management styles as well, to see if there's any correlations. That was brought up earlier. I'm just going to skip ahead a little bit. So here, just a quick base on our stroke code protocol. So we do have a blast page. It goes to the pediatric fellow first, along with the PICU team, anesthesia, MRI technology, interventional, and then there's actually a specific order set. But now that we just switched over to Epic from a different system, we are working out a little bit of kinks, to be honest. But I think for our first one with the switch, went pretty well. That I can't see, I'm sorry, that's just more details about the pathway. So we're going to, so actually I was in Cincinnati, or I was in Aspen, and I presented this QI project. So the past several years, we've been working on our metrics for improving response times. And the main ones that we looked at was door to MRI and door to code stroke. As you can see, the 2019 and 2020 kind of had a little bump, but this was the height of COVID. And regardless of what you came in for to go to MRI, you had to have a COVID test. So would the COVID test come back in 2 hours, 4 hours, 10 hours? You never knew. So that kind of threw out the metrics a little bit. But as we started relaxing a little bit, 2021 and 2022 started showing improvement. And we do have quarterly meetings with various staff. Some outliers that we do have, because patients do come from all over, is sometimes it takes 6, 7, 8 hours for patients to get to us as well, which can also hinder their care. So I think taking all this into consideration, if you're a massive referral center and you have patients coming from 6 or 7 hours away, whether or not they can be brought by ambulance, helicopter, plane, it kind of takes into consideration what kind of level of care and how soon you can give them care as well. That was the gist of it. There was a lot of stuff that was discussed before in the middle that was nicely covered, so I don't have to cover that again.
Thank you very much. Great job. Anybody has any questions? If not, we can have some more discussion. You said you put the kid on aspirin, correct? What I know you said differential diagnosis. What do you think was the cause of her stroke?
I know that even MRA of the, MRA of the neck didn't show any atherosclerosis despite her size. You wouldn't really typically think that. I think whenever I was emailing with Dr. Bedaluvu about it, he kind of had an idea of maybe just traumatic vasospasm after the setting of a MVA.
No, so there was a clot, right? Or
Yeah, I don't think we know where it exactly came from.
No, there are two clots, right? So I would love to hear Dr. Vadivelo's thoughts if he has any different idea. What's interesting, we got a TE with a bubble faster than we got an MRI. Because again, she was on the table and I told, anesthesiologist did a phenomenal job. I told Dr. Bannister, if I'm not mistaken, was involved. Yeah. I said, can we get a TE? And literally in 15 minutes, we're doing a TE with a bubble on the IR table. And so we thought about fat emboli, but again, maybe there's some hidden pulmonary shunts. I don't know. But I would love to hear.
Yeah, I think that, we think of trauma. I brought up the point that, traumatic spasm, we see that not necessarily for a large vessel occlusion, but just the idea that we do see traumatic vasospasm and another interest in the interventional world from that standpoint. But here, yeah, my first thought was fat embolism. I was going to ask the question of, I didn't see any.
With a negative TE?
Well, no, I was just going to say that, was there any analysis of that clot?
That's interesting. We know we got the vessel open, but all we got is some frothing out of the thing on the pump when we did the aspiration. There was nothing solid to send for analysis on the. We use, I forgot what kind of a garden variety of a pump that we have, but looking at the pump, there was no, but the clot was gone. So, so far, right, Sam? Everything negative, right?
Everything's been negative so far. I think she's actually being transferred to a different facility that's closer to where her family is actually going to be. But so far, our negative has proven nothing was the cause at this moment.
Go ahead.
Oh, I was just going to say, I'm not sure the etiology of the thrombus or the composition of where it may be coming from. I was going to ask a point on the PFO, but I'll let you go first. Sorry.
The T didn't show any PFO, but I mean, we know that in adults, you could have a shunt. Sometimes we can do TCD with hits to detect for any shunt presence. It was right after surgery, so I think that's kind of the other thing that we could, right? Oh, I'm sorry, the day after. The other thing we could do is in adults, sometimes we do a pelvic, looking for venous DVT in the pelvis. You can do a MR venous of the pelvis. I know she was a little larger lady, but there were no shunt that we found. Going back to the process, I think, we work hard and you guys do a great job. This one fell out just a little bit, but we do have a working process. Door to cold stroke of 30 minutes. So I think ER is doing a great job. And the fact that you guys are involved and doing this is very, very helpful. One thing I would say in our process, so, and I want to ask you guys about your process. So what happens if do you guys get a call for every cold stroke? And what happens if you get scrubbed in? Who gets called? And what do you do if you're scrubbed in? Who notifies you?
From a fellow wise, so there's
No, I'm talking about Dr. Vaduvelo and Dr. and Demetrius. How does your process work? How do they notify you for a cold stroke? If you're scrubbed in, obviously, if you don't see it.
It's usually, it's either the stroke team or the child neurologist. Both are collaboratively saying that the interventionist needs to be called. Usually it's during the daytime, or if I'm around, they're calling me directly rather than going to the UC adult guys. So if I'm scrubbed in, which has happened twice, I just handle it. By the time that they're ready to come over to the table, by that time with our fellows in pediatric neurosurgery and things, a lot of times my cases, I think luckily they've been at the end of cases or in the middle where I can finish quickly and move on. So I don't have a good answer there if that had to happen, but I would assume that the current patient would have to get off the table and then I'd have to move to that next.
one of the issues that we have is that there's just so many mimics. And we may have perhaps 2 to 3 code strokes a week, but the vast majority are migraine or something that's not a true stroke. So we always don't want to overburden, I guess, endovascular neurosurgeons with a lot of mimics. So we struggle with how to let them know when we really need them, at the time. And I think telematics has helped quite a bit with this, having a common app. But I think every time we learn more and we try to improve the process.
That's what I think. I mean, just to answer this, I think we usually will prefer to be notified every time it comes through the app that we know the patient is going to imaging, MRI or CT, whatever is going to happen. At that point, you're in the lookout between yourself, the stroke navigator that is one of our NPs. That's how we're notified, basically. But you cannot rely on the phone call to an attending. That always breaks the process. So you have to have, I think the best thing to do is to have communication to all the members of the team. Whoever is not on call turns off the app. But if you're in the house working night or day, you're gonna get the notification if you're on.
And I think, Harry, with the fact that now we have the pediatric side connect through Viz AI, it makes it much easier for us. And this is something to consider because this is gonna come to the phone anyway. And we get so many of those that I think it will be interesting to maybe activate, and it's very easy once you see an MRI and an MRA that is negative. It just that dissipate really quick and adds, because this is a low volume compared to what we deal with on the adult side. I think maybe something to consider. Just activate and keep the process every single time, real or not, make it happen, because I think that decrease that. But I just want to echo what Nima said and what Sam present. There's no question for those of us that have been involved this for a couple of years now, we got much better in our process. And I think your slides show that. This is something that I think we have to discuss, get our radiologists involved. Is this reasonable to say, okay, if the kid is whatever, over 100 pounds, 200 pounds, pick up a weight and age and get those two together, and maybe the body weight can overrule the age. And with that, okay, CT is acceptable, because again, we could have saved easily 2 hours of intervention for her. I think that's something to consider. And I would love to hear your thoughts about that, Dr. Vadivela.
Yeah, no, I absolutely agree. I think saving time is so key. I think the number one point, even in my presentation, was the delay in not only getting to a diagnosis, or once you have the diagnosis, how to treat that diagnosis. So anything that will improve that delay from a communication standpoint, I absolutely agree. I was actually going to bring up a question. If that PFO if there was found to be a PFO on that bubble echo, would you have closed it?
Mm-hmm. And a 15-year-old? I don't think we have any evidence for that. For adults, yeah, I mean, there's some evidence that closing the PFO would help. In pediatric, I don't think we have any evidence, but if it's large enough and that was a source, could consider it. One other thing I was going to bring up from our process, so we get notified for code stroke, but we get notified through our app. So one idea is we could, discuss putting our mid-level, because we have great APPs that could kind of work as a gatekeeper if we're scrubbed in. For example, in this case, I think Ellery is here. She got the message and she came and she showed it to me, because otherwise I wouldn't have found out about this case. So I think that may not be a bad idea for us to get involved.
That's the best way that has worked for us. They end up being the glue between the whole team to have they're out and they're usually they're not scrubbing with us. So now the other thing was very important for us was to create the education on the pediatric side to be able to call stroke codes, so it's not there. So from all the nursing as well as emergency room, and everybody needs to know that the process exists, and then you can activate it. And that is not that intuitive for most people in the pediatric side, that that is even a workflow. So that actually probably is the hardest thing, is once you create the app, you have the NP team available to see, then you have to make sure that everybody's activating. And you're gonna get a lot of calls. We do get maybe more. So it's separated than the adult chat. There's a pediatric chat only. And then you, I think we have 2 pediatric hospitals, one in the south of Chicago, one in the north of Chicago. And it's a very, we started doing this only in one of the hospitals. And, but I think it's getting popularity to go to the other one. But the question for everybody though, is shouldn't we be monitoring more? We have a huge Down syndrome clinic there. We have also a lot of congenital heart disease patients. These are probably in a higher chance to develop strokes. Shouldn't we be focusing more on the population that also has a higher risk, to the folks that take care of those patients, to be aware of the workflow? That is definitely an area, I think it's an effort that is worth to spend time on the population that is more at risk. So
Thank you. Thank you, Sam, Harry, Dr. Valdivelo. It was phenomenal to have this discussion. Looking forward. Viscera is not a bad place, so we may see you in July there. Thank you again. With that, guys, I think we are concluding. I don't know, Dr. Nima, Dr. Sauvageau, Wendy. I don't see Dr. Neva around, but if somebody wants to make a final remarks or thank you, I think.
I just want to thank everyone, including Wendy, Abby, Jeff, everybody who's Tim, and you guys did a great job getting this going, and it's been organized very well. So thank you very much for your hard work.
Thank you, everybody. So where's the reception? Right outside. No, we're gonna have Abby directly, everybody. Enjoy.